Good morning, committee. I like to start on time. I know it's difficult on a Friday for some people to be here early. I'll just mention in advance, we have a couple of our members, some have some medical appointments today. Others will be with us on WebEx, and Senator Michael Fagg is in Ways and Means, and so as soon as that ends, he'll try to be here to join us probably closer to about lunch. I want to thank our team that's here with us today, and we're going to begin with Elizabeth.
Good morning. Elizabeth Cohn from Kansas Legislative Research. I just want to pull your attention to, we have some follow-up items from the November 22 Bethell meeting. And so you'll see 6 items in the testimony. The first 4 are from Kansas Legislative Research. So there's a fiscal year 2022 military and expedited occupational licensure report. There's a memo on funding for Centers for Independent Living. There's a 50-state survey about certified medication aids, and a May 2022 amendments to home health regulations memo. And then there's 2 items from agencies, the Kansas Department of Health and Environment, their responses to your questions, and then the Kansas Department for Aging and Disability Services responses to your questions.
Next on our agenda is the presentation on KanCare, and we'll begin with Lou Ann Kibbe, with Systems Advocacy Manager for Southeast Kansas Independent Living. Welcome to committee, Lou Ann.
Can you hear me?
And she's virtual. Thank you. Yes, we can hear you.
Okay, great. Thank you, Chair Gossage and committee members, for allowing me to present my testimony to you today. My name is Lou Ann Kibbe. I am the Systems Advocacy Manager for Skill Resource Center, which is Southeast Kansas Independent Living. We are a center for independent living that advocates for the rights of and provides services to thousands of people of all ages with all types of disabilities annually across the state. My testimony today is going to focus on home and community-based reimbursement rate parity and the direct support workforce shortage. First, I'd say Skill appreciates the increases in the reimbursement rates that were made last session to the HCBS reimbursement rates, which has allowed wages to be increased for DSWs through the waivers. Skill believes there should be parity among the rates so that wages paid to workers are equal and not influence their judgment of which, the judgment from the workers of which individuals they'll work for. The governor has proposed an increase in her budget this session to bring the rates for the physical disability and brain injury waivers up to match the rates of the frail elderly waiver, which we certainly do appreciate, but that would still be substantially lower than the rates under the IDD waiver. In order for recipients to hire workers, not only are they competing with each other on the waivers, but they're also competing with other employers. And I refer to a recruiting handout in my testimony from McDonald's and Hayes that is paying $13 an hour and some pretty desirable benefits, including $2,500 tuition assistance. If they're full-time, they can get health insurance, 401k program, paid time off, all kinds of things. So it makes it more difficult for people with disabilities to be able to hire the workers that we need. So Skill has a couple of requests. One would be that the committee recommend parity among the HCBS reimbursement rates of the various waivers, so workers are paid equally across the waivers. And then also that the committee recommend the state work with stakeholders to prioritize and develop a strategic workforce plan in response to the ongoing shortage of direct support workers that are so vital to many people with disabilities who live in the community, in their homes and communities. With that, I thank you very much for your time, and I'm happy to answer questions at any time.
Thank you so much. And since you are virtual, I'm going to ask if there are any questions on the committee at this time. Seeing none, thank you very much for your testimony. And now we're going to move to Audrey Schremer, Executive Director for Three Rivers. Audrey, welcome to committee.
There. I'm Audrey Schremer, and I am here on behalf of the Kansas Association of Centers for Independent Living. I am the executive director of the center, that serves Northeast Kansas, based in Wamego. So thank you for the opportunity to do testimony, and I will definitely hang around today if you have questions about services or self-funding. We at the association wanted to discuss with the committee some of our key points that we will be advocating for this legislative session. The first being adequate funding for Centers for Independent Living for the grant fund services that we provide. These services cover gaps that no other entities provide services for, and we, particularly at Three Rivers and our other centers, have seen a large increase in the last year for people seeking services, increase with persons with multiple disabilities. And to give you an idea, I think it surprises people when we talk about this. The average consumer that we serve at Three Rivers is a 50-year-old female who has acquired a disability later in life, may lose her job because of the disability, may lose her home because she's lost her job, and then we have to help her navigate the disability field. You know, hopefully we're able to find stable housing and new work skills to return to work, but not always. And that's just the average. Obviously, we serve people all ages, all types of disabilities. The other issues that we wanted to discuss is the community service coordination, targeted case management service for waivers. We feel like that is a gap still in the community that is desperately needed. Medicaid expansion, we particularly are hopeful that we can see Medicaid expansion come through that would allow our direct service workers working for consumers in their homes to access insurance that they can't get now, and to preserve and enhance those very policies that allow people to self-direct their services, as well as continued oversight by the committee for the MCOs, how they assess for services, and how they develop plans of care. So thank you, and I will remain for questions later.
We will save the questions for those in the room after everyone has testified. And now we will move to Askia Adams. Forgive me if I'm butchering your name. A private citizen, and she is virtual. He is virtual. If you're talking, we can't hear you. Is there any way we could assist him? We can hear you. And committee, while Mr. Adams is getting prepared, we are timing 3 minutes for each of the participants, but the participants so far have actually been under the 3 minutes.
Before you today, we all recognize there is a direct support worker crisis in the state. However, we are not addressing a very important piece of the puzzle. Yes, wages are important, but that is just a starting point. For individuals with disabilities to be able to keep valuable workers, we must take care of direct support workers. Presently, Direct support workers do not have any benefits, leaving them vulnerable if they have any medical problems. Why is this a concern of people with disabilities, you ask? Simple. If our staff is unable to take care of themselves, they will be unable to take care of us. Allow me to share a personal story. Last year, one of my staff needed to take some time off for medical reasons. On most jobs, she would have been able to take paid time off. However, since she was a direct support worker, she had to quit because she did not have any other options. There was no way for her to continue getting paid while she was out on leave. Did we really want to send a message that direct support workers have to choose between their job and their health? That is what we are doing currently. As I have stated before, if we really believe individuals with disabilities have the right to live in communities, then we must provide direct support workers what they need to live. No matter how much your staff loves working with us, if they cannot survive or have what they need, then our workers are going to find jobs that will supply them those things. No, this is not about people. It is about making sure we are supporting workers, so they in turn can support individuals with disabilities. Supporting direct support professionals means more than just increasing wages. It means actively ensuring that direct support professionals are supported with the benefits they rightly deserve. They deserve to be treated as professionals and to be given the benefits that other professionals already have. How many of you on this committee have benefits like insurance, paid vacation, paid sick leave, and retirement? Stop and ask yourselves, would you be a legislator if you were constantly concerned about if your job was going to provide you the supports like these you need? We all can answer that question. The answer would be no. Why are we expecting those who take care of our fellow Kansans with disabilities to save insurances? I would like to suggest a few ways we can improve the lives of direct support professionals. We can boil it down into four main areas. Number one, providing a living wage. Number two, providing health insurance. Number three, provide vacation. And number four, pay overtime. These things may seem trivial to you, but let me remind this committee that unless people have these things, we will continue to have a direct support worker crisis in Kansas. Over the years, I have had workers tell me they loved working with me. However, they needed a job that would give them benefits. Many of my workers had families, so I understood why it was so important for them to have benefits. One year, one of my direct support workers took 2 weeks off to go on a family trip. She did not get paid for the time, but if she had been on another job, she would have been able to take paid vacation. Can someone explain why this worker did not deserve paid vacation? When we provide direct support professionals these benefits, they feel valued and are more likely to stay with their clients. As an individual who has a disability, it is important that I can keep good workers. For me to be able to live independently, having dedicated workers is imperative. It is extremely difficult to find dedicated staff when people are concerned about benefits. As I have said before, it makes more sense to support me in the community than in an institution. Part of serving me and other Kansans with disabilities in the community means valuing the direct support staff who work with us. Again, let me emphasize, we are talking about just ensuring direct support professionals are given the support they need for them to thrive while they help people with disabilities flourish in our communities.
Mr. Adams, thank you so much for your testimony. And committee, do we have any questions? Seeing none, we will move on to our next conferee, which is Craig Knudsen, who is a policy analyst with the Kansas Council on Developmental Disabilities. Welcome to committee.
Thank you. Madam Chair and members of the committee, thank you for the opportunity to provide testimony to you today on behalf of the Kansas Council on Developmental Disabilities. My name is Craig Knudsen, Policy Analyst for the Council. You have a copy of my written testimony, so I'll limit my comments to some of the main ideas in it. First of all, the Council applauds the leadership of Representative Carpenter and members of the IDD Waiver Modernization Special Committee for convening and leading a dialogue and action-oriented plan to modernize our IDD waiver in order to better meet Kansans with IDD and their families' needs. This leadership has been crucial as families and caregivers in Kansas are in crisis. As of January 17th, 2023, the waiting list for IDD's waiver services was 4,813 Kansans. This represents a 19.2% increase in the size of the waiting list over the last 2 years alone. Today, the council would like to focus on two significant needs to help shore up capacity, to help address the waiting list issues, and lay the groundwork for a successful community supports waiver. Number one, targeted case management. Targeted case management is one service that individuals and families on the waiting list can access and provides a crucial and necessary level of support. Unfortunately, targeted case management is not a waiver service and did not benefit from the 25% IDD waiver reimbursement rate increase that was approved by the Kansas Legislature this past session. In fact, it has been over 10 years since the TCM services in Kansas has seen a reimbursement rate increase. As a result, the state has begun to lose vital TCM provider capacity and talent over the last several months. A quick glance at the chart on page 2 of my testimony shows how Kansas lags behind peer states in the level of TCM reimbursement. We must rebuild and bolster targeted case management workforce capacity in the state that attracts talent, retains talent, and provides a career path for individuals who want to invest in this incredible profession serving our community. Targeted case management is crucial to help families in Kansas and those with disabilities connect with resources in the community. This is the foundation of a community supports waiver. Secondly, we must expand our workforce infrastructure in Kansas to increase employment outcomes for people with disabilities. Kansas has one of the lowest utilization rates of supported employment services for people with disabilities in the country. To illustrate our extremely low utilization rate of supported employment services, in 2019, only 271 Kansans actually accessed this service. Unfortunately, Kansas also lacks the necessary infrastructure and provider capacity to offer supported employment services, due in large part to the reimbursement rate of $13 an hour, which is one of the lowest in the nation. In closing, the council feels strongly that now is the time to not only modernize the IDD waiver system in the wait list and address our dire unemployment rates for individuals with the IDD in Kansas, we must also address the workforce, talent pipeline, and career pathway for individuals who dedicate their lives to serving, supporting, and caring for our population. This starts with increasing and enhancing the rates that will attract, retain, and create a better career path for targeted case managers, providers, and other individuals and entities supporting our community. Thank you again for your ongoing leadership addressing these needs in Kansans, and I will be open for questions at the appropriate time.
Thank you very much, and thank you for staying within our time frame.
Thank you.
And next we would have Liz Long, Policy Analyst for Kansas Council on Developmental Disabilities. Welcome to committee.
Thank you all for letting me speak with you today. I'm coming to you with a different topic than Craig brought to you. I'd like to talk to you about the committee's bringing the committee's awareness to some gaps in the state agencies identifying and sharing information on known perpetrators of abuse, neglect, and exploitation of persons with disabilities in the following two areas. First, it's difficult for providers and people hiring their own staff to identify people who are already on the confirmed perpetrator list. There's 7 different organizations that keep track of these situations, from DCF, Adult Protective Services, Child Protective Services, KDADS monitors the adult care facilities and the CNA, CMA licensing. KDHE has home health licensing. There's the Board of Nursing, Board of Healing Arts, Behavioral Board, and criminal background checks with KBI. There are fees for verifying with some of these registries and several sites to go to, and few have results available immediately. These are just the external hurdles to hiring direct care workers. Easing the burden for individuals with disabilities, their families, and providers by requiring a universal registry where providers and self-directing families can check direct care workers' histories against known abuse, neglect, and exploitation issues would improve the quality of services and reduce further harm to potential victims across all settings. The second area to address is the gap of workers who are in facilities but are not licensed who commit abuse, neglect, and exploitation. These staff will not get added to any registry. even if during a KDADS facility licensing review, an individual is clearly responsible. This individual can then move to another adult care facility or HCBS provider with no record of the harm they caused. So today's request: recommend a universal registry that each agency posts their information to publicly regarding staff who are not eligible to rehire due to abuse, neglect, exploitation, criminal actions, malpractice, which is state-funded in place of the current fee-funded model. The second request is for a legislative post-audit to assess the multiple processes that allow perpetrators to continue to work in positions with potentially vulnerable people. The rest of my comments are in my written testimony, so I appreciate that, and I'll be here for questions if you have any. Thanks.
Thank you. And next we have Colin, I hope I say this right, Olenek, Legislative Liaison with Self-Advocate Coalition of Kansas.
Okay. Hello, my name is Colin Olenek. I am the legislative liaison for the Self-Advocate Coalition of Kansas. I would like to discuss the new community support waiver that was recommended by the Intellectual and Developmental Disability Modernization Committee. As you work on passage of this waiver, there are several things that I would ask you to consider. First, assuring people with intellectual and developmental disabilities will have budget authority across all services provided by this waiver. Will be important. This will assure people with intellectual and developmental disabilities and their families have full control of the services they receive. Second, the importance of this waiver cannot be expressed enough. A community supports waiver will allow individuals who have been on the waiting list for years, up to 10 years, who have waiting for 10 years, to have access to a level of service that would assist them in continuing to live in the community. The other issue I would like to discuss is the new assessment tool used for the IDD population. The current tool is deficit-based, meaning that it looks at what we cannot do. I strongly urge the state and this committee to use a strengths-based assessment that focuses on what we can do and the support we need to accomplish that, and where our self-esteem matters. Thank you.
Thank you, Mr. Olenek. Next, we have Matt Fletcher, Executive Director of InterHab.
Thank you. Thank you, Madam Chair and members of the committee. I am Matt Fletcher, the Executive Director of InterHab, and we greatly appreciate this committee's continued leadership on behalf of issues that impact the lives of Kansans with intellectual and developmental disabilities. I wanted to bring up a couple of different topics to the committee today. The first is targeted case management. You heard a little bit about that earlier in previous testimony. As was mentioned before, targeted case management management did not receive a funding increase when the legislature increased the HCBS IDD waiver in the past few sessions. In fact, IDD TCM has not been increased in well over a decade. The last time the rate was touched at all was 2008, and at that time there were concerns expressed about the rate that was put in place, whether it would be adequate for case management services to be performed. So at this time, we're very, very pleased for the governor's leadership in including 1.5 million SGF in her budget recommendations to increase the rate. However, our members have studied this service, and in order to bring sustainability to TCM, they have concluded that the rate needs to be increased from its current $43.32 per hour to at least $75 per hour. That would require adding 4.5 million SGF into the budget, and so we respectfully request the legislature's support for addition of 4.5 million SGF for IDD TCM in this current legislative session. In addition to that, I just want to call attention to two service alternatives that we would encourage the legislature's support of. Providers are increasingly looking to service alternatives not only to meet the needs of the IDD population and their choices, but also to address the chronic workforce shortage issues that face this system. The first such service alternative is something known as shared living. It's a program that matches host home families to persons with IDD. Only a few providers in Kansas can offer this service currently due to a moratorium that's been placed by KDADS on that service delivery. I'm happy to report that just based on recent conversations, KDADS is now moving forward on the processes needed to lift that moratorium. So we're excited to see that progress and hoping to see that service be available to providers in the future to be able to offer. The second such service alternative is remote technology, remote sensing technology, which allows individuals through technology to be able to live independent in the community. We'd encourage the legislature to look into those topics and to support those in the future. And with that, I'll stand for questions at the appropriate time. Thank you.
Thank you. And committee, next we have Nick Wood, who's the Associate Director for InterHab virtually, and I'm assuming this is a bit of a different topic for this group.
Yes, ma'am. Thank you, Chair Gossage and members of the committee. Can you hear me?
Yes, we can.
Okay, thank you. I'm like others, I'm going to just quickly comment on some of the discussions around the IDD Special Committee and the Community Support Waiver as a means to eliminate our waiting list for IDD services. So we do think that that's the way that most states have taken steps toward eliminating waiting lists. We think that it's a good approach. Grateful to the IDD Special Committee for coming up with the list of services. We think that that's terrific. There were a couple questions during presentations from KDADS, I believe also KDHE, that legislators had that we just wanted to try to speak to very quickly. One is around timeline, meaning kind of what kind of progress can we make maybe in the near future. And I just want to say, the application to CMS does not have to be complete. We would want to have a good idea of what we want to have in the application, obviously, because that sort of starts a clock between the state and CMS, where they'll be reviewing it against kind of what the federal guidelines are and even our state laws. Its second point is it's advantageous for a state to submit a 1915C waiver concurrently with their managed care waiver. So I don't know that you always have to, but it's pretty clear from CMS guidance that if you're going to operate them concurrently, it's good to submit the applications concurrently. We also, I guess, as far as next steps in the timeline, what we would be looking for is a kind of a published timeline around public engagement and public comment. That's just some points on what a timeline or what progress would look like to us. There are other questions about the cap. The IDD special committee, or the special committee recommended $20,000 cap. And you heard from advocates, and I mentioned this too, I think in my testimony, that caps have been controversial in states when they are essentially a hidden waiting list. When you're just choosing not to meet people's needs, that has resulted on these programs being a little less popular, I would say. But a cap, I guess, in the way it's been discussed so far, probably does help the legislature predict costs, estimate costs into the future, and utilization. And so there are different types of caps that you can use. You can use caps on the services themselves. And then essentially everyone has a budget for that service that they can work with. One thing that you might want to consider is that those caps be flexible. If you have someone who has a high cost plan, and it might be, the average cost on the comprehensive waiver is about $45,000. The average cost on a community support waiver is less than half of that. If you have someone with a real high cost plan and they have high cost needs, but they would choose a community support waiver and it would be financially advantageous, we're recommending that you should consider allowing people to still access that waiver if that's what they choose. It could be financially advantageous to the state on a case-by-case basis, or even for groups of people. And I think we heard that from other states who came and testified to the special committee in October. They were talking about how they had sort of experimented with their waivers over the years to get rid of their waiting list, and that they found that financially it made sense to do things like that. So,
Nick,
just a couple
thank you
points
so
learned
much
today.
for your testimony. I'm sorry we've gone over the 3 minutes, but will you be available for us to come back to you for questions?
Absolutely. Thank you, Madam Chair.
Thank you. In committee next, we will go to April Holman, and she's the Executive Director for Alliance for Healthy Kansas. Welcome to committee.
Thank you so much, Madam Chair and members of the committee. My name is April Holman. I'm with the Alliance for a Healthy Kansas. We are a coalition that is broad-based, and we have about 128 organizations that are members of the coalition at this point in time. They range from large statewide organizations to small local neighborhood organizations that have all come together to advocate for KanCare expansion. And our members have many, many different reasons why this is part of the solution to problems that they're facing, but they all come together on that one solution or part of a solution, which is KanCare expansion. We usually don't testify before this committee, but because the issue has come up several times in previous meetings, I just wanted to take a moment to share our perspective on why KanCare expansion is needed. And really, when we talk about that, we have several things that we look at overall. It would reduce healthcare costs for everyone. So when there's a high level of uncompensated care that providers experience, those costs are shared with everyone. And so it would help to at least stop the increases due to uncompensated care. It would protect Kansans from medical debt. We know that's a leading cause for bankruptcies. And if people don't incur that medical debt in the first place, they won't be in a position to need that bankruptcy. It will fix eligibility limits, which are currently very low. So in 2023, the income limit to qualify for KanCare is less than $9,447 a year for a family of 3, so like a mom or dad and 2 children. They would already be making too much money if they were earning $9,447. It would help to preserve and strengthen rural health care. It would help to address the general workforce shortage in Kansas. It would make Kansas more economically competitive. There were 4 different polls measuring public support for KanCare expansion in 2022 alone. These ranged from just below 72% supporting expansion to all the way up to 78%. So I am just here today to ask for your help in trying to get a hearing for KanCare expansion this year. We haven't had a public hearing in several years, and I think the public really wants to have their day at the Kansas State House. Thank you so much for allowing me this time, and I'm happy to answer questions when appropriate.
Thank you. Committee, next we have Tanya Dorf-Brunner. Good. And she's the Executive Director for Oral Health Kansas. Welcome to committee.
Thank you, Madam Chair, and thank you. You got my name exactly right. That's not always easy, so congratulations. Again, my name is Tanya Dorf-Brunner. I'm the Executive Director of Oral Health Kansas, and we're the state's oral health advocacy organization for consumers. I want to just run through a handful of things quickly. First of all, I just want to start by once again thanking you for extending last year the Medicaid dental benefits to adults. This was a really major step forward in our state. The legislature championed that. As a result, now adults have access to fillings, crowns, and periodontal care or gum disease care. A huge step forward. We've been working, that went into effect July 1st, so it's actually very new. There's not data really available yet, but we've been working really hard on consumer and provider education resources. We've got an adult dental benefit website, and I've got a link to it in my testimony, so you can check that out. We're trying to continually come up with new resources to help people understand what's available, help providers understand how to do the services. So if you see anything that you think, gosh, why didn't they answer this question, let me know. I'd love to add more resources and always interested in what else is out there. Just real as a quick aside, we got a call maybe a couple weeks ago from a new dentist in the state who said he'd from another state that had dental coverage for adults. He'd heard it was in Kansas and was just interested in how to become a Medicaid provider. So I think the word is out there. I think we can do a lot more, but it's out there. I would say in the process of getting the benefit package developed, we visited with a lot of stakeholders last year. It was very clear that dentures were a really unmet need and were not going to be covered in that package. So that's what we're going to be working on this year. If you're on the budget committees next week, you're going to be hearing from us about that. One of the most underserved populations is people who live in long-term care settings. There are some denture coverage available in the frail elderly waiver, but really not for people living in facilities. So and for other adults on Medicaid. So really the point is people need consistency in what's available. They need to know that it's there, but really more importantly, probably providers need consistency. They've got a lot of things to juggle. So to know that they don't have to figure out which managed care organization covers what, which population is this patient in. If it's just covered, it's going to provide a lot more consistency and maybe make providers a little more willing to be a Medicaid provider. We've got about 24 organizations who've signed on to support that, and again, you'll hear more about that next week. I'm also just happy to quickly announce that we've been doing a lot of stakeholder work around people with disabilities and sedation dental care access. It's been going really well. I'm pleased to say all of the managed care organizations are involved. We've been really happy with their involvement. And I don't think this is in my testimony. I just want you to know. One great new tool that's going to come out very soon is a dental passport, and this is endorsed by all the MCOs. It's at KDHE right now. It's going up the ladder and will hopefully be approved very soon, and then it will be widely available. The goal of this passport is a way to make consumers with a wide range of disabilities have a chance to communicate their needs and kind of their holistic needs to a dental office so that they don't have to keep repeating their story to each new person who comes in to talk to them. It's also really going to make it easier for providers to understand the complete details of all their patients. So excited that that's going to be out soon. Looking forward to the momentum continuing and just appreciate your support. Thank you.
Tanya, I've been told I speak quickly. You beat me by a mile.
Thank you. I'm looking forward to my retirement career as an auctioneer.
Well done. Committee, let's welcome Scott Lopez. And Scott, occupational therapist, registered licensed assistive technology professional, certified rehabilitation technology. Thank you so much for being here.
Good morning, Madam Chair and the members of the committee. Thank you for the opportunity to provide my testimony today. Alliance Rehab and Medical Equipment is a complex rehab technology provider, otherwise known as CRT. CRT is a specialized subsection of DME, which includes medically necessary and individually configured wheelchairs, seating and positioning systems, and other adaptive equipment such as standing frames and gait trainers. The procurement of this equipment requires evaluation, configuration, fitting, along with ongoing services, which are modifications, future adjustments for growth, repositioning, repairs, typically done in the client's home. These products are designed to meet the unique and individual needs of individuals with disabilities resulting from congenital disorders, neuromuscular disease, myopathies, injuries, or trauma. The primary issue that the primary issue is that the current reimbursement is unsustainable for providers to continue to provide CRT services for individuals enrolled in the Kansas Medicaid system. The current Medicaid reimbursement is set at 65% of Medicare, rendering providers unable to cover operating expenses or break even. To further complicate the matter, we've seen steep increases in operating expenses, including dramatic increases in acquisition costs for the products we provide. Our freight charges are up. We're also seeing additional fuel surcharges. The fuel we put on our vehicles are up. Delivery vehicles costs are up, and labor costs are up. We've seen manufacturing costs on the rise due to raw materials going up in cost, and these are raw materials we use in the components that are used to provide devices to your beneficiaries in the Medicaid program. Unfortunately, the payment amounts have not kept up with the rate of inflation, and we haven't seen a payment increase in way over 10 years. As a provider in Lenexa, Kansas, we serve both clients in Kansas and Missouri. There's a significant difference in the reimbursement rate between the two states. We recently pulled some orders and compared them between Kansas and Missouri Medicaid, and shockingly, there's a 315% difference in the rates, with Missouri providing acceptable and fair reimbursement. The current Kansas Medicaid methodology does not allow for providers to receive secondary reimbursement through the Kansas Medicaid program. Medicaid, the rate's too low to trigger the secondary payment, and providers are unable to collect this. So not only does the secondary payments need to be addressed, but the entire payment methodology needs to be updated to ensure we can continue to afford to provide these services to these individuals with disabilities. As the only independently owned CRT company in Kansas, we can't continue to provide these services at the current rate. I want you to keep in mind there are three companies in the state that provide these services, 2 in Wichita and our company Lenexa. Our ask for 2023 is to increase the reimbursement to appropriate and fair rate. I would be happy to collaborate with the Medicaid team and discuss reimbursement methodologies and explore other alternatives and kind of come up with a reimbursement schedule that is more like Missouri or Colorado, where we can provide the services for these individuals. Thank you, and if you have any questions, I'll take those at the appropriate time.
Thank you very much for your testimony. And committee, next we will welcome Carrie Grostadier, and she's with Infant Toddler Services of Johnson County.
Did
Welcome.
you practice my name? No one ever says it right.
I'm from Eudora, and we have a million Grostadiers.
Absolutely.
Thank you for being here. A wonderful family, by the way.
Thank you. Thank you. Good morning, Madam Chairman and members of the committee. I appreciate the opportunity to testify today. My name is Carrie Grostadier, and I'm an occupational therapist working in early intervention in Kansas. You have my written testimony in front of you about my concerns, and I focused on the delay in access to equipment, but I wanted to tell you a little bit about the families that I work with each day. I work with children birth to 3 in their home with special needs. I see each of my clients on a regular basis. I support them and their family with their child's development and celebrate their successes each week with them. As part of my job, I must begin thinking about what their mobility needs might be at 3 years old when they transition from our program to the school district. With the current system, I need to start thinking about that at approximately 18 months of age, considering a 6-month wait at Children's Mercy Hospital for evaluation and a 6 to 9 month wait for delivery of equipment. Imagine the development that happens between the ages of 18 and 36 months. It's quite a bit that happens. I want to tell you specifically about one family I work with. The child I work with is 18 months old and entered the world at 25 months gestation. When he came home 2 days before his first birthday, he had difficulty holding his head up, wasn't able to sit on his own, and wasn't communicating. Currently, he's almost sitting up independently and rolling to get to his toys. With the current seating policy, I need to begin to make referrals to the seating clinic for mobility device now, so that when he moves to the school district, he will be able to move within his school environment. Let's go back to how much he's done in 6 months. He went from not sitting, not communicating, to now he is almost sitting and communicating with his family, telling him when he's hungry. Just imagine what further development's going to happen in the next 6 months and in the next 12 and next 18. The current system creates a delay in access to equipment and can provide questionable outcomes due to the potential wait for that evaluation and the delivery of equipment. As an OT, I have the minimum competency to make recommendations for mobility and seating devices for children, as do all OTs and PTs that work with children in the state. I propose that the seating clinic requirements be eliminated and allow the therapist and the providers that know the child best and work with them in their home environment play a role in providing that equipment and meeting their outcomes. I appreciate the opportunity to express my concerns in this area, and I look forward to working with the committee and Kansas Medicaid to resolve this delay in access to equipment. Thank you.
Carrie, thank you for being here. Committee, next we'll go to Madison Elliott, the Public Policy and Advocacy Director for National Alliance on Mental Illness of Kansas.
Hi, thank you for the opportunity to present testimony today. I'm our Public Policy and Advocacy Director for NAMI Kansas, and so we're a state organization under NAMI's national organization, the National Alliance on Mental Illness. And so what we strive to do a lot is provide programs of education, support, and advocacy for people living with mental illness, their families, and friends. And we believe that all people with mental health conditions deserve accessible, affordable, and comprehensive health care. So based on our beliefs, mission, and policy priorities, NAMI Kansas would like to make the following recommendations. So one being KanCare expansion. We request that the possibility of KanCare expansion is considered in an evidence-based manner. Studies and evidence of the benefits of Medicaid expansion are abundant. Notably, Kansas Health Institute recently published their report titled Medicaid Expansion's Impact on the Kansas Behavioral Health System and Users of Behavioral Health Services. The report further supports that Medicaid expansion is associated with increased revenue in the behavioral health system, increase in percentage of facilities that accept Medicaid, increase in visits to mental health providers, decrease in arrests, decrease in rearrest rates, savings for county jails, decreased crime rates, decrease in childhood neglect, and decrease in foster care admissions associated with neglect. Some other areas that we support is, I apologize, we do support, as some others have stated many times before, it's rate parity across all HCBS waivers and other incentives to increase workforce and utilization. Person-centered care for these services are key to people receiving the care that they deserve. Additionally, we recognize the workforce shortage in behavioral health and healthcare in general. So we recommend that the committee continue to support and explore incentives and methods to address the shortage of workers in these areas. Thank you.
Thank you for your testimony. And next we have Leslie Anderson, with the Executive Director of Kansas Association of Area Agencies on Aging and Disability. Leslie, welcome to committee.
Thank you, Madam Chair. I'm going to use the acronym K4AD to introduce myself. I am here on behalf of the 11 area agencies on aging that serve the state of Kansas. I want to highlight a few details of my written testimony about how the AAAs relate to Medicaid and coordinated care in Kansas. The Older Americans Act created the AAAs at the local level in 1973, and their responsibility was to advocate and coordinate for services for older adults and caregivers. Some of you work very closely with your local AAA. As the one-stop shop for aging services, AAAs gradually evolved into the single point of entry for the BIFE, PD waivers, and PACE program. to avoid duplication of services and to help the state and Kansans conserve resources. You'll hear a lot about targeted case management. The administrative case management program is not targeted case management, so I want to make sure that there's that clear delineation. So that is specifically to help individuals who are already functionally eligible for the waivers that I mentioned and PACE to help with that financial component. It was in December, they helped 690 individuals with that piece. The Aging and Disability Service Resource Center is another service, and it provides the options counseling and the assessments, and there were 11,953 assessments done last year with a corrected number of 22,905 contacts through the statewide call center. In previous meetings, we talked about the backlog of the CARE Level 1 assessments from the hospitals and the special admissions, and Jayhawk Area Agency on Aging is working very closely with Behavioral Health Commission, and they are aggressively entering those assessments to clear up the backlog. As social determinants are person-centered and resources vary by a person's circumstances, the association strongly advocates for the state to include the AAAs and other experts when developing a resilient infrastructure, creating and amending policies, designing a reliable management information system and policies, and when planning and developing measurable outcomes to manage the complexities of managed care, coordinated care, Money Follows the Person program, the Senior Care Task Force recommendations, and when other decisions are impacting older Kansans. Ending on a positive note, the Senior Care Act served a total of 3,666 individuals in last fiscal year. 1,951 were consistently served each month at a cost avoidance to the state of $7.15 million. With that, I'll close and stand for questions at the appropriate time. Thank you.
Thank you very much. And I do want to mention for those in the room and for those on WebEx, we are paperless in this committee. So I had somebody in the past say, boy, those people just are on their computers the whole time. So we are looking at their testimony. So please be aware of that and taking notes. We didn't hear that. We didn't hear that, Representative. So we will now ignore the peanut gallery. We will now welcome Linda Mowbray, and she's the president and CEO of the Kansas Healthcare Association and Kansas Center for Assisted Living. Appreciate your testimony. And did I butcher it? How's the last name pronounced?
Close. Mowbray.
Mowbray. Great.
Thank you, Madam Chairman.
And thank you for your testimony to my committee earlier, and we look forward to this testimony to the Bob Bethell Committee. Welcome.
Thank you. I am Linda Mowbray, President CEO of Kansas Healthcare Association, Kansas Center for Assisted Living. We are a statewide, not-for-profit trade association that represents nursing homes, assisted livings, residential health care, Home Plus, long-term care units of hospitals, quite a gamut of aging services. Our members are for-profit and not-for-profit. We have about 15% not-for-profit in our membership currently. And we represent homes that are licensed for 4 or 5 individuals up to nearly 200 individuals. So we have really the gamut of different types of membership. I would ask you, if you would, to move forward in my presentation notes to page 3. And this is a map that shows some very, very drastic information about Kansas. Since the beginning of 2020, we have lost 19 skilled nursing homes. There's one more scheduled to close in March, and it's on your map in red. The sheet following that gives you a list and description of what those homes are, where they were at, and shows you what parts of the county that are being affected. Over 1,000 beds. KanCare is an entitlement program for our elderly. aren't they entitled to stay in their own community when they can? We have to fund the KanCare program, the Medicaid program, in order to keep these nursing centers open. Not everyone's needs need to be met in a nursing home. There's assisted living, there's home plus, there's home health care, variety of different services. And we very much support the continuum of care that's available in Kansas. But assisted livings are closing too. Home plus are closing too. The other big elephant in the room is staffing. I think you've heard others address that, and we'll hear more about that. We stand ready to offer some solutions with that, whether it's internships or with different incentive programs or apprenticeships. We really feel like there are some solutions out there, but we need your help to find them. And I will stand for questions at the appropriate time. You all have been such good partners with us in the past. Please, let's keep it going forward.
Thank you, Linda. And now let's welcome Rachel Monger, who is the president and CEO of Leading Age Kansas. Welcome to committee.
Thank you very much, Madam Chair. I am Rachel Monger with Leading Age Kansas. We're the nonprofit and faith-based senior care association in the state. And I appreciate Linda, my colleague Linda, tag teaming with me these last couple weeks with our presentations and including today. I just want to highlight our Leading Age Kansas situation report. We have given that to you guys through this committee a couple times now, starting last fall. So the one that's attached to our written testimony today is updated for January 2023. The numbers have gotten worse, unfortunately. Some of those numbers are adult care homes that have closed entirely or permanently closed down portions of their building grew to 47 in 2022. And then after some closure announcements from our own membership in Leading Age Kansas at the end of the year, we already know that number is going to 49 in 2023. And we're only in January. Our labor costs are up nearly 25%. Our workforce has shrunk by 10% or more, depending on the setting. Our reliance on contract labor, also known as staffing agencies, has grown by 90% at a cost increase of 270%. And that's the government data that we've given you in that situation report, along with a map of Kansas that shows you senior care deserts and some of those aging population stats, if that can be handy for you. And then our own membership survey that Leading Age Kansas, Kansas Healthcare Association, and Kansas Adult Care Executives did at the end of this last year on admissions data. Our surveys indicate that as recently as November, thousands of older people are being turned away every month who are looking for nursing home care because we just don't have the staff to care for them. Hospitals are struggling with their inability to discharge older patients, and that is for good reason. We aren't taking them. We're asking for the legislature's assistance in 3 areas: making sure our Medicaid rates stay fully funded and actual cost of care is fairly reimbursed, that staffing agency reform that helps us ban the use of non-compete clauses and contract buyouts for agency nurses and nurse aides, and support for new programs to help improve healthcare and human services workforce recruitment and training, as well as programs that can encourage more people to enter and stay in the workforce in general. So thank you very much, Madam Chair, and I will be around for questions.
Thank you very much,
Thank you.
Rachel. Next, we'd like to welcome Haley Ordoin, Legislative Committee Chair for Kansas Adult Care Executives. Welcome.
You must have had to phone a friend for that last name.
Came from at the end of the aisle here.
Thank you, Madam Chair.
You.
And thank you, members of the committee, for being here to testify in front of you once again. I'm not going to repeat what our colleagues have just previously stated, but I will stress the fact that when all 3 of us are united in our agreement of what really needs to take place, hopefully that sends a really strong message for you. I am here on behalf of the Kansas Adult Care Executives. For any of you that don't know the association, we are the administrators and operators in these buildings. So we are the boots on the ground, experiencing these issues firsthand and directly, implementing plans to try and navigate through them and just doing our best to stay afloat on a daily basis. In regards to the funding Medicaid reimbursement rates, we would just ask, the 5% in the budget doesn't even really begin to touch. You guys previously last session gave a full rebase with cost for the adjustment and inflation. We would ask for that once again. We have members that are seeing the cost of a soap dispenser, soap in a building, went from $6 to $46. It's not something we can sustain. Supplemental staff oversight, one of our members, their previous budget was $10,000 annually spent on staffing agency. The last year, they hit $1 million. Again, not sustainable. Workforce development, I think you guys continue to hear a lot. I know to never come to this committee without solutions, so you'll see on page 2, the solutions that we see to the problems, fully funding our reimbursement with a full rebase. That's a solution for now. Something to look at further long-term is the process by which Medicaid reimbursement rate is determined. I think that's a more longer-term goal. Montana has a model for that. We report our finances annually, so we have that anecdotal data by which we could redetermine the process. Accountability being placed more on supplemental staffing agencies. I understand that House Bill 2265 has made its way. We would be in support of that. And then focusing attentions and efforts on pursuing the recommendations of the Senior Care Task Force. That was a group with several of you members in it that I understand is being presented to the Senate Health next Wednesday. But there are suggestions under there that work alongside of the workforce development, recruitment, and retention that I would be happy to answer any questions on at the appropriate time. And I did attach some of that information in testimony. So thank you very much.
Thank you very much. And finally, we have Shannon. And Shannon, I'm debating between Flatch and Flack.
You're close. It's Flock.
Flock, see? I tried. Vice President of Finance and Reimbursement for the Kansas Hospital Association. Thank you for being here.
Thank you. Thank you for allowing me to come speak to you guys on behalf of our Kansas hospitals. We at KDHE strive to be proactive with the Medicaid MCOs. And by doing that, we do have quarterly meetings with them to try to address issues. However, there's one issue that we just really can never come to a resolution on, and that is really prior authorizations. We talk about it a lot about this issue, but I wanted to make sure you understand the Medicaid MCOs are no exception to this. We have a lot of issues around prior authorizations with them. We started to protect, prior authorizations were started to protect from having unneeded tests and treatments from done and to help with the care of the cost of health care. However, it's really transition. It is not helping with the cost of health care. It is just transitioning the cost of health care onto the taxpayers. So I want to give you a little bit of an example of that. Have a 26-year-old patient admitted, this is a Medicaid example, admitted for a motor vehicle accident, double compact fractures to both femurs, massive hemothorax, hematoma, a liver laceration. On day 1, our hospital is already figuring out and working with our care coordinators about how to move them to the next level of care. After a few days in the ICU, it was determined that LTAC will definitely be needed in the next level of care. However, so we started that process of finding an LTAC that would accept the patient. Day 14, we found an LTAC to accept the patient. We submitted the prior authorization paperwork. Day 22, it was determined that the patient was no longer medical necessary to be in our hospital. Still haven't heard from the Medicaid MCO on whether they would be accepted into an LTAC. So what does that do? That is now we may have to make a decision to discharge the patient in an unsafe condition or keep the patient in our hospital. We keep the patient in the hospital. That we know that is the right thing to do. 6 days go unpaid in our hospital, but we're keeping the patient. We finally hear back from the Medicaid MCO it was denied, saying, no, sorry, we'll just let them go to a SNF, LTAC. After 50-some phone calls, we finally find a SNF to accept them. This is on day 47. So 47 days in our hospital unpaid, taking up one of our beds before the patient can be transferred to the SNF. So I can give you, again, my own example of how prior authorizations are hurting our hospitals. 4 years ago, I was trying to recruit a physician to Kingman, Kansas, where I was. I lost 2 out-of-state hospital physicians that were willing to come to my community because Kansas did not have prior authorization legislation. We cannot find workers, we cannot find physicians to come to Kansas because we need to show them the support that we're going to give them back the control to take care of their patients. So thank you, and I'm willing to answer questions.
Thank you, Shannon. Committee, I would address your attention to the written-only testimony. We have 2 of those, Rick Elskamp, private citizen, and Tony Johnson, the CEO of Recover Care Midwest. If you look at the clock, you can see we're almost right at 10:10, which puts us on schedule but gives us very little time for questions. So, committee, do we have just a couple of quick questions for the early conferees? Yes, Representative Landwehr.
This will be for Ms. Flack. Can you give us the name of that MCO that you're having a problem with? Which company?
That would be all 3 of them. Yes. All 3 of them have denied.
I'm sorry, just a moment. We don't need the clapping from the audience, please. Go ahead.
Yes. No, all 3 of them we fight on prior authorization issues on. That specific example, I'd have to go back and check which Medicaid MCO it was. That was actually an example from Advent Health. I'm happy to follow up with you on what Medicaid MCO that specific example was for.
Well, and the reason I ask that question is because staff tracks these things. So when you come to us, we want specifically who it was, because then when those MCOs appear before us, we ask them to respond to those issues. My others would be you mentioned the MCOs. I assume that private insurance has pre-authorization. That probably creates you heartburn in your world, as well as Medicare.
Absolutely. Yes, it is definitely not just a Medicaid MCO issue. It is across the board issue with health insurance companies.
Well, I can tell you that when I talk to a lot of these different companies, because I've had these discussions with the Hospital Association, we're also hearing about a lot of the errors in coding and different things that come from the hospital. So I want us to think about this being a 2 sides and a 2-way street on things, so that we're not crucifying just one industry on errors, because healthcare is very complicated.
Absolutely.
All the coding, all the stuff that has to be put in. So we want to make sure that we're good partners. And I think most of the time when we talk through with these individuals, we're able to resolve them. So I think we can help you.
Yeah, absolutely. And I totally agree with you, Representative. I am all for making sure our hospitals work on their issues too. We're not perfect, for sure.
Well, no one is.
Yes.
That's why I have to go to church every Sunday.
Yeah.
So.
So, thank you.
All right, if I may, Madam Chair. Linda Mowbray? And I'm not going to just pick on Linda, because I'll pick on Rachel Monger as well, so you can just kind of listen to this. Is make sure that you're getting to us the ideas and the recommendations that you see on whether, entry-level people, changes that can be made, because we are trying to work on this. We're trying to work with the boards out there that do licensing and credentialing. You guys are out there in the field, bring them to us. There is no such thing as a crazy idea on this. We've had conversations with our regents as well. So don't be quiet. Dave would love to hear from you. All right?
Yes, ma'am.
So we want your ideas.
You will hear from us in the, probably as soon as next week, with some of the ideas that we are collaborating on. And we've got to get this engine started, and we have some ideas to do it.
Okay, well, and just so you all know, as legislators, we're working on it. We've got multiple committees that are, talking and working, and some of our agencies are being very helpful partners too, but we need our people that are providers out there as well. Thank you.
Thank you.
Committee, other questions? Yes. Representative Ballard.
Thank you, Madam Chair. Well, I'm going to start with two. Leading edge would be first. And then Haley Adorn is next. But with leading edge, one of the things that struck me is when you talked about the 47 long-term care facilities that are closing and reduced services, but often the first to go are the dementia care units. And that seems to be everywhere because, I mean, Lawrence has experienced that as well. Where do these people go when they close these units? Because I'm sure there was an understanding when they were admitted and people had a little peace of mind, they had a place to go. But when you close it, is it the responsibility of the receiving people to find another place or at least recommend where they can go?
So in that situation, what we're really seeing, I'll explain what it would look like from, and this is just anecdotal from what we hear from our members, is you have a nursing home, and then one part of it would be the dementia care unit. It tends to be more locked so that people can't leave, right? Keep that safe, and they tend to be much more heavily staffed and specialized program, all of that stuff. So when we don't have the staff to really properly do that anymore, what happens is that they close that area, they'll move the residents into the more general parts of the nursing home, try to manage it that way, and then don't backfill. So what we're saying is that we're not actually kicking people out. What we're doing is taking away these specialized places that are meant for dementia, transitioning them over to the more general parts of the nursing home, for better or for worse, and then not backfilling. So what we're losing is that specialized dementia care. Now, I think you'll have someone like the Alzheimer's Association who would be better to talk about where people are going when they need nursing home care and they aren't being admitted. We don't necessarily have a way of tracking that. But as far as what we talk about with dementia care units, I should clarify, thank you, that we're not just kicking people out, we're just transitioning that specialized care.
Okay, may I continue? Well, then, most caretakers, nurses have special skills, or they should have special skills when they're working with dementia. Okay, now, are they retaining some of these people when they put them in the general ward to make sure that they're getting the care they need and not just the minimum that you would do for anyone that was in a nursing home?
I think in an ideal world, they're hanging on to those specialized trained people, but we also know we have tons of turnover. We have lots of staffing shortages. So I think people are doing the best they can with the staff that we have and trying to do training, but also lots of turnover there as well, even when you train someone.
Okay, thank you, Madam Chair. Now, you had a question, you want that? Well, I can't take over, go ahead. Okay.
You're done?
Oh, no.
Or someone else?
Yes.
All right. Who else you got?
Haley Adorn. Thank you very much. First of all, I was just totally outdone when, you know, a soap dispenser went from $6 to $46. I mean, I'll buy a whole bunch of them and see that they get them if that's the case. But anyway, the question I just have is, one of the things you said, the buyout rates for the non-compete clauses are draining us in an attempt to recruit. Why are there so many non-complete clauses? I mean, that people are buying themselves out of, or whoever's hiring them is buying them out.
So it's a contingency that these staffing agencies have built into their contracts. And unfortunately, many of us providers find ourselves desperate times call for desperate measures. You need staff, you play by the rules. We don't have the luxury of really being able to pick and choose. A lot of the times you don't have just one agency that you contract with. You might have 6, 10. I mean, you do what you can to try and fill in what you can. And so those are in there. So when we go and have a staff that says, you know, I like your environment, it really feels homey, I want to stay here, but I have this buyout clause, we end up seeing prices 10, 20,000 for the buyout, because that's income lost for the staffing agencies. So you're essentially buying out some of their income and providing it in a different manner. And then there's no guarantee on our end that that individual, you know, is mandated or required to stay as an employee in our facility. So you run a risk in trying to bring that person in, and at the end of the day, that's where you see the huge inflation of our cost centers and our cost reports on wages.
So on your buyout clause, when you do that, do you not have a contract on that one of how long they stay, or do you just buy them out because you need to have the person working?
A lot of, I mean, it can vary, but a lot of the time, individual buildings can make their own policy in that, if that makes sense. So, yeah, most of us don't, because, you know, most of us don't with free will of employment.
Thank you. Appreciate your answers.
And if you don't mind, I can expand a little bit on the closures, because I've gone through one.
All righty.
It is very traumatic. We had a skilled nursing facility. A lot of times you have your dementia, you know, residents in there. And what we had to go through is you do have to have a plan you submit to the state, to the feds, based on your licensure. But we were not able to close our operations until every single individual was placed. So that's why you have that 60-day mandate. It can take longer. But I had residents go, our county seat, we were in our county seat, we lost our one and only nursing home. We had residents go everywhere from the closest was maybe 20 minutes away to 3 hours away.
Oh, appreciate that too. Thank you.
All right. Thank you. And then we've got a couple more questions, and then we want to kind of get back on track. Is Representative Carpenter, and then it'll be Representative Concanon. So we've got about 3 minutes between the two of you.
Thank you, Madam Chair.
You're welcome.
And in the interest of time, I'm not going to ask all the questions I have, but one thing I want to tell everybody that's testifying here is, with a few exceptions, there has not been anything that you've testified to that we're not working on. We hear you loud and clear. We don't mind you bringing up, you know, every time we meet, but believe me, we are listening. The chairs and the respective people on this committee are working. You may not see it in the newspaper headlines or any of that kind of stuff, but we are working to address these issues. So just know that. Thank you.
Representative Concanon.
Thank you, Madam Chair. Yeah, I was going to ask Linda Mowbray on the, you were talking about the number of facilities that had closed. This is your testimony, right? That.
Yes.
Yeah, so I think I have my answer already, but is the total number of beds 1,039?
Yes, that is the total number of beds once that facility that closes in March. That will take the total up to 1,039.
Okay. I mean, I knew there would be more since our last meeting, but I thought that number was shocking. But we're over 1,000 beds across the state now that are lost. Okay. Thank you. And then, are you the chair?
I'm the chair right now. We could do all kind of things, but I only have like 5 minutes.
Yeah, the Democrats have taken over.
That's right.
A quick question for, let's see, Ms. Flock. Good morning. Hey, so you talked about what obviously is the number one issue from the hospitals. When I have visited with my hospitals, I've lost the word. They're having a hard time getting getting the physicians, the new physicians,
On board?
credentialed.
But you did well.
Yeah, well,
Yeah.
it's Friday, and this place has killed some brain cells in my head this week. is that it, they're having a lot of issues with credentialing? Are you hearing that across the state, or is
Yes.
it okay? It's
Yeah,
not-
I mean, again, not only a Medicaid issue, it is statewide with all health insurance trying to get physicians credentialed. It has been my goal since I've been a hospital CEO for 15 years to have a statewide credentialing program like other states are putting in. Makes no sense at all to have to credential the same physicians with 50 different credentialing processes that every health insurance has. They're all different, and they're delayed in care. And at some hospitals, and you probably heard, it takes 9 months after you hire a physician for them to start practicing in your local communities, because it takes them that long to get through the process. So,
And I remember when a long time ago, when my husband first got into practice, it was go ahead and start, and then it would be retroactive. And
well, I would love for it to be retroactive, and kudos to Sunflower and Aetna with our Medicaid MCOs that have agreed to do credentialing, so they can start immediately, and they will backdate the approval of the credentialing to the date that they started. United Healthcare will not follow that. So as far as Medicaid MCOs, they're the ones that have been the hang up on that.
Okay, all right, thank you.
You bet.
Well, you know, I thought I had a little more time, but I think you were stalling is what you were doing. Because I was about to go to Representative Reese to see if she had a recommendation. We could be out of order for a little bit, but no. No. You have a question, go right ahead.
Question is for Scott Lopez with Alliance Rehab. Scott, you talked a little bit about there are 3 providers in Kansas, and there's 1 in Missouri.
Correct.
And your store, your agency is in Lenexa, right?
Correct.
Okay, so I guess in Johnson County,
Correct.
folks can go across. So if Kansas Medicaid recipients, they're using Missouri?
No, we have the pleasure of servicing both sides of the state line.
Okay.
And honestly, if we can't figure out the reimbursement puzzle, there is a company in Kansas City, Missouri that services some of Kansas, and then there's 2 in Wichita that are both private equity backed. Okay. I'm an independently owned company. I don't have private equity backers, so the reimbursement really, and I'm a lifelong Kansan. So I want to take care of my community. We're not some sort of mill that throws out equipment like some of these private equity companies that are looking at their bottom line and that their bottom line only. We actually care about those we're providing services for. So that really the issue, it becomes like, I have to make a decision. I can't, like, when I say we're not even breaking even, the problem is we're not, and especially, I have some information and I'm happy to share with you guys, but the reimbursement is at the point where when I add in my labor costs and my tech's van and my tech going out to make the repairs and us going out and providing the services of the home and our customer service, we're losing money. So if we can't make some sort of, work towards some sort of resolution, I hate to say this, but come May 1st, I have to stop taking new Kansas Medicaid referrals because it will put me out of business. So we're going to have a bigger access issue for these individuals because we don't have enough service providers either, and we can't even find people. Like, we're working 15-hour days because we can't even find people to come work with us because there's a professional shortage out there like we're hearing in the hospital systems. So, you know, yes, there are 3 companies in Kansas. The other problem is on the HCBS waiver side of it, I'm bidding against Missouri companies because they need 2 bids, and they don't even pay taxes in our state. So they're winning these bids by $50 because they have no evaluation and they didn't go through the process. They get a denial through the insurance to take it to the waiver because the waiver has criteria. So I take that all through the process, and then it gets bid to a Missouri-based company who wins it by $50, and I lose it, and they don't pay taxes on it.
Taxes, yeah. Thank you.
Thank you, Representative Ballard. I really appreciate you helping us out in my absence. Committee, I'm afraid that's all the time that we have. We're a little behind now, but we'll catch back up. Thank you all for being here today. I have several questions that I'm going to reserve, and I'll reach out to you privately. And now we're going to start with Carrie Bacon, the KanCare Ombudsman. Carrie, welcome to committee.
Thank you, Madam Chair. Chair people, I appreciate being able to be here and talk with you. My name is Carrie Bacon. I'm the KanCare Ombudsman. Committee people, it's been a long week, yeah. So the report that you have is the annual report. There's also a fourth quarter report that will be posted next week on our web pages, along with the annual, but I usually at this point talk about the annual report with you all. Our office, the KanCare Ombudsman office, went through a major change. We've kind of talked about it, where we are now part of the, we're functioning as an independent agency, and that whole process, I think, went relatively smoothly. So we're glad that we're at that point now. I will let you know that functioning as an independent agency is not the same as being an independent agency. You have to be in statute in order to actually be considered an independent agency. So there are a few little glitches that happen because of that, but for the most part, we still function very smoothly. We did quite a bit of outreach this last year, and if you go to pages 5 and 6, you will see some of the things that we have done. We have done in-person and video outreach to our stakeholders. We had a new fact sheet, the PRTF, which is the Psychiatric Residential Treatment Facility fact sheet. We partnered with KDHE in creating application guides, which are now posted on the KanCare website. And we continue to increase our Facebook presence. We also did a survey. Again, at your request, we're doing it annually now. Talking about the survey, you'll find that on pages 34 through 40. We had a significant increase in participation. It was a 196% increase. We were very pleased about that. We still find that there's a significant number of people that had not heard about our office, and so this was a means of helping people to know about our office. We received a significant number of comments regarding barriers to our office. It was 56% were comments on not knowing about us or not knowing how to get in touch with us, what we do, what an ombudsman is, those kinds of things. 22% were comments that were what I call operational, were things that our office can make adjustments on to make our office work more smoothly for the people that contact us. Then our initial contacts for 2022 for the whole year are the lowest we've had, probably since before we started the volunteer program. But I will tell you that fourth quarter is up, and based on the number of calls we had in January, I think that first quarter is probably going to be up again. I'm not sure what the reason is for that, but sometimes I think that the survey is helping us make more people aware of what we do, and so that I'm hoping that that may be part of the reason. In the data that we have, I included a percent to total. So let's go to pages 9 and 10, and it may seem kind of silly because you can see the numbers, but I thought it would be helpful maybe to put percent to total so you can see by region that the number of people that call us by region is very similar to what Medicaid's numbers are. It occurred to me when I was going through this report that I've kind of been making an assumption that they're similar, but I had never done a percent to total. So I thought I would do it, and then I share it with you guys, you all. And then on page 19, it shows our response time. And the response time is down. Sorry, it's on page 20. It's down for third and fourth quarter. We're still responding somewhat well within a week, but we're not quite meeting our getting things done within 2 days. And so we are going to be focusing on that for first quarter. I think that's all that I have that I'm sharing with you today. If you have any questions, I'd be happy to answer them.
Our confusion was.
Oh, I'm sorry.
We had a bit of a confusion. The document that I see online, and by the way, it's Carrie Laundered now, isn't it?
No,
Did I
I'm
have it
Carrie
right?
Bacon.
You're Carrie Bacon.
There are
That's
two Carries
two
in the
Carries
Office
with
of
the
Public
department.
Advocates, yes. And we spell
That's
our
what
name
threw me off.
exactly the same way.
Okay. I was on the wrong document, and I was not able to track with you. Thank you, Carrie.
Sure.
Okay. Now I've got the right document, and we're good. Committee, time for just a couple of questions, if there are any, for Carrie Bacon. Yes.
Thank you, Madam Chair. Carrie, did I hear you correctly? You said that your office lacks independence because you're not in statute?
So I didn't know this to begin with, and it was clarified for me by D of A lawyer. The executive order set us up saying that we are functioning as an independent agency. But the lawyer said that actually to be an independent agency, we need to be in statute. I think that the governor's office is working on something right now
that's
to do that.
what I was wondering, if you knew if anybody
I
was
actually
working on it.
provided them the language for that, and they said that they are using it.
Okay, well, and I know that we need that for the Office of the Child Advocate, the other Carrie.
Yeah.
But I was, I'd be happy to work on that, but if somebody else is already
The
pursuing.
governor's office said that they were working on that and hope
Okay,
to get
great.
it in this year.
All right, thanks, Carrie.
And Representative Carpenter, and this will be our last question.
And Madam Chair, I will make this very brief. For us data freaks like me out there, I appreciate this report because, as many of you have heard me rail on accountability and what we're doing and how we're doing it better, this really brings it home for me. So I really appreciate what you do. So thank you.
Thank you.
Thank you, and thank you for your testimony.
Sure. Thank you.
And next, we have a presentation on the Office of the Medicaid Inspector General, Stephen Anderson. Thanks for not having the name Carrie. We appreciate it.
Not a problem. Well, the Chair Gossage, members of the committee, thank you for the opportunity to appear today and discuss the Office of Medicaid Inspector General. My name is Steve Anderson. I'm pleased to provide this update. The OMIG is finalizing our 2022 annual report, and we'll file it with the Legislature hopefully next week. A copy of the report will be available on our webpage. The OMIG has also concluded its audit concerning the eligibility determination of Medicaid recipients that have moved out of the state of Kansas. KDHE's response to that report was incorporated in the final report, and it should be published within the next week or two. We also initiated performance audits last year involving eligibility determination for Medicaid recipients on the Transitional Medical Program, as well as Medicaid beneficiaries with multiple identification numbers. We anticipate having both those reports published before this committee meets again. Also, in cooperation with KDHE, our office developed a fraud, waste, and abuse awareness training program that was provided to both KDHE as well as contract employees of KDHE. We completed 6 training sessions last quarter and provided training to approximately 196 employees. It is anticipated this training will be offered in the future on an annual basis to current employees as well as all new contract and KDHE employees. The purpose of the training is to ensure that employees are better prepared to identify fraud, waste, and abuse, and how to report it. The OMIG also continues to oversee an ever-increasing number of complaints of fraud, waste, and abuse and legal acts concerning KanCare, Medican, and CHIP. The majority of these complaints do come to us via the Kansas Department of Children and Families, or DCF. I have a chart on my testimony that shows calendar year 2019, we had 227 complaints. 2020, more than double, 650. 2021, 1,195. And then calendar year 2022, we had 1,419 complaints. So as you see, every year, more and more is happening. I currently have 6 positions authorized from my office, with 3 of them being auditors. We added 2 of those auditors last June. They immediately started making a big difference by initiating audits as well as working on investigations. They were critical in helping for our ability to fulfill part of our core mission of conducting audits and performance reviews. Pursuant to the KSA 75-7427, my office is directed to establish a full-time program to oversee audits, investigate, and make performance reviews. I previously testified the state of Kansas does not have resources allocated to conduct Medicaid eligibility fraud investigations. Eligibility fraud investigations have been ignored for several years and hopefully will be addressed as soon as practical. I reference Audit Report 2002 that was done that specifically talks about this issue that's previously published. It's available on our website. This could be easily resolved by providing additional resources to the OMIG in the form of investigators and an analyst. To place the need in contact, I would reference back to the chart looking at calendar years 21 and 22 and see that the majority of these allegations do involve eligibility fraud. Another issue of particular concern is the looming problem of eligibility fraud after the public health emergency ends and KDHE begins the process conducting eligibility redeterminations. Additional staff would help us identify and investigate cases of eligibility fraud that warrant prosecution referrals. An example of a referral that we get involving this sort of thing and are referred for prosecution is the Medicaid beneficiary on caretaker medical that provided false information on her application about household composition and income. She stated that her husband, father of her 4 children, was not in the household and providing no financial support. A review of her case determined that she would not have been eligible for caretaker medical if she'd been truthful on her application and subsequent contact by KanCare eligibility workers. Consequently, her false statements resulted in $43,372 in capitation payments being made over a 5-year period. She also allegedly committed over $27,000 in food assistance fraud. Thank you for your time this morning. As always, I welcome any suggestions from the committee on audit, review, and investigative topics.
Thank you so much for your presentation. Just a quick question about the case that you just mentioned. Was any of this recaptured back to the state?
Hasn't been yet. The case hasn't been completely adjudicated. It's going through the court process right now.
As a licensed health insurance agent in the state, I'm required to take waste, fraud, and abuse training every year. And I'm wondering if this also applies to doctors, pharmacists, hospitals who are wrongfully taking Medicaid dollars, filing incorrectly. Do you do fraud investigations on those as well?
We do. We do. And as far as the training goes, we'd be happy to provide training. In fact, KDHE's talked about opening this training up and making it available to members of the public.
Mm-hmm. And then the last question is, what was the result of your training more people to watch for this? Have you had a result? You mentioned more cases coming in. Do you feel that was a result of the training or just there's more fraud?
There's more fraud, and I do believe the public health emergency has exacerbated the problem. The training we did was over the past few months, so we really haven't seen the fruits of our labor. But we did get really positive comments back from the people who received the training and had greater awareness, so that it will help those eligibility workers better understand what fraud is.
And once we can get those folks that are not qualified for Medicaid services off the rolls because of the emergency that you mentioned, that should help as well. Would you agree?
I would think so.
Thank you. Other questions, committee? Representative Landwehr.
Thank you, Madam Chairman. I guess what I would like to see, and I don't need it here today, but maybe in the next report, is kind of a detailed status of what you've provided us on I don't see the page number. Maybe it's at the top. Anyway, where you have the calendar year and the complaint screened, kind of what the status, how many of them were actually ones that are continuing investigation? Have we been able to close them? Is it there and I'm not seeing it?
It's not there. We normally don't have that in our testimony, but it will be in my annual report that'll be published here very quickly, and that'll help.
All right, thank you.
Thank you.
Representative Ballard.
Thank you. We're looking at the amount of complaints that are screened, but off the top of your head, can you say of this particular one in terms of the husband was still in the house and the amount of money, how many of those kinds of frauds do you have, or do you catch it early enough that they don't do this? But to this, how many would you say you received in this category that maybe would be over 60,000?
Sure. And this is purely an estimate, so please don't hold me to any specific number on this, but I would estimate that approximately 100 per year would fall into this category of being relatively significant. Of the 1,400 this last year, approximately 100 would warrant further investigation if we had the resources to do it.
And what possibly would be the least amount that you bring somebody in for?
As far as the threshold goes, there's other factors, of course, if they've had prior convictions or if they have also food assistance frauds as well. But for our purpose, if it's not at least $25,000 to $30,000, it really wouldn't justify the expenditure of resources.
Okay, thank you. Thank you, Mr. Chairman.
Representative Concanon.
Thank you, Madam Chair. So at our last meeting, I remember asking you about how much more staff you needed. I believe you said 5 at that time.
I actually said 2 investigators and an analyst, but if you want to give me 5, I'm not going to argue.
Well, my question before was, how many do you need to be able to expand? So the 2 that you got, is that's you're set now?
No, the auditors we got helped with our audit function. We have no resources to do these investigations, and we're just trying to scrape out time to do that. And I really need two investigators, period. I'd have 0 investigators, and I need an analyst that would be dedicated to assist them.
Okay. Was that in your budget request this year?
It did not go forward on the budget request that was submitted by then Attorney General Schmidt, but we are currently working with the current administration to get that rectified.
Okay, thank you. Thank you, Madam Chair.
Final question, Representative Carpenter.
Very good. Thank you, Madam Chair. And Steve, thank you for being here. So will you keep us informed on the process of that budget?
I will.
Okay, very good. Thank you with it. So in looking at all this, is there one critical place that the system broke down to not be able to track that? Or are you able to look at one thing and say, or is it multiple things, or is there one kind of crack in our system that allow this fraud to happen?
When KDHE and KDADS were separated several years ago, the oversight responsibility for investigating Medicaid eligibility fraud basically moved to KDHE, and they never created an investigative arm, whereas the food assistance side maintained it under DCF, and so their investigators don't look at Medicaid fraud at all. And so for the longest time, we've had a blind spot in that area, and we've been trying to identify that, and that audit report I was talking about identified that as being an issue and why it was an issue. But so I'm trying to rectify that. My office has the ability to investigate this, but we just don't have the resources.
All right, very good. Thank you. Thank you, Madam Chair.
Thank you so much.
Thank you for your time.
And now we will address the responses from the state agencies and managed care organizations. And committee, if I could draw your attention to the specific issues resolution spreadsheet, as our first conferee is coming up to the microphone, and that would be Sarah Furtick, she's the State Medicaid Director for the Kansas Department of Health and Environment. Sarah, welcome to committee.
Thank you, Madam Chair. Good morning, committee.
Sarah, one moment, please.
There's a typo in the copy that you have, so we're fully sending out a copy of the pages at the end.
Oh, thank you so much.
Okay. Good morning, committee. The first item for KDHE response is item number 3. On my copy of the log, that's page 9. And this is kind of a long-standing item talking about the need for community service coordination for KanCare beneficiaries. We still don't have an update on that. And the next one for our response is on, quite a ways down. It is on item number 9, which actually breaks across 2 pages on my copy. So I'm looking at page 21, item number 9. And item number 9 is kind of a compilation of a variety of testimony that this committee has received concerning private duty nursing reimbursement rates, which is on the KDADS side of the budget that would require an appropriation. But then there were also some concerns about administrative overhead for some of those staffing agencies. And so our response really is no further update from our November 2022 response, which is that we really don't have the legal authority to regulate the percentage of administrative overhead that staffing agencies are allowed to use based on the Medicaid rates that we pay. I would also add that we were asked to provide supplemental information on this topic, and we did include some additional information in the supplemental responses document that we submitted to the committee. So there's more information there.
Committee, what is the feeling of the committee regarding continuing this on the calendar? Representative Landwehr.
I think at this time we can remove it because it's been looked at and is being looked at within different committees, and we're fully aware of it. I'm not sure that we need to continue it on this particular spreadsheet if that's the will of the committee.
And committee, then, may I ask all in favor of removing this? Say aye.
Aye.
Aye. Okay. Thank you. It will be removed. Please proceed.
Sure. Thank you, Madam Chair. The next item for KDHE response is on the following page. Item number 10 on my copy, it's page 22. And this concerns brain injury waiver reimbursement rates. Again, that is a KDADS budget item. KDADS, excuse me, would require an appropriation to increase that rate, and we don't really have any further update beyond that. I would suggest, Madam Chair, that there really is more of a KDADS line item. As long as it's up for KDHE response, I will have the exact same response for you. So I might suggest either referencing that as an item requiring legislative action, or at least take KDHE off.
I would agree with taking KDH off. Committee? Seeing head nods? Yes, we will take that off. Please proceed.
Thank you, Madam Chair. The next one for KDHE response is the one right below that on my copy on page 22. That is item number 11. And we had a number of conferees talking about dental benefits and the need to add comprehensive dental to KanCare, and particularly coverage for dentures and partials. We have been working with Oral Health Kansas in the off-season to try and figure out what that would cost. It sounds like a very simple proposition, but the reality is we don't know what the unmet need is among our populations that you wouldn't necessarily think would need dentures and partials. You know, we might have some 25-year-olds who need a full set of dentures. So Oral Health Kansas has been helping us with some modeling for that. And based on that work, we've anticipated that it would take about 1.7 million all funds, including about, looks like 687,000 SGF to add dentures, partials, and then all the codes for adjustments and repairs to those to Medicaid coverage beginning in July. And we assume that there would be about an 18% increase in utilization for that. And Madam Chair, there might be some questions, so I can pause here if you like.
Committee, I believe we do have questions. Representative Carpenter.
Thank you, Madam Chair. Just very quickly, could you repeat the SGF portion of that?
Sure. We have the exact figure that we've estimated on the issues log, and that is $686,584.17. Our estimates are usually pretty precise.
Thank you.
And I would also add, Madam Chair, that SGF estimate is fairly conservative because that assumes that we will have about 59 to 60% federal matching percentage.
Well, if I could read red print, I would have saw that. So I'm sorry about that.
No, you're perfectly fine. Just wanted to alert you of that. I think also just looking at this, those of us who assist people that are dual eligible on Medicare and Medicaid know that many of them have access to dental coverage such as this through the program that they have through their Medicaid Advantage plan, Medicare Advantage plan, and some of them include dentures, not all. So thank you so much for that. And committee, what are your feelings on number 11?
Madam Chair?
Yes, Senator Baumgartner.
Thank you. I did have a quick question with regard to the denture tag that was just shared.
Okay, yes, please go ahead.
Okay, one of the things that we do know is that dentures and partials tend to find their way where they get lost, particularly when folks are in assisted living type facilities. So what are the guidelines or the guardrails as far as replacements on those?
So that's a very good question, Madam Chair, and thank you, Senator Baumgartner, for that question. So we would assume that we would apply kind of the national standard for denture replacement, which is a full set every 5 years. That's what this would include.
Thank you. Thank you very much.
Any other questions, committee? Does anybody see this as going forward, removing it? What are our thoughts here? Because the next would be legislation, I would think, given the information that we have. I don't know what more, I'm not sure what more they could tell us at this state. That's why I'm recommending removing it. We asked them to do a study, and that's been done.
All right, if we remove it, it's because they've made the recommendation, and I guess it's up to us to move it forward to see that it happens. But usually, we remove things when it's been done.
Well, what we asked them to do has been done. So we asked them to do a study as to how much this would cost, and that's their part, and that has been done. Does that make sense? Not what we've done. So if the legislature wants to continue with that. All right, so a recommendation, yes, Representative Ruiz.
Yeah, I just want to make sure we don't lose it, because if it's not there, then we forget about it. So if we do remove it, well, or if we say, can we say legislative action is needed and we keep it on until the next?
So committee, are we fine with that? I mean, I don't have a problem with that. I just don't think there's anything more that could be done other than legislative action. Is that okay with you, Representative Ballard? Is that okay?
That's okay, because actually, you know, I'm on social services budget, and I will bring it up, I'll be honest with you. So I'll bring it up in that case, so it's not going to get lost.
Okay.
But I think I'm fine. You can remove it because I know it's going to go forward.
Okay. Representative Ruiz, is that good enough for you?
And then hopefully between the three of us, we'll make sure that it.
All right.
Thank you.
Then we will ask that it be removed. Thank you for doing your due diligence. Next.
Thank you, Madam Chair.
Sure. Thank you, Madam Chair. So the next item for KDHE response is item number 16, which on my copy of the spreadsheet is on page 27. And this is kind of a similar topic to the earlier one about administrative overhead. This concerns price gouging on temporary staffing agencies, and state agencies do not have the authority to regulate that in any fashion. That was our response in November, and we really don't have a further update beyond that. That's not something KDHE or KDADS can do.
So at this stage, we could remove KDHE from this as well as KDADS in that they just have no authority over this. Yep. Thank you. Removing number 16.
Okay, moving right along. The next item for KDHE response is item number 20. It's on page 29 of my document. And we heard from Dave Adams from KEMSA last November. I'm sorry, this was in September, talking about some of the challenges that EMS services face across the state. Our response in November noted that the legislature added about $10 million in 2022 to help increase EMS rates. That was very well received by the EMS community. And really, we would welcome any other recommendations on how to better support first responders like EMS through the Medicaid program. And that continues to be our update on that until we can self-appropriate. That's about all we can do there.
So this was basically addressed, and not to say they don't need more funds, but it was addressed in November of 2022 by this body, by the legislature, I should say, in appropriations. So committee, are we comfortable with removing that? Yes. 21.
Certainly. Number 21 on the same page for us. This relates to the CHIP eligibility statute, which is in Chapter 38 of the KSAs. The current CHIP eligibility statute sets eligibility for the Children's Health Insurance Program at 250% of the 2008 federal poverty level. What that means is that for every year since then, the state agency has had to translate whatever 250% of the 2008 FPL was into current FPL. Last year, through a budget proviso, the legislature authorized KDHE to increase, to right-size CHIP eligibility to 250% of the current year's federal poverty level. That is a one-year-only budget proviso, and I believe the conferee on this item is asking for legislative support in making that change permanent so that it will pivot every year as the FPL increases. The eligibility rate stays the same at 250% of the current FPL. That's a change that KDHE supports. We think it makes sense, and we're happy to continue that if the legislature authorizes it.
I would say at this point we could probably remove it because we have had bills that have been submitted into both houses regarding this very issue. Committee, are you in agreement?
Yes. Again, it's one of those things, don't want it to lose. What if we're not successful in passing legislation?
Representative Landwehr.
We'll do the same thing that we've done the last several years. It will be a proviso put into the appropriations bill. Because just like we discussed last year, the issue with any bills that deal with Medicaid is how many times people want to have the Medicaid discussion and just start gutting them. And my position as the chair on health, that a lot of those bills come out of, will be that we either have zero discussion or we have one discussion. And that's what's got to be decided.
Thank you.
Mm-hmm. So we will be removing number 21. Thank you.
Okay, so Madam Chair, on the copy that the committee has, that would conclude KDHE's responses. However, there were a couple pages left off of the copy that you all have, I believe. So if it's okay with you.
Just one moment. Elizabeth, have those been downloaded yet?
They have not, and they're the printing error.
Okay.
I can either share my screen and
Yeah, let's do that.
There we go. So, Madam Chair, this piece might be a little anticlimactic because there's not a whole lot for us to share beyond this, but I wanted to make sure our presentation was complete. So item number 24, it's teeny tiny type. It says the committee requested KDHE report on existing programs that use state and federal medical funds Medicaid funds to meet the health needs of newborns and the prenatal health needs of pregnant mothers. We included that information in our supplemental responses document, and essentially CHIP and Medicaid are the biggest programs that do that because we provide comprehensive coverage for medical and behavioral health services for pregnant moms and for newborns. But we also have a couple administrative contracts with county-level agencies to do early intervention services, particularly with pregnant teenagers. So, and some of those programs are funded with federal Medicaid matching dollars. So the local agency puts up the local state match, and then we draw down federal matching funds to help support those efforts. So we've got some more information in that supplemental document.
And what was the number? Was it 24?
I don't believe, oh, yes.
Number
yes, on
24.
there.
All right, so we have a question from Representative Landwehr.
No, I was just trying to follow along because I'm also dealing with another issue at the same time here, so I apologize. So number 24, is that it, Sarah? Mm-hmm. So we can probably remove that at this point?
I would agree. Do you feel like that we ask you to present, you have presented that information? Thank you.
I would concur.
All right.
Madam Chair.
Let's remove 24.
Okay, and then similarly, item number 25, right below that, the committee requested a statement by Secretary Stanek that the recently enacted home health regulations would not be enforced and that KDHE would work to amend the regulations based on feedback from home health agencies and home health providers, and that was included in the committee report from last year. So I believe Secretary Stanek provided that statement to the committee separately. She'll be here this afternoon. We can clarify that if need be. But KDHE has not taken any enforcement action on those new home health regulations, and there have been a series of webinars that all interested providers have been able to tune in on. I think one of them was on December 28th. The other one was on January 5th. And in our supplemental response document, we include the link where if anyone's interested in watching those webinars, they're posted on the KDHE website. So that work is very much in process.
Representative Landwehr.
I think, Madam Chair, I would be inclined to maybe leave these on just so that we can track it through maybe one or two more committees and, you know, make sure that we're staying up on everything on that. Representative Carpenter.
Representative Carpenter.
Thank you, Madam Chair. So is there a triggering time for this? Is there a deadline that we need to have those in place?
You know, Madam Chair, that's a good question. I'm inclined to say no, Representative Carpenter, and the reason why is that Secretary Stanek has discretion on how to enforce those revised regulations, and she has opted to exercise her discretion not to. So none of those providers are in any risk now of having those revised regulatory requirements enforced by the agency. And I know that the Public Health Division that's working on those regulations, they're wanting to get revised ones completed sooner rather than later. I would also add that when it comes to regulations, the approval process is very, very lengthy. So if the committee were to request a deadline for those revised regulations to be effective, there could be factors totally outside of our control that would prevent the agency from meeting that deadline. So just food for thought.
I really wasn't looking for a deadline. I was more looking at what the federal government was going to require us to for a timeline. So I'm fine with that. Thank you.
I agree with Representative Landwehr in that I think it would be good to have oversight over this, and we appreciate the work that you all have done on this and look forward to asking questions of Secretary Stanek. Thank you.
Thank you, Madam
And
Chair.
that concludes yours.
It does. Thank you.
Okay, thank you. Any other questions, committee? All right, moving forward. Committee, we're going to invite Scott Brunner to the microphone. And for those of you that don't know, he's the Deputy Secretary of Hospitals and Facilities, Kansas Department for KDADS, Aging and Disability Services.
Thanks, Madam Chair. I'm going to handle the KDADS responses for the issues log. and move through those. Our first item is item number 1. Deals with the IDD waiting list, and there's a few pages of description leading to that. But our current response, or our February 23 response, is on page 5. And again, the discussion or the tracking of issues over the issues log are about the IDD waiting list and efforts to try to address that. So per the IDD Waiver Modernization Committee that met over the summer, KDADS has completed some cost estimates for the recommended community service waiver. We're going to share those with you this afternoon in our formal testimony. I believe the Secretary is going to do that. So you have those numbers to look at. And then we did start a process with the University of Kansas to study the waiting list that we mentioned last time that you all met. Research studies ongoing. We meet with the team on a monthly basis to talk about progress. And again, as they finish their report and come up with recommendations, we'll share those with this committee and other committees as well.
Committee, are you in agreement that this is something, this waiver wait list, that we need to keep on? Everybody in agreement with that? We will keep that on. Thank you so much.
You're welcome. The next item is item number 2 on inappropriate use of antipsychotics in long-term care settings. We've had an ongoing conversation about this issue with this committee. It's one of the items that KDADS regularly reports on in our testimony. Our response for this session is on page 8. We do continue to monitor trends. It is one of the pay-for-performance measures that we use with our managed care organizations, and that's the main data source that we've been reporting back to you. We're not, because of the timing of this meeting relative to the last one, we don't have a data update for you in the presentation, but in future meetings or when you meet again in the spring, we'll have that updated data for the pay-for-performance. And we should also have the national data set that we use that gives a ranking of Kansas relative to other states, but that's just not available given that your meeting is a little bit earlier in the cycle than that data is available. But we do track it over time, and we'll continue to include that in our standard agency report.
Representative Landwehr.
Scott, is it possible, I know you do it in your regular report, but is that something that you could take and bring to us? Just, it's something we're monitoring. We don't like it. No one in this room likes it. No one at the agency likes it. But we just want to keep understanding where we're at with it. And then you representing Ballard, and I've dealt with it for many, many years. And
it's on the list of items that we get from legislative research that just to include in our regular report. So we'll continue to do that and provide, as the data is updated, we won't give you something that you've already seen.
All right.
Hopefully, we try to avoid that.
all right, thank you.
Yep, you're welcome.
Committee, it is your pleasure to keep this on. Okay. Yes, we will leave it. Thank you so much. Go ahead.
The next item is item number 4, and you have to advance a few pages, I think to page 12 for the current response. This is an item about crisis services for individuals that have behavioral health and receive services on the intellectual and developmental disability waiver. Last time you all met, we let you know that we had or KDADS convened working with Sunflower Health Plan and the other MCO partners, sequential intercept model workshop, which was a gathering of folks that work in this area across different service sectors, community partners and stakeholders and others, to talk about how tracking the process that somebody goes through as they're interacting with either law enforcement or the service system, and trying to identify where there are gaps and where there might be some service connections to make. The update from that is that we've held that conference in November. I think it was after you all met the last time, and to focus on individuals with those crisis services. We're reviewing the results of that 2-day meeting, and we're working with a contractor to gather. They've got some subgroups working to focus on individual questions. So as that work develops over the next several months, we'll share that back with the committee as well. But it is identifying specific services and places where we can target interventions to help folks with those dual diagnoses.
I'm pleased to see that you're doing that, and we welcome that report. Committee, is it your pleasure that we leave this on? Seeing head nods, it will be left. Continue, please.
Item number 5 is our next one on person-centered supports. And to get to our current responses on page 16. And as you read through the other, the kind of historical description, it's about care coordination and access to those services. Our response for this month is we'll consider, as we're looking at the next round of the KanCare contract, adding other services or other more person-centered. I mean, the supports that the MCOs provide now is person-centered, but if we need to refine that definition or modify that definition, we'll look at that as we go into the next round of contract negotiations or contract procurement with the MCOs.
I've heard rumor of other MCOs that might be wanting to send an RFP and be considered. Can you tell us about that process, or shall we wait for your report?
I'd rather you wait for Director Furtick's report
Okay.
on that topic.
All right, thank you. Committee, what is your favor with number 5?
I should say it would be more appropriate for the director to talk about the RFP process than myself.
You'll be pleased to know we're going to drop this one.
Oh. Our next item is item number 6 on trends in nursing facility capacity and closure of facilities over some time. We do continue to track the number of nursing facilities, skilled nursing facility beds decreasing. We see that as from the licensing perspective, which is the part of the system that KDADS is responsible for. That comes to us in the form of requests for reductions in the number of beds on a license, temporary closures of facilities, facilities that have a low census, or they want to designate that they have a low number of beds available, and some permanent facility closures. We've got more information in our presentation this afternoon about the number of beds and facilities that are closing but across the service spectrum, so skilled facilities and other types of adult care homes. We can give you a little more full picture of that this afternoon.
Committee, on number 6, are you comfortable with keeping this one? Something we need to continue to monitor? All right, thank you. Scott, you may proceed.
Item number 7 is our next one on utilization of HCBS services tied to an Inspector General report. Our February response is that we've been working with between KDADS and KDHE to make sure that all the assessments that are needed are done in a timely way. We've pulled the fallout lists or lists of individuals who have services but they haven't been completed or fulfilled, and looked at that with our MCO partners to identify people who haven't had an assessment on in a timely basis. We've hired some eligibility specialists to help monitor that tracking and program eligibility, and we're working with CMS to develop an oversight plan to make sure that we're tracking all the assessments in a timely way.
Thank you so much for that. Let me just tell you, I'm only one committee member, but I can say the concern about taking something off of the list is like, well, thank you for, your oversight on that, but will that just go by the wayside when we feel we need to continue to have oversight? You had mentioned earlier that as part of your responsibility, it was included in your report every year. Is this something that could be included in the report?
Absolutely. That's the committee's. We can track it that way and add something into our regular report around this topic. Be happy to do that. There are some items that are statutorily required. That's where the list started, and then I think some items have been added over time. But that's certainly a way we can address it either here, and we're certainly the team that manages this directly will be here this afternoon to report, and they do on a regular basis. So I think you've got a couple of different opportunities to hear the agency's response.
Representative Landwehr.
Well, and I think also if we were to take and remove this at this time, it's a discussion that we would make sure that our Inspector General is going to always bring back to us, and I think we would also hear from our other individuals dealing with them. So that would just be my personal opinion, Madam Chair.
I'm of the same opinion. I think leaving something on, but if we add that to the report and that we want to have this consistently going forward, should not necessarily be an action item. So let's remove that, and then we can add that as if we need legislation for that.
Our next item is item number 8, which is on the same page, page 19. This is about backlogs in the CARE PASSAR assessments that individuals need to determine whether they require adult care level of treatment. The backlog are, and you'll get more information about that this afternoon as well in our formal presentation, but the backlog consists of both level 1 and level 2 assessments. Level 1 is the entry to just a nursing facility, and a level 2 assessment makes some additional determinations about behavioral health needs, and there's backlogs in both of those categories. We believe that by June 30th, it's reasonable that we could get the backlog down to a manageable level where it isn't as extreme as it has been. And then there's more information, and folks will be here this afternoon to talk about that with you in more detail than I just did.
And I would think that by then we would have our second quarter meeting, and it would be good to have a report on that. Committee, are you comfortable with keeping this on? Great.
And Madam Chair, I neglected to mention it in the follow-up information that staff asked for. This was included there as well, and there's a little bit more detail there about an information technology project that the agency is moving forward with to make more of the process of submitting a PASSAR screen and updating the information electronically, so there aren't faxes getting lost or things missing along the way. And we'll have some updates. Drew will be here this afternoon, can probably give you a little more background on that as well. But there's some additional material.
Thank you for that.
Our next item is number 9 on specialized medical rates. It's on page 21 of your document. I think our response is similar to KDHE's, that we don't have the legal authority to cap the administrative costs on the provider that provide the service. We're meeting with the MCOs monthly about how to increase provider capacity, and if there was any need to increase rates to drive that capacity, that requires some additional resources through the budget process. We did note in here that the services delivered by a licensed provider can't be self-directed because that home health service has to be supervised by a registered nurse. So unlike some other HCBS services where the person receiving the service can self-direct, that doesn't work in this area because of the nursing requirements.
Representative Landwehr?
And, this might be a discussion that we need to have with the Board of Nursing if there's some changes that we can make in that to, I'd want to hear their opinion on that, is in order to make this easier to deal with. Would you agree with that, Scott, or not?
The service we're talking about for really technology-dependent kids, having some level of medical oversight and skill is part of that service. You're dealing with equipment, feeding tubes, tracheotomies, things like that do require some specialized skill and training and oversight of if it's like in a nursing facility or a skilled facility that we regulate. If a nurse aide is doing some of that work, they have to be directly supervised by a nurse as well. So it's comparable across the service spectrum. It does create some obstacles when you're trying to do that in somebody's home, but it's worth discussing. But I think the nursing oversight, given what the skill or what the task is that's being performed, it's a medical service, so there needs to be that level of oversight.
So I think we could remove it.
I am in agreement, so we will remove number 9 completely.
Our next item then is number 10 on page 22. This is about rates for brain injury rehabilitation facilities. And our response for this month is that the governor's budget recommendation, the issue or the item is about rates in those facilities and for folks that provide that service. We did include in our budget submission, and the governor's budget includes an enhancement of $9.3 million, all funds, to double the daily rate for intensive brain injury rehab facility or brain injury rehab treatment. It may not be in a facility. So as that moves through the appropriations process, I think that would address some of the concerns that the stakeholders raised.
Committee, we removed this for KDHE. Are you of agreement to move this for KDADS? Thank you. It has been removed.
Our next item is item number 12 and deals with access to housing supports and housing services. We've provided some other responses in the past. Our update is that we agree with conferees, and KDADS has a national subject matter expert that's working with us to kind of expand our capacity around working on housing issues, both supported housing and providing housing for folks with disabilities. We recommend that the MCOs continue to invest in housing as a social determinant of health moving forward, and we're reviewing some of the current housing pilot programs to see if consolidation or expansion would benefit Medicaid recipients.
Committee, I see no reason to leave this on here. Do you have any objections? Right, we will remove it.
Our next item is item 13 on the following page, number 25. I think this is a new one, so there isn't as much history. You don't have to turn quite as many pages, but it's a request from Interhab about adopting language on assisted services that's similar to technology first states. Our response is that we're working with stakeholders to develop a request for proposal using some ARPA funds for a technology first initiative. As we're also taking on the renewal of the IDD waiver, we'll work on this specific topic with stakeholders and include it in the development of any changes in the IDD waiver that are necessary to respond.
Committee, personally, I would like to see what has been done more by our meeting on the second quarter. Are you in agreement with that? We'll leave it.
Okay, our next item is item 14. It's on the same page, item 25. It was a request from a couple of stakeholders about a grant opportunity to identify grant funding for a dementia services coordinator that could work within KDADS. The request from the committee last time you met was to do some research on what the grant opportunity looks like. We've done that. It's a grant through the Administration for Community Living Alzheimer's Disease Program Initiative. If the successful applicants for this grant could receive between $650,000 and $750,000 over a 3-year period or 36-month period, but that's 3 years. And it does require a state match of 1 for every $3 that's applied for. That's the research that we've done about the grant. We'd be happy to take direction on the committee's interest in having us apply for the grant or filling the position kind of going forward from there. But doing the research on what the grant opportunity was the request from last time that you met.
Committee, I'm inclined to remove this, but we could add another at the end of our meeting today as we're adding new requests that whether we want you to go ahead and apply for the grant. Are you in agreement? Did that make sense, what I'm saying? Here that we asked them to look into it. They did look into it. They did their part. Then we could ask them a request to apply for the grant. Okay? All right.
Our next item is item number 15 on the KMIS system. The issue was around notifications that are sent out about assessment due dates. Our response updated from the last time you met was that we've met with representatives from the Association for Aging, for the K4A and the ADRCs on January 9th to discuss the concerns about data that's available through the KMIS system. We're going to provide more timely information and routine reporting to the ADRCs to help ensure the information is available to assist them in completing assessments in a timely way. We continue to work on meetings with KMIS systems users and stakeholders and to seek input on modernization opportunities for the future. To modernize the KMIS system, I believe is the response.
Committee, again, I see this one as there's been some movement here, but I would like to hear an update and keep it on so we could hear an update in our second meeting. Are you in agreement?
Item 16 is on temporary staffing agencies. I'm not going to be presumptive and assume that you want it to be removed from our list as well. But this is about temporary nursing agencies and accountability and regulating prices. Our response, similar to what Director Fertig mentioned, this item was, we closed this item the last time that, or I think it was the last time you met, or one time over the summer. The bill that was introduced over the last couple sessions didn't advance. At this state on the list, we'd like to request it be moved to requires legislative action because we don't have the authority to regulate temporary nursing agencies under current statute.
I'm comfortable with leaving it on the list and saying legislative action because there's nothing more that KDADS could do. Are you comfortable with that? Good point. It was taken off for KDHE, so we'll just make a note of legislative action. Okay. Thank you. Number 17.
Okay, item 17 is about lack of supports for applied behavioral therapy. We've given a couple of responses before, and for February, we've made numerous initiatives to address caregiver shortages. The state plan around this service has been amended to allow for a larger pool of ABA therapists to expand the capacity.
Are you comfortable with this response that we would see that would be all that would be needed to include the larger pool in addressing this?
I think that's up to the committee. I don't have strong feelings about it. I should point out in the supplemental materials that we provided to legislative research, there was additional information about the cutoff age for this service, and it's item number 5 on that list. I can just read that to you so you have it. The best time to start ABA is between ages of 2 and 6. The research indicates that the age to stop ABA services varies widely among providers depending on severity and the diagnosis. Medically indicated, the range would be between 3 years and up to 8, or duration of treatment between 18 months and 5 years. The range for other states where they stop reimbursing for ABA services, in Missouri it's 18. Anybody who's over 18, and in Oklahoma it's age 21. So I think that's all the information you asked us to provide in follow-up to the last meeting.
Committee, what are your thoughts on number 17? Representative Ruiz.
I would like to see that age range be extended to 21.
I'm comfortable with leaving it on here and for us to review it at the next meeting. Okay, that will.
With an agency response around what it would take to open the age range, just to make sure I was tracking. Okay, thank you. The next item is item 18 on the next page, 28. It's an item about an employment first opportunity through the final settings rule. Since the last time we've met with stakeholders to develop an employment first RFP. It's currently in the procurement process, so it's out with, I don't know if it's out accepting bids or it's moving through the process for procurement. KDADS has also awarded a NEON Technical Assistance Award that will provide 3 subject matter experts to work with the state to help develop policy systems and supported employment rate structures moving forward.
Committee, I feel like this progress has been made, but I would again like to have an update in the second quarter. Yes. Representative Carpenter.
Thank you, Madam Chair. So does this include increasing the reimbursement rate for employment first?
I think that would be part of the recommendations. We'd look to the technical assistance people to help us understand if that would be useful. Getting nods that that's close to being the right response.
All right, very good. Thank you.
Representative Ruiz.
Does this include the 14C agencies that have that 14C designation?
I'm getting an indication it does not.
Okay. Thank you.
But happy to call on others if there's more information you need beyond that.
Number 19.
Number 19 is about respite care and the need for that. Our response is that we understand the importance of respite. There has to be an RN to provide that service during the renewal of the technology assistance waiver. KDADS will work with CMS to look at different options, including determining if there's an option to allow non-nursing staff to provide the respite care, kind of similar to the other item we talked about.
Thank you. And committee, I'm comfortable with leaving this on so we can have an update as to progress. Very good.
Item 22 is on page 30. And this is about access to services through Centers for Independent Living. If there was an interest in the committee or others to provide additional funding to Centers for Independent Living through KDADS, it would require an additional appropriation. That's consistent with what we've reported in the past. Our budget hearings are coming up in the next couple of weeks for KDADS. Oh, I'm sorry, I was reading the wrong one. Page 31. I apologize. I saw February and just started reading. The item was previously listed as requiring legislative action because of the appropriation need. Centers for Independent Living currently receive funding through the Department of Children and Families Rehabilitation Services. So there'd be a couple of places to look at adding that into the budget if that's the committee's desire. Sorry for misdirecting. That was on page 31.
No, not a problem. So you're of the opinion that because what I'm seeing here, the committee included this topic as a recommendation in the committee report, and that was in November. And then in February, this item was previously listed as requires legislative action, as it would require an appropriation. They receive funding through the Department of CF. So DCF. So it sounds like there's nothing more that KDADS could do in this issue. Is that what I'm reading here?
I believe so. Yes, Madam Chair.
In that case, I would be comfortable with removing it. Yes, Representative Carpenter.
Thank you, Madam Chair. And so while we're on that subject of SILs, which has become a topic for me, could we get a flow chart of their funding and how they're funded? Because I know they get some federal money, they get some grants, they get, kind of, ever since I think it was one meeting that I didn't even know what they were. So, okay. So I've been on a fact-finding tour to find out how they're funded, and yeah. So if you could.
Sure. We can work with stakeholders and our friends at DCF to put that together.
Yeah, I know PD waivers, but they get some federal grants, and,
right.
And they get some grants for you. So anyway, thank you.
We can work on that.
And are there other numbers that are not in our pages?
Just the last two items, item number 23 and item number 28 are on our list.
And they're there. Very good.
So item number 23 is there on, I don't know if you have the pages or not, but this is the item about insulin administration.
Scott, excuse me, just one moment. Senator Fagg was in Ways and Means and is just joining us, and so I can only imagine how lost he must be. So I just want you to know that there were a couple of pages that were not added on, and so those are up on the screen. Go right ahead.
All right. I'd be happy to go back and repeat everything I've said up to now, if that would be helpful at all, or, okay. I'll put the offer out there. Item 23 is on insulin administration. We've had a discussion with the committee over the last several months about what is in the scope of practice for certified medication aid, if they can do it, insulin administration. The last time that you all met, the recommendation was to introduce a bill to resolve that issue and at least raise it as a way to expand the practice, scope of practice for CMAs.
And what is the will of the committee? It sounds to me, having looked at this before the committee, When I read this, I felt that since legislation was needed to proceed, there's nothing more that KDADS could do. So I think that we could remove it and then consider that as legislation we may want to look at. It sounds like it didn't pass last year.
Scott, all right, being I don't have binoculars and I'm trying to multitask back here, what is your response on this?
What we talked about in November was that the current CMA regulations don't allow a CMA to do an injection or any kind of insulin administration. If you wanted to change that, you'd have to either direct us, well, I think you'd have to change the statute that says what the scope of a CMA's practice is. We did talk to the, oh, that's really helpful. We did talk to the folks who teach CMA courses about their interest in teaching about insulin administration. We didn't get a lot of uptake from that. I don't think anybody that we spoke to thought that was something that needed to be included in the CMA's scope of practice. And we did talk to the Board of Nursing, and they had the similar concern that it's not within the current statutory structure to allow a CMA to do insulin administration. So to
Okay.
change that would require statutory change.
And Arida, in our report, was there discussion of maybe looking at a bill? I know we didn't ask for a bill on this, but I don't remember in the report if we recommended to look at a bill, but not to draft one.
Madam Chair, my recollection is that there was language included that said that the committee would look at a possibility of a bill pending information, research on what other states were doing, which was provided today.
Okay, so I think we can remove it, Madam Chair.
Thank you. It will be removed. Next.
And then I think our last item is item 28. And it was based on the committee's recommendation that KDADS consider accelerating the timeline for approving community mental health centers moving to CCBHC status in this spring. Was included as a committee recommendation. So our update, we continue to work on the quality assurance and data collection for the first year of CCBHC implementation. The first round are actually going through that process right now. We remain on track following the statutory guidelines to onboard 9 additional CMHCs this year as CCBHCs. We're in regular communications with the association about the timeline, readiness of individual centers, and we can review that timeline during the consensus caseload process that we use for Medicaid if there's a funding change that needs to happen based on that timeline. Drew Adkins and I think Andy will be here this afternoon as well if you have additional questions, but our direction right now is to follow the statutory timeline to onboard CMHCs and into CCBHC status and look at their readiness as they move through that process.
Thank you, Scott. It looks like you heard us and that you are trying to follow statute to make sure that it's a timely manner in which this transition has taken place. Is that correct?
That's a fair assessment, yes.
Committee, I'm fine with removing that. They did their part. That's number 28.
And Madam Chair, I think that's the last item that required a KDADS response.
Thank you very much, Scott.
You're welcome.
For your time today. And next, we'll have Carrie Kimes, Director of KanCare Provider Relations and Strategy, United Healthcare Community Plan, on behalf of all 3 of the MCOs. You won the short straw.
Yes, I did, and good morning, and this will be a very quick update. Our one update today was item number 5. Updates were on page 16. And as part of Scott's updates, the decision of the committee was to close that item. But Madam Chairman, I would be open to answering any questions if there are questions from the MCOs in regards to KJ's testimony this morning on the MCOs and prior authorizations, if that would be the appropriate time to answer those questions.
I'm trying to look at our time frame, and we have a couple of minutes here where we could address that if someone had questions regarding the MCOs and something that was arisen this morning. Representative Landwehr, did you have a question? Okay. Anyone? Representative Concanon?
Not really. I guess my question would be, what would your response be to the prior authorization comments?
Thank you for the opportunity. Prior authorization is kind of always a pain point in the insurance industry, but it's also sort of a necessary evil in the means to control cost and usage within our industry. So one of the things that we look at anytime a hospital or any provider brings that up is kind of what's going on. And so one of the things that we looked at for the hospitals is kind of what's going on with that. And so for all inpatient admissions, we always ask hospitals to notify us when they admit a patient into the hospital, and then for certain clinical situations to provide clinical information as to why they're being admitted. And so in a lot of situations where we're having disagreements, it's just a situation where the hospital either didn't notify us and let us know that the patient is there, or they didn't provide the clinical information and then didn't follow the necessary steps to do the appeal or to work through that with us. So I think it's just a matter of working through educating them on the process and working through that, and just the general dislike of having to go through any sort of administrative process around the admissions of patients into an inpatient setting. The other item is kind of the disagreement of when a patient is an inpatient versus observation, and I think that's just an ongoing learning process between all MCOs, or really any insurance company, on clinical criteria on when a patient should be in an observation bed versus when they need to be in an inpatient bed, and how that conversation goes between a hospital and an insurance company. And it's just going to be something that's always an ongoing discussion and a point of contention. And so we constantly work with hospitals. All of the hospitals, from a KanCare perspective, have a full-time person assigned to them from each of the MCOs to be a resource, to have those ongoing conversations, and just making sure that's happening so that we don't have these constant points of contention. So it's just making sure those conversations are happening, and that there are open lines of conversation, that they're discussing the clinical criteria, and that there's no misunderstandings.
Thank you, Madam Chair. So in my conversations with the hospitals, one piece of that is that when they are trying to call, they're sitting on hold for hours at a time. And that, that makes communication difficult. I'd like to hear a response from, about that. And then a second question, I'll just go ahead and ask now, is do you have any policy in place for when something for prior authorization is approved, like every time? Do you have that kind of policy in place where you can go ahead and let them pre-authorize it? Pre-authorize the pre-authorization.
Absolutely. So obviously it's never we never want a provider to experience sitting on hold. That's not something that I've heard. So I would encourage any hospital or provider of any, from any walk of life, if that's what their experience is, to let us know that. Generally if they're calling to ask for a prior authorization or ask for a prior authorization review, that goes in through our main kind of provider call center line. We monitor that every day. I monitor that. I get 8 reports a day, personally, that I monitor that for United. So I know how long how many people have called, how long they're holding, how long the longest person has held on any given day of any given week. And we don't see hours and hours of people holding. So we would want to know that if that's the experience, because that's absolutely not what we want the experience to be. To your second question, there are lots of clinical conditions that are automatically what we call administratively approved, because we don't review the clinical, we don't ask them to send clinical information, because we know those are always determined to be a medically necessary admission, and we're going to automatically administratively approve those for a certain period of time. So deliveries, right, are a good example of that. We always administratively approve deliveries for moms and babies. So they don't have to send clinical or get prior auth. You just need to tell us they're there. And then those are approved automatically. So that's one good example of that situation.
Okay, thank you.
You
Thank
bet.
you, Madam Chair.
Representative Reese.
Thank you for the presentation and answering questions.
Sure.
It's well known among hospitals that you're going to sit there for hours. I mean, I've done it. I'm a clinical social worker. I work for a local hospital. I've been on the phone for hours getting those prior auths, and maybe United Healthcare is better about it, but I don't know about the others. But it would be nice for us to know what's the average time wait for that authorization from the call to whoever the benefit specialist on the insurance end, how long it takes to resolve, an issue. I think that would be important. I would be curious to know how many authorizations have been denied after the patient has already been admitted, and they've been there maybe even up to 72 hours, and then we hear that they have been denied that admission. Would like to know from the MCOs how often that happens.
Absolutely. And so just to clarify, let me clarify the point. So when you say you're waiting for hours, just to clarify, you're waiting for hours to get a prior auth decision?
Yes.
Okay. So generally speaking, just CMS defines rules in regards to how long we have to make a prior auth decision, right? So if it's deemed to be an urgent or emergent prior authorization, we have 72 hours to render a decision. If it's a non-urgent prior authorization, CMS gives us 14 days, right? Which seems ridiculously long. So on average, for an inpatient one, we usually are rendering a decision in less than 48 hours. But I mean, that is all data that we can pull on what the average time for an MCO to make a decision on an inpatient prior auth is. And that's something we're happy to put together and get back to the committee.
And how often those are denied within those timeframes?
Sure. And just to clarify, so are you wanting outright denials?
Yes.
Okay, sure, absolutely, we can get that.
Thank you. Thank you.
Of course,
Madam Chair.
thank you. I know our time is really short here, and I like to stay on time with our
Absolutely.
agenda. But I do want to mention that I have offered, since I have been a health insurance agent for 20 years and worked with both hospitals, providers, as well as insurance companies, I see both sides. When you're protecting the out-of-pocket for a client who's insured, and if a hospital could have done an X-ray instead of a PET scan, and I know that's a broad example, one being $200 and one being $4,500, the insurance company is just asking, could you just explain to us why you jumped straight ahead to this particular test? If the doctor can or the hospital can say, well, here's why, okay, that makes sense. It's trying to save and then also save on premium for the insurance companies. But then again, on the hospital side, if they're delaying care for a patient or waiting for a long period of time. So I think that we could work together. I have offered to sit as a mediator. Would you know if the MCOs would be willing to sit down with some of the key hospitals and have a discussion about some of their major concerns? Would they be willing to do that? I'd be happy to
Absolutely.
mediate. Thank you.
Absolutely.
I'm pleased to hear that. All right, committee, we are now moving on. Thank you so much. We're now moving to the unresolved issues, and Elizabeth, would you address committee?
Yes, I think you covered the unresolved issues. We have all those, but I noticed you mentioned new items. So we we would like to collect those new items from you so that we can add them to the spreadsheet for the April 2022 meeting.
And committee members, if you had some of those in particular, if you would make sure to get those to Elizabeth, and we will follow up on making sure that you have those by the end of the meeting. All right. We are a little ahead of schedule. That never happens, right? Thank you all so much. We will have a working lunch, and you all can have a restroom break. And so we will see if our lunch is here. Can somebody check? Quiet, please.
If I may,
Yes.
lunch is running about 5 minutes late.
In 5 minutes. Thank you.
For everyone, if you'll have just a heads up here for a moment, we are recessed until 12:20.
Bean? And we'll start with a presentation by Carrie Lawnard with the Kansas Child Advocates Office. Welcome, Carrie.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. I appreciate the opportunity to share with you about the Division of the Child Advocate. My name is Carrie Lawnard, and I serve as the Child Advocate here in Kansas. And I hear this morning that there was maybe a little bit of confusion regarding the different carries that happen to be in the Office of Public Advocates.
I don't know who would have done that, but I'll get right on it.
So the likelihood of two carries and spelling the same is highly unlikely. But my presentation looks like this. So hopefully all of you have a copy of that in front of you. So to start, I will be referencing, essentially I try to provide just a brief summary of the annual report. So at the front page of the handout that I had provided, there should be a link directly to our annual report, which is available on our website under the report section. If you have trouble locating that, just let me know, or I'm more than happy to provide a hard copy as well. So the Division of the Child Advocate was established back in October of 2021 via Executive Order 2127 and 2128, creating the Office of Public Advocates and then the Division of the Child Advocate. I joined the office in mid-December of 2021, and so it's been an interesting year building a new division here in Kansas. To share with you a little bit about myself, and I know this will feel maybe like deja vu to a few of you who have heard me speak and share. But I come to this role after about 14 years or so working as an attorney in child welfare and in other capacities, representing parents, working as a guardian ad litem, representing grandparents, foster parents as interested parties. And prior to working as an attorney, I had worked several years as a school social worker and then spent some time in other capacities working with mental health center, working briefly as a case manager for one of our private contractors through social work PRN, and then had served as a CASA for a time period. So for me, child welfare and child and family well-being has really been a key foundation and part of my professional career. And so having the opportunity to really play a role in developing this division here in Kansas was something that I really embrace, and I hope to continue to build it as we move forward. So looking at the mission and purpose and really the function of the Division of the Child Advocate is to hear the voices of our citizens, whether it is the foster parent, if the child, the parent, the grandparent, giving them an opportunity to voice their concerns to an independent division to really look at what's happening and hopefully then to provide an independent review of those policies, procedures, and the decisions that are being made in our child welfare system. To bring you to slide 4, page 4, it just is a real brief look at what 2022 looked like for us. So to start, building a new division was looking and hiring staff. So I'm extremely proud of our staff and the hard work and the commitment they have to developing this division and really serving our Kansas citizens and child and families. And we had shared recently, and I've shared with others, that in looking at all of our backgrounds and our numbers of years of service, our combined numbers of service in child welfare is 70 plus years. So I think that we have a good amount of experience and professional background in this role. We established a physical presence as far as the Office of Public Advocates. We're housed both with the KanCare Ombudsman and the Long-Term Care Ombudsman. And as we were developing and building policies and procedures and really doing a lot of outreach, we started hearing concerns from our citizens and those that are involved in our system. And so that's been an interesting learning process as we hear the concerns that are being shared with us as we're still building a new division. And so part of receiving those complaints and those concerns is first trying to gather the information that is necessary. And as most of you know here on this committee, there are a lot of different individuals and entities that play into our child welfare systems. And so making sure that we have accurate information and complete records as we look at what's going on is important, and it takes some time. And hopefully moving forward, we can continue to develop and evolve and have a more efficient process there. We also worked on implementing a website to share information, not only about our division, but also other resources. And through that website, individuals can complete an online complaint form that comes directly to our office. In April, we initiated, in honor of Child Abuse Prevention and Awareness Month, we initiated our social media presence and just started sending out letters and information to the public and other partners in the child welfare system. I think what's one of the important roles, and if you go to slide 5 or page 5, is that when we are looking at a concern that comes to us, there's 3 key components that we want to make sure that we share with others and that we approach a concern, which is, number 1, we want to make sure that we're coming at a place from independence from all of the different entities and parties that are coming to us in concerns, a place of neutrality. We want to, it's important that we are honoring the voices of those that are brave enough to share their stories with us, but we're not necessarily the direct advocate for that individual, because there's a lot of narratives that are being shared in this, involving this child or this family. And so we want to make sure that we're hearing and looking at it from a place of neutrality and really then advocating for child and family well-being overall. The third piece is confidentiality. We think it's important not only to honor the confidentiality of our children and families that are in this system, but also the individual who is brave enough to share and bring their concern to our division. On page 6, or slide 6, it really just breaks down the different types of investigations at this point that our division is looking at. And those are probably the largest number is case-specific investigations. And that's when an individual brings to us a particular concern regarding a child and family and their individual experience. The second type of investigation that we are looking at is a systemic investigation. We do have a couple of those right now that we're looking at, and really that's looking at if we start to hear concerns regarding a particular area and looking at the systems in that area or region or by a particular practitioner, then we're going to be looking at that from a systemic investigation point of view. And then finally would be a KDCA-initiated investigation, and really that's taking the information that we've learned from the first 2 types of investigations. If we're starting to see patterns and practices across the state or in particular areas, then we may be initiating a more intense look at what's going on. On page 7 is just the map of Kansas. We utilized the DCF map that shows the regions and the different areas here in Kansas. And you'll see that we just really highlighted the number of complaints that we have received so far in each of those areas to highlight where they're coming in. You'll notice that in some of our larger areas, such as Wichita, we do have a larger number of complaints, which makes sense based on the population there. What was encouraging to us is that we have received concerns in each of the different areas. So our outreach is working. I know that we have a lot of ways that we can expand and make sure that people do know about our division and and this resource that's available. If you look at page 8, it just is a quick look at the number of formal complaints that we have received each month. You'll see that spike in May, which we attribute to a lot of the outreach that we were doing in April. And also just in looking at other areas that when concerns start coming in, there tends to be a spike at the end of semesters in schools or entering into summer. And then you'll see a spike in November. And that also can be attributed. I think there was some information in the media that may have brought some awareness about our division, as well as, again, looking at leading into the holidays tends to increase concerns and people outreaching. Slide 9 or page 9 is really just a quick summary of the primary concerns that we have heard from folks that have reached out to our division. So in the annual report, you'll see a much more comprehensive list of concerns that we have received, but this is really essentially the top numbers as far as what is coming in so far. And then if I can take you to page 10, when we're looking at policy and practice considerations based on some of the information that we're hearing so far, some of these are not going to be new or surprising to anyone in this room, which is the workforce issue and how that is impacting the services that are being provided to our children and families. And we see that workforce really playing into a lot of the different areas of concerns that are coming into the door, whether that's the need for proper training, supervision, support, caseload management. And then something that I know that this group is looking at closely is looking at some of those community resources that are being provided to our children and families, the mental health supports. So as we look at the number of youth that are entering care, really focusing on the prevention services and working to ensure that our families are equipped with the services, supports, and skills that hopefully they need then to keep their children safely in their home. And then once youth do enter into care, one of the concerns that we continue to hear from folks is the lack of services once they are in care. And so again, looking at those community services that are available. And as you'll find, and as you are aware, that services look different across our state. And so really trying to focus in on those areas where we have some gaps in services available. And if I can take you to page 11 or slide 11, for this division, it's looking at moving forward, 2023 and beyond. And so I think I alluded to the fact that one of our focuses moving forward is really continuing to improve our timelines and responses to those individuals who are bringing concerns as we continue to develop our procedures and our outreach and really looking at how best to triage those concerns and where we can have the most impact and advocate sooner in improving the services that are being provided to the children and families. We also want to continue that outreach across the state and making sure that individuals know that we're a resource, and we want to make sure that we're a resource. So when people come to you, your constituents express concerns, we hope that this is a division that can provide support and resource to those individuals and answer questions that you may not know the answer to. One of the, we did initiate a couple projects starting in 2022, and moving forward, we intend to continue to work on those and provide information. One of those was a former foster parent survey. There was some information that was provided in about, I think it was October of 2022, noting really the large number of foster families that have left in the service of providing and opening their homes to our youth and no longer renewing their license. And it was a significant number. And so in getting that feedback from the Joint Committee on Child Welfare Systems Oversight, we had worked with Department for Children and Families and KDHE to get that information in the child placing agencies and then initiate a survey. We do have preliminary results that we had shared with the Joint Committee on Child Welfare Systems Oversight, and we're working towards really gathering the rest of that information from individuals. So as people completed that survey, they also had the opportunity to share their names and their direct contact information and consent for us to contact them directly to really get a much more comprehensive information regarding, why did they leave? What were their frustrations? What were the things that were working, and where can we improve? And so we hope that that information will be helpful moving forward. The second project that we had started is we have continued to receive concerns about the agency process regarding the best interest staffing, how they decide who is the adoption the family who is the adoptive resource and permanency option, and what that looks like in the process, as well as judicial oversight. So we have just started some conversations so that as we're hearing those concerns, that we're also gathering information from the individuals who are working with those children and families and find out what's working for them and what's not working, so that hopefully our recommendations can be something that is helpful moving forward. And finally, we hope that the Division of the Child Advocate can be really a platform for providing information and really a collaborative effort to improve our systems. So there's a lot of different groups and entities that are acknowledging that we need to do better for our children and our families. And I think a lot of times those are working in silos. And so if we can assist in providing a place of bringing all of that information together so that we can continue to improve and do better for our children and families, and we want to do that. And finally, just I added a special thanks and acknowledgement, because I think one of the things that's so important for us is to acknowledge that it's not just one agency, it's not one service provider that is child welfare and improving our child and family well-being, but it's all of these different groups, whether it's the Department for Children and Families, whether it's our foster care case management providers, our child placing agencies, our schools, our courts, our mental health providers, our faith community, our community advocates. We all play an important role, and it's going to truly take a village to improve our systems. And just finally, last page is the contact information for our division. And so I welcome, if you have questions, if you have information, if you have constituents that have concerns, please feel free to contact the division. And we're more than happy to speak with you directly, speak with your constituents, and we hope to receive feedback moving forward as well, and how best we can serve our citizens. And Madam Chair, I'll be happy to stand for questions.
Thank you. Committee, do we have questions for Carrie? Senator Fack.
Thank you, Mr. Chairman. And Carrie, thank you for what you do.
Thank you, sir.
How many children would you say in the state of Kansas, like last year, we advocated for? Trying to get a scope of how big this is.
I'm sorry, how many, if you can repeat the question, I lost.
Your child advocate, how many children did we advocate for?
So we had received, in the year 2022, we received 165 formal complaints, and that involved 321 children.
321 children.
And we anticipate that as a new division and as we continue to do outreach, that number will continue, that will increase as we move forward.
Okay. Thank you.
Representative Landwehr.
Thank you, Madam Chair. On your chart on page 8, are you able to track the complaints with perhaps the number of children going into the system at the same time, or?
That is not, Representative Landwehr, that is not something that we have tracked yet in 2022, but moving forward, if that would be important information, I think, as we look at the numbers that are entering into care, as well as our numbers, those are numbers that we would be able to look at.
Okay. I just think it'd be good to kind of, follow those trends and see if we've got any correlation with any of that. And I'm happy to sit down anytime you want to about the number of reasons that we have lost foster parents. I won't take up the committee's time on that. And a comment moving forward, and I have had these discussions with the agency before, is an online database would just be so much more wonderful to have access to. And the other problem that we run into is our workers being able to find time to actually sit down and put stuff into the files so that we have timely information on any one child. And I'm not going to fault those workers, because I also know the caseloads that they're trying to handle. So it's a tough project you've got.
It is, Representative, and I welcome the conversation regarding the foster parents, I think, and the struggles that they're facing. So I look forward to that conversation. In regards to the database and information, it's a struggle that we've acknowledged. Number one, just our staff being able to access the number of different databases that information is being housed in. It takes time, it's complicated, and then you question how accurate it is and thorough. And we also acknowledge that these workers are oftentimes working in crisis mode. So they're there looking at which fire do I put out first. And when you're doing that, you don't have the time to sit down and make sure that you're accurately documenting everything that you're doing. And so, so that absolutely is an area that we would support, is that the department just continuing to work on that database. And I know that there's steps moving forward, and so just continuing to take those efforts.
Could you just give us a quick update on, you said as you're doing more outreach, can you tell us what sort of outreach you'll be doing in the future?
So that's, Madam Chair, we haven't exactly identified where we want to go next. So I do think that one of the things that we have discussed is making sure that our school districts have all of our information. We have received complaints or concerns from schools, and so we know that a few people may have that information, but making sure that that's an area that we can do outreach, continuing to make sure that we can reach our youth. So how can we ensure that our youth are receiving our contact information? So we've talked with our independent living service providers, and so I know that they have that information, but also making sure that some of our younger youth, our guardian ad litems, our court personnel are utilizing that as a resource.
And has there been any progress in moving toward talking to faith-based groups, youth groups, et cetera, getting this information out to churches and synagogues?
We haven't gone there yet, but again, we're open to information and feedback and suggestions and how best to meet to get the word out.
Thank you, Carrie. Thank you for presenting to committee. And sorry, I was just a little late getting us back in and convening. Thank you again.
All right, thank you.
Committee, before we move forward, I just have a couple of quick announcements. First, I would like to thank CMHC and Kyle Kessler. Kyle, are you in the room? Thank you for lunch today. We really appreciate it. Also, we did not intend to hang meat in the corner today. I realize it's extremely cold. I've heard from everybody. My hands are freezing. I can't even write in my notes. We've asked for it to be turned up. We understand that that may be broken. And so that would explain why, frost is on the inside of these windows. So I hope you'll bear with us. I also want to thank Representative Landwehr. After my injury, it's very difficult to sit. She brought a special pad for me that I really appreciate, but it makes me look 6'4". So I promise I have not grown over lunch. Now we'll move next to the KDHE updates, and we'll start with Secretary Stanek, if she's in the room. There she is. Thank you, Secretary, for your being here.
There, no. Good morning, or afternoon. I guess it's afternoon. Good to see all of you. I just have a few brief remarks today, and again, looking forward to working with you this session. I'm making my way to one-on-ones with most of you. Related to the Medicaid program, you're going to hear a lot of great updates from both sides today, but I would tell you that we are continuing a lot of great agency collaboration between DHCF, KDHE, and KDADS and DCF, and I want to thank Secretary Howard and her team for continuing to look for opportunities to make this kind of split program more aligned and into one. I'd also say that the MCO meetings, I referenced them in a previous meeting, we have been meeting again as leadership teams, and we had a joint collaborative in January, which was a compilation of a lot of the individual joint meetings we were having with them. And we are focused on some bigger strategies for the program, trying to get back to basics on every day there's something going on in Medicaid. I mean, it runs well, but there's a lot of other stuff we want to do. And some of the focused work we're looking at right now and working on is a centralized credentialing mechanism, so we don't have three disparate, separate credentialing processes. We have one that will be a massive undertaking, but it's doable and it's been done in other states, and we need to get there. And so I'm committed to seeing that through, to do the homework and figure out what that's going to take. So we are working on that. We also have a lot of technology, but we don't necessarily have a technology roadmap. So we're bringing in all of the vendors that currently serve the Medicaid program by around June. And we're going to have a little summit to hear from each other, all the vendors, what we are using, what we're not using, what we could optimize, and what's out there that maybe could benefit the program, both from the beneficiaries as well as the people that run the Medicaid program and the people that have to deal with claims and everything else. So we're excited about that. We are also, we have a number of quality measures. We're not really aligned on them to the degree maybe we could be. We want to try to work in subgroups on quality measures that align with the state health rankings, where we stand. Are the initiatives the Medicaid program's working on aligned with trying to improve some of those? We also have a number of pay-for-performance measures. We also have some HEDIS and the FQHCs have different measures than the hospitals and the other providers, and so we are working collaboratively to try to align some of that. And continuing on some discussion from last year, the value-added benefits, we continue to talk about how to promote them. We're recognizing some gaps in awareness there. And so those are kind of the high-level items I'll cover today and tell you we're working on them. Again, you're going to hear a lot of great detail of all the work that's going on in the Medicaid program, but I'll entertain questions if there are any.
Thank you, Madam Secretary. Committee, do we have any questions for the Secretary before we get into the rest of the reports?
Not yet, but we'll work on it.
Okay. Hey, thanks a lot.
We'll move to Sarah Furtick. Hey, you're already up there. Great.
I sure am.
Thank you for
Madam
coming
Chair.
back.
Yeah, you bet. So there will be 3 folks from the Division of Healthcare Finance providing our update today. So I'll start with me, then we'll move on to LaTanya Palmer. She is our Director of Eligibility. I think most of you are familiar with LaTanya. And then we are going to round out with Christine Osterland. She is our Deputy Chief Operating Officer. She will be providing some information on the Consolidated Appropriations Act of 2022. Yes, Madam Chair?
Is this a continuation of the slides that the Secretary was using or a different presentation?
These are the same slides that the Secretary was
so. Okay,
using.
could you tell us
we
what
should
page
be-
you're on?
Well, I should be on,
Page 4.
yes, page 4.
Thank you. Well, no, my page 4 doesn't look like.
It's the second report. Update Bethel. Not the executive one. Right. Okay.
All right, thank you. We'll give us a moment to find that, if you will, Sarah.
Does everybody know where we are? Okay. The challenges of going paperless sometimes. All right, so the first item that we wanted to update you all on is where we are on the KanCare Section 1115 waiver and our next steps in that process. So when we appeared in front of this committee back in November, we had updated you all on the results of our public information sessions that we held throughout October. We held 15 of them and got a lot of really good input from various stakeholders during that time. In early December, we held formal public hearings on the 1115 waiver renewal. And then we took all that input and finalized our waiver application, got that submitted by the deadline, which was New Year's Eve. We got it submitted on December 28th. And so it was a lot of work to get that submitted. So right now, the 1115 waiver application is posted on CMS's website, and we are in the federal 30-day public comment period right now. That concludes tomorrow. On the electronic copies, we've included a link to where folks can go and view the comment. When I checked the other day, we'd had 5 individuals submit comment. One of the comments had no content attached to it, so we couldn't really do much with that. We had 3 organizations submit comment in support of moving in this direction, and then we had another commenter who had some just general criticisms about KanCare. So that is in process. Where do we go from here? So after the federal public comment period, CMS will continue their review of our 1115 waiver renewal application. Typically, they like to have 12 months for that review. So in all likelihood, it'll be fall until we hear from them on kind of a final decision on how they're going to, well, we anticipate they will approve our application. We'll hear about that probably later in the fall. We also anticipate we'll get some questions from them throughout the year, clarifications. We might have some meetings with them. So all very typical process. We also have 2 other companion pieces to the 1115 waiver application that we'll be working on this year. One of them is what's known as the 1915B managed care waiver, and then the other one is a couple state plan amendments that we need to fully transfer most of the authority for Medicaid managed care in Kansas to authorities other than an 1115 waiver. And it's kind of a refresher for those of you who were around last year and heard us talk about this a lot. The purpose of this is to make sure that we, going forward, the risk of having to return federal dollars for overspending CMS set spending caps is minimized so that we, as a state, we can invest as much in Medicaid as the legislature sees fit. That's kind of what we're doing. So all of that will proceed later on in this year. And the go-live date for all of these waiver applications is going to be January 1, 2024. So we've got, Representative Carpenter will be pleased to hear, we've got about 11 months left under our current budget neutrality caps. I will be thrilled to say goodbye to them. And so, yes, this is a good thing for the state. Still some work to do there. Next slide, please. All right, so an update as well on our KanCare MCO contract reprocurement. Our current MCO contracts expire at the end of this calendar year. We will be doing a 1-year extension through calendar year 2024. We have not started that contract extension process. The reason why is that CMS will not allow us to extend those contracts until we have set capitation rates for calendar year 2024. And typically we set calendar year rates. That process starts in the spring and goes into the summertime. So we just haven't gotten there yet. But we will be working on that later this year. And then the next steps for the RFP, we're going to be resuming the public input sessions that we started in the spring of last year. KDHE and KDADS will be working on those jointly. We don't have dates, times set for those yet, but we do anticipate having a large number of input sessions. We want to, we learned from last fall when we did public input sessions for the 1115 waiver that most folks strongly prefer a virtual format. We had some in-person sessions where no one showed up, but we had the Wichita State University support team there. We had our contractors. We had KDHE staff. We had KDADS staff. So we had Spanish language translators there, ASL translators. We were ready to go and no one showed up. But our virtual formats were very popular, particularly with actual KanCare members. So we anticipate, from that learning experience, we anticipate leaning pretty heavily on the virtual format. It also makes it easier for folks to join. I mean, you can just hop on one of these input sessions from your couch. You don't even need to get in the car or put on shoes. You can do it. So we're going to be working on that probably late winter and into spring. And really, I mean, the goal of these is we want to hear from everybody who has a stake in KanCare. So that includes you all. That includes the folks sitting behind me in the gallery. That includes advocates, providers, our members. We want to hear from everybody who cares about KanCare and wants to see it succeed. And so we're hoping to get the RFP on the street, ideally September 2023. That's what we're looking for. Next slide, please. So a little bit more information about the postpartum extension. You may recall that back in the 2022 session, the legislature approved funding that allows Medicaid to extend coverage for pregnant women through 12 months postpartum. That is up from about 2 months postpartum. That was the previous long-standing policy. So that was a very well-received change in Medicaid eligibility. And so we submitted all the federal approvals necessary to make that official. That policy became effective April 1st, 2022. We had to wait until the end of the session to submit the approvals, but under CMS rules, they can be retroactive to a date. So we set that at April 1st, 2022. And so now what comes next? We've got an extra 10 months of coverage for postpartum women. What are we going to do with it? So we've been talking with the KDHE Public Health Division, in particular the Bureau of Family Health, to figure out areas where they see we can drive some improvements in maternal mortality and morbidity. And so we've got a couple of coverage additions that we're studying for effectiveness. One of them is to make sure that breastfeeding moms have access to lactation support counseling. It doesn't always come easy. It sounds like it's easy, but some moms struggle with that, and we want to make sure that our moms have access to that support to help them be successful. We're also looking to possibly expand coverage for home visits for Medicaid moms. That can make sure that, you know, women are seen timely. It also helps providers kind of get a view into how mom is doing in terms of mental and emotional health. And then we're also looking to into adding doula coverage. And we can talk more about this throughout this session, but doulas are non-medical providers, and they're really kind of a support network for the pregnant mom. They know a lot about the birthing process. They can help moms who are kind of scared of the process navigate it. They can help moms better understand instructions from their doctors. They can help direct moms to resources in the community and to where to go in the medical system when they need help and when they have questions. We've talked with some folks in Sedgwick County. There's been some evidence coming out of Sedgwick County that indicates that women who receive support from doulas early have much lower rates of C-sections, so there could be some cost avoidances there as well. So our team is studying that to see if that might be a worthwhile addition to help some of our most vulnerable moms get that timely prenatal care and hopefully, you know, reduce unnecessary C-sections and unnecessary poor health outcomes that could be avoided. Next slide, please. An update on the Healthcare Access Improvement Program, or HCAP, as we pronounce that acronym. So I've been, I think since I started in this job, I've been providing updates about the HCAP to this committee. It's possible, Madam Chair, that this might be the last time I need to do this for a while, and for the very good reason that we finally received all of the approvals that we needed from CMS last fall. The advocacy to expand this program began in 2019, ahead of legislation that the legislature passed in 2020 to expand this program to bring in more federal dollars to support Kansas hospitals. And after a lot of advocacy on behalf of the state, KHA has been very intimately involved in this as well. The entire Kansas congressional delegation, in particular Senators Marshall and Moran, have been involved in this advocacy. And we finally got all of our approvals in place by October 2022. So I'm happy to report that this program is fully up and running. The first round of quarterly payments to hospitals went out in December, and the next round of quarterly payments is scheduled for sometime this month. This is important to the state because really for the first time this program is self-sustaining. Under the prior law that we had been unable to fully implement until last fall, hospitals were assessed a stagnant rate. So it was based on a particular year's revenue. So the amount of tax dollars coming into the state had stayed the same since like 2004. But the program was working, and we were spending more than we were actually taking in revenues. This meant that state general fund dollars had to be used to prop up the program for a number of years. And so it is now self-sustaining. We don't need to rely on SGF anymore. So this is great news for hospitals, great news for you all, and great news for the state. Next slide, please. An update on our STEPS program. So a little bit of background. This is a purely voluntary employment support program for up to 500 members who are eligible for KanCare. And it's really targeted to fill the gaps between other employment support programs that we have in Medicaid. So the folks who are eligible for this program, they tend to have behavioral health diagnoses, serious behavioral health diagnoses like schizophrenia. And also it's targeted on folks who are on wait lists for HCBS waivers. So an update where we are now, we had 38 members participating in the program in November. We're now up to 50. Of those 50, 30 of them are on the IDD waiver wait list. We've got 3 more on the PD waiver wait list. 1 is on the brain injury waiver, and we've got 16 of them in the behavioral health population. So we've had 200 referrals so far, and we're constantly looking for opportunities for outreach for members who might be interested in this. And we also included a link on the slide for more information about the program in case anyone likes to learn more. Next slide, please. An update on the COVID-19 public health emergency. So our update is going to be different than it has been for the last multiple Bethel committee meetings. So the federally declared public health emergency that had been set to expire on January 11th has been renewed for another 90-day period. It's set to expire April 11th. Since these slides were submitted for printing, we have found out that the Biden administration intends to terminate the public health emergency effective May 11th, 2023. So a little bit of breaking news there. Also, and Christine will provide more information about this shortly, but under the Federal Consolidated Appropriations Act of 2022, no longer is the public health emergency tied to the ongoing requirement to keep folks on Medicaid, the continuous eligibility requirement. As of April 1st of this year, those two things are decoupled. So the public health emergency can continue as it's going to continue, and the obligation to keep folks on Medicaid will terminate as of April 1st of this year. So it's been decoupled at last. However, we are still tracking that public health emergency closely. There are some flexibilities that we were able to enjoy during the public health emergency. KDADS has some on the HCBS waivers. And so CMS is continuing to work with states to figure out which of those flexibilities should continue and which ones would expire along with the public health emergency. Next slide, please. So 3 more slides for my presentation. I won't highlight these necessarily, but what we showed here are the MCO profit and loss per NAIC filings for all 3 MCOs. These numbers are cumulative, and so we're showing you Q1, Q2, and Q3 for 2022. Q4 2022 information is not yet available, but we would likely have that by the April Bethel. So, Madam Chair, that concludes my portion. I can stand for questions now, or I can turn it over to LaTanya.
Sarah, we'll go ahead and see if we have any questions for you. Any questions for Sarah? Yes. Representative Carpenter.
Thank you, Madam Chair. Sarah, thank you for being here. Slide 5, just curious, I see the MCO contracts have been extended for a year. So how does that work? Who has the authority to extend those?
That's a good question. So, Madam Chair, they have not been extended yet. They are currently set to expire at the end of this calendar year, but we'll be extending them for an additional year. So this is a process that requires approval by CMS and also the Department of Administration. So this goes through the procurement office and D of A. So those are the approvers.
Thank you for that. I remember a pretty big fight to get it extended a year in the legislature last year, and then I look on here and you guys are, so just kind of funny how that works.
Madam Chair, we don't really have an option. We can't just let the contracts expire. We don't have an option. We have to continue these services. So that's why we're doing that, to bridge the gap between when this contract will expire, including that 1-year extension into 2024, and when the new MCO contracts will go into effect.
And you will be going out for RFP probably in the fall?
Yes, absolutely. We have to.
Okay, very good. Now to HCAP. One of my favorite subjects. So how many dollars were we talking about there?
Oh, if I recall correctly, Madam Chair, I think in total with state general fund, no, sorry, not state general fund, the assessment revenues plus the federal drawdown, we're talking about $450 million annually. It's huge.
Yeah. Now, were there any doctors reimbursements in that this time?
That's a good question, too, Representative Carpenter and Madam Chair. So the way the HCAP program currently works, the revenues go to support physician rate increases, and it also goes to support hospital rate increases. The way this new program is designed, the physician rate increases will remain the same. There's no additional physician rate increases with this program, and the additional revenues are going to the hospitals.
So the old one was roughly 80-20.
I believe, Madam Chair, there was an LPA audit that showed that in reality, it wasn't quite like that under the old program. It's supposed to be. The way we've designed the new program allows it to fit the statutory distribution scheme.
So we do have that straightened out.
We do, finally.
And then one final question on that. So there was a provision in the budget that SGF funds would be used to backfill HCAP. That is no longer necessary?
That's correct. So, Madam Chair, under this new program, it is self-sustaining. The revenues that we bring in from the hospitals are used to draw down federal matching funds, and that is the pool of money that gets distributed. So no more SGF backfilling.
And Madam Chair, I might add, the reason I say that is because I was responsible for backfilling the HCAP, the original back HCAP with SGF, and I want to make sure that that doesn't happen again. So very good. Thank you. Thank you, Sarah, for the question.
Representative Landwehr.
Sarah, you talked about some things on that would expire and some things that would not expire. Is it possible for us to get a list of what those items are?
Madam Chair, Representative Landwehr, are you talking about the PHE-related flexibilities on slide 9? Yes. Sure, yeah, we can provide that to you.
Okay. And then just to add on a comment, I'm just kind of flabbergasted, I guess, a little bit with the idea of the extension, because even some individuals on this committee and other committees accuse myself and many others of colluding with current MCOs and offering no-bid contract extensions, and now everybody's really quiet about it. Even got to the point where several of us got a letter from Mr. Grissom asking for all of our digital communications between ourselves and other folks. So I find it interesting that everyone's quiet, everybody's happy now, that it's being extended out a year, and that none of us should take and worry about these contracts. I don't understand, I guess, why the current administration could not have had their RFPs on time, as you had predicted, for early this spring.
Madam Chair, so the bill that was passed in 2022 blocked the state from issuing an RFP for these contracts until after January 31st of this year. That would not give us enough time to responsibly rebid these contracts. That was the message that we shared back during the 2022 session. We need about 15 months from when the RFP hits the street to when the contracts go live. There's good reasons for that. It takes a lot of time for bidders to put together their bids. It takes a lot of time for the state to carefully review these bids. They come in on carts. It's volume after volume after volume. It takes time to go through all that information. It takes time to negotiate contracts, and then you need at least 6 months for implementation time. You add all that time up, you need about 15 months or more. So to answer Representative Landwehr's question, if we had tried to put the RFP on the street on February 1 of this year, that would give us 11 months to implement. That's not enough time. That would be setting the state up for failure. So as we tried to convey last year, if we were delayed in issuing the RFP, we wouldn't really have a choice but to try and extend these contracts, because there isn't enough time to responsibly reprocure in 11 months. So that's why we're extending them. We would have preferred to bid last year, to put it out to bid last year, but we have to extend them.
Thank you very much, Sarah. And to keep us on track, We're getting back on track. Let's call up LaTanya Palmer, Director of Eligibility. I wasn't on. LaTanya Palmer, Director of Eligibility, thank you and welcome to committee.
Thank you very much. Good afternoon, Madam Chair and members of the committee. I'm Tanya Palmer, Director of Eligibility. I will be starting on slide 13, providing a few updates to the committee. I will provide an update on our application status, as well as our application processing times as they stand right now. And finally, I will provide an update on our staffing levels. Next slide. Thank you. Currently, we have a little more than 7,000 applications in-house, and as you can see, a vast majority of our applications are processed in under 45 days. About 8% of our total applications are over 45 days, with 1% of those in active status. So these applications are ready to be processed. About 6% of our total applications over 6% of our applications over 45 days are in pending status. For these applications, we're waiting for more information in order for us to process these applications. Typically, information that's requested of the applicant. Sometimes it's information that's requested of other parties involved in the application process. Just to note that some applications we do, according to federal requirements, have up to 90 days to process. And that includes applications where the applicant reported a disability, but is not declared disabled according to Social Security, the Social Security Administration, or a determination hasn't been made by the Social Security Office. So there's a bit of a process to get through for the applicant to have a determination by SSA, but we do hold those applications until a decision has been made by that entity. Next slide, please. Slide 15 is an additional slide that we wanted to share with the committee. We thought it would be of interest. I believe Senator Gossage, you asked a question related to the data here in previous Bethel committee meetings. This slide outlines approximately how long it takes our staff currently to process applications from beginning to end. So at the point that we receive an application and then up to the point that the determination has been made and a letter sent to the applicant letting them know the outcome of their request. For elderly and disabled applications, it's taking us approximately currently 18 days on average to process these applications. These are applications for individuals age 65 or older, disabled, or are Medicare recipients. Applications for individuals requesting long-term care services, it's taking approximately 27 calendar days to process these requests. These are applications for individuals who live in a nursing home or medical or other Medicaid institution or similar facility. This group also includes individuals requesting home and community-based services. Family medical applications on average approximately 11 days for us to process these applications. These are for typically applications for pregnant women, children under the age of 19, and low-income parents and caretakers caring for minor children. Again, these are averages. Sometimes it takes a little bit more time, sometimes less, but as we've demonstrated in the previous slide, majority of our applications, the vast majority, are processed in under 45 days. Applications for pregnant women are expedited, so typically processed in under the 11-day time frame that we have here. Elderly and disabled and long-term care applications are the more complex applications requiring asset information from the applicant. So those typically take us a little bit more time to process in comparison to family medical applications where we do not request verification of assets like bank statements and other resources. Next slide, please. Slide 16 provides an update on our staffing. We currently have 23 vacancies, and this is an improvement of approximately 16% in comparison to April 2022. So we are very happy and pleased to see that we have been able to report steady improvement in our recruitment efforts during each Bethel committee meeting. And our hope is to continue the momentum with the understanding that attrition is just, part of business. We have experienced great progress in recruitment. We know that the current challenge is to get our staff up to speed. Eligibility processing is complex, so it'll take a little bit of time for us to get the staff up to speed so they're really proficient in processing eligibility. And that is all that I have for an update for the committee this morning. A little shorter of an update than I typically provide, but I'm happy to answer questions if you all have any.
Committee, are there questions for Ms. Palmer? Seeing none, thank you so much.
Thank you.
And we'll move forward to Christine Osterland, the Medicaid Operations Director.
Good afternoon, Madam Chair, member of the committee. I'm Christine Osterland, Deputy Chief Operating Officer for KDHE. Today, I'm going to provide the update on the ending of the continuous eligibility requirements, going through some of the changes that resulted from the omnibus bill that passed in late December. Next slide. So kind of at a high level, I know Sarah touched on this. One of the big changes that was made due to the omnibus bill was it finally decoupled the ending of continuous eligibility from the public health emergency, and it set the date for us that when we can start terminating folks from the Medicaid rolls is April 1st, 2023. Probably the other biggest change from the omnibus bill, which is actually a gain for the state, is they changed the federal participation. I think most of you are aware that during the public health emergency, we were receiving increased FMAP of 6.2%. Prior to the passage of the omnibus bill, the way the rules were set was that when the public health emergency would end, we would receive the increased FMAP for that quarter only, and after that quarter was done, that increased FMAP would be 0%, and we'd be back to just our base FMAP rate. So the omnibus bill actually gave us a step down of the FMAP, which kind of coincides with the 12-month cycle to review our members for if they're still eligible for Medicaid, and during that time we'll still receive some increased funding from the federal government. Next slide, please. So this next slide really is just kind of showing you a breakdown of what that step-down process looks like for the increased FMAP. Just as a reminder, our base FMAP rate is 59.76%, and that's for the fiscal year, which would end September 30th. Typically, FMAP rates do not change dramatically, so our base rate will stay around that 59.76%. You can see, obviously, the quarter that we're currently in now, the 6.2% remains the same. Where we start to see the change and where the benefit to the state begins is second quarter, which will start on April 1st of this year. Under the omnibus bill, we will still be receiving 5% increased FMAP compared to previous guidance we would have already been at 0. And you can see that we'll get a step down each quarter of this calendar year, and December 31st, 2023, all increased FMAP funding is ended for the state. Next slide, please. Redetermination timeline. So as you've heard, April 1st is the first date that we can remove folks from Medicaid that were under the continuous eligibility provision. The omnibus bill contains several requirements that the state must meet in order to start conducting the Medicaid reviews and removing people from the rolls. CMS had issued us some initial guidance in late January, and I actually can do a late-breaking update since we published these slides, but actually yesterday we were able to have our technical assistance call with CMS to go through all the provisions in the omnibus bill that we must meet prior to starting reviews. We got answers to some questions. One more small item we need to meet with them on next week, but for the most part, we believe we are in compliance compliance with their requirements, we have to submit a plan to CMS by February 15th. But now that we've had our technical session with them, we're going to be able to finalize that plan and get that submitted by the 15th of this month, which will then allow us to start our reviews process. Currently, right now, with the timing of us getting the plan to CMS on February 15th, again, didn't have this in the presentation just because we didn't know when that technical session would happen, but since it's happened and our plan will go in, we are planning on, in the month of March, we will begin to send the first notices to Medicaid members that they need to complete their review. Which would then mean May 1st would be really the first date in Kansas when we would see folks terminated from the rolls. The last slide in my presentation is just really as a reminder of kind of the provisions of the continuous eligibility, the few reasons that we could terminate folks from the rolls, and then just as a reminder of kind of the comparison of our eligibility numbers from February of 2020, right before the public health emergency started, we were just shy of 406,000 folks on the Medicaid rolls, and as of December 1st of this year, we were just a little over 533,000 on the rolls. And with that, Madam Chair, that's the end of my presentation. I will stand for questions.
Committee, do we have questions? Representative Ruiz.
Thank you, Madam Chair. I'm trying to take notes. I'm typing at the same time. I'm not a fast typer. Can you give the timelines again of when the first notices are going to go out?
Yep. Madam Chair, Representative, yes. So we will be starting. So I'll kind of just outline what the process was for the omnibus bill. First step was we have to be able to submit our plan to CMS. That will go in on February 15th. That will allow us to begin sending our notices to individuals to that it's their turn to start their Medicaid review, and those will be mailed somewhere around March 13th. That week will be when the first notices will go out, and then they have a specified time frame that they have to respond to that notice, and then if they respond, obviously we would work that review and determine coverage, and if they do not respond, then in April we would run what we call a discontinuance, but essentially run the system process that would allow us to end their coverage, so they would be no longer on the Medicaid rolls as of May 1st.
Additional questions? Okay. Representative Ballard.
Okay. I guess I've gotten confused about it a little bit. Okay, so the omnibus is one thing, but then I probably should have asked Ms. Furlick about this when she did before. All right. So if the cutoff date is April 11th, right? Am I looking at it for the emergency?
Yeah, Madam Chair
May.
and Representative, yep. So, yeah, so the omnibus bill essentially made the public health emergency in one swim lane, and continuous eligibility for Medicaid is in a separate swim lane, and their dates do not align anymore. So April 11th was in January. The president extended the public health emergency till April 11th. And then just recently, he declared an end to it for May 11th of 2023. But because the omnibus bill basically pulled the continuous eligibility requirements away from the public health emergency, that date was set in that legislation as April 1, 2023 is the dates that states could begin ending the continuous eligibility requirements. So yeah, they're two separate.
Okay, so they can begin ending, but they still have the 12 months.
Yes.
That they're able to take them off the rolls.
Yes.
They don't have to meet the May or the April deadlines.
Yeah, April, yep. sorry, Chairman, Representative, you're absolutely right. April 1 is the first date that we could remove someone from the rolls, but we get 12 months to initiate the reviews.
Okay, maybe in an explanation, not as a criticism to you, but maybe for us, when we explain to people, those are the cutoff dates, but that doesn't mean at that date you get nothing. You have that 12-month period of time in order to remove, what is it, 150,000, whatever it is that we have to remove.
Yes. Chairman, Representative, yes, you are correct. So we have 533,000 members that we have to conduct a review on over a 12-month window. And the way we're approaching it is we will just run our normal reviews process like we did prior to the public health emergency. So every month, if your review date, for instance, April, was April 2023, we will send you a notice in March telling those members whose review date is April 2023, it is now time for you to submit your information to be reviewed to see if you're still eligible. Then in April, we'll send it to the folks who have a May review date. And yes, we will do that for the next year.
So that's on your due date, so that can go through, so you don't have to get everybody at the same time.
Yes.
So in other words, you're going to be working all the time.
Yes.
Just trying to get them.
Yes.
All right. Thank you very much. Thank you, Madam Chair.
Our last question, Representative Carpenter.
Thank you. I just wanted to make clear, so it's on their eligibility date when you review that, so it's.
Madam Chair, Representative, getting into the weeds a little bit. So prior to the public health emergency, everything was tied to you became eligible for Medicaid in April. Your review date would be the following April. Since we've had 3 years of the public health emergency, what we've been doing is every time it was extended, we moved their review date by 4 months.
Oh, okay.
And so no, anymore, it does not align for everybody. It doesn't align with the date that they, the month that they gained Medicaid eligibility, though historically that's what it was. So yeah, review dates now get in a little bit into the weeds of.
Well, I'm sorry about that. I did not know that because I thought it was going to be an annual, just like their due date or their eligibility date was before. The other thing is, I had a meeting with Conduit, and they have been reviewing these folks every month, just like they should have been doing, even if we didn't have. Is that correct?
So what was happening, Madam Chair, Representative? So what was happening during the public health emergency? We did not make any system changes, and so we allowed, we call it the reviews batch, but we every month allowed that to run. And if we were able to, we call it a passive review. So when we run that batch, what it does is it goes out and it tries to match income. It tries to, you know, we have a variety of matches that we do, change of address, income, there's a whole slew of them. And if we can match you, so we find information for you and we're able to determine that you're still eligible for Medicaid, we grant you another year. We continued that process. No one had to touch those. We would just send a letter to the member and say, here's the information we found on you. If anything is different or you want to correct anything, you may send us information back, but you are eligible for the next year. That's the process that we have continued during the whole public health emergency. What we weren't doing is if the information would say you're no longer eligible, or we would have normally mailed you a review because we couldn't match anything on you, we did not send those because, of course, we were keeping people on the rolls.
Thank you for that.
Thank you so much.
Yes, thank you.
And committee, we're ready to move now from testimony from the Kansas Department of Aging and Disability Services, beginning with Secretary Laura Howard. Secretary Howard, welcome to committee.
Great. Thank you, Madam Chair. Pleased to be here with you, with my team members today. I'll also be relatively brief. I wanted to focus my comments on a couple of updates from some work that happened during this interim period in particular. So I'm starting on page 2 of the slides. I'm going to talk just briefly about an update on the Regional State Hospital project, the community support waiver, and just mention a couple things in the governor's budget that I think you heard some things about this morning. So first, on page 3, the Regional State Hospital project. We were very pleased to participate during the interim with the Special Committee on Mental Health Beds, and we're very pleased to get the recommendation from that committee for the State Finance Council to release the $15 million that had been a topic of discussion throughout this session last year and the summer. The Finance Council did release that $15 million to KDADS on December 21st so that we could begin our planning regarding the Regional State Hospital project. We began to move forward on that. We've hired a project manager now to work on the project. Some of you may know her, Melinda Gall, who used to work with the Speaker's office. So we've hired her at KDADS to be the project manager related to this project. Just as a reminder to the committee, the plan is for 25 beds for acute inpatient psychiatric, 25 for forensic. The committee did make strong recommendations that as we are working closely with the county, as it would relate to the site or the facility, that there be space for future expansion, should that expansion be necessary. There was also a recommendation from the special committee that I imagine the appropriations committees will hear from stakeholders on, related to the possibility of a fund to reimburse hospitals and jails that are observing patients waiting on transfer to state hospitals. But again, mainly wanted this committee to know that we are moving forward. We've hired that project manager, and we're beginning to talk to the county about those next steps coming out of the interim committee and the actions by the State Finance Council. The second thing I wanted to talk about briefly on page 4 and on page 5 of the handout has to do with a request that was made for some follow-up information from KDADS in the report from the Special Committee on IDD Waiver Modernization. Those of you who were on that committee, spent time this interim really looking at the whole issue of waiting lists within the HCBS programs, particularly focused on the IDD program. And one of the recommendations from that committee was that the state should pursue a community support waiver. And so one of the requests to KDADS was that we come back with a fiscal impact statement for each of the services that the committee discussed that would be included in a community support waiver should such a waiver move forward in the state. There were some other recommendations that the committee made, including a cap on services at $20,000, and some things like that, as well as recommending some specific services and asking us to cost those out. So we've done some of that work and have come back, and this is just a really brief summary. We've made an estimate of a range of participants from 3,600 to 7,500. We would refine that further based on the waiting list study that's being conducted by the KU Center for Developmental Disabilities on our behalf. I'd also would note that there's a real emphasis in this on supported employment, as well as respite training and personal care options. We also anticipate an increase in the proportion of individuals who would self-direct under this waiver. The potential costs, based on those numbers, would range, if the waiver were fully funded at those levels of from 3,600 to 7,500 beneficiaries, would range from $72 million all funds, about 29 million SGF, to 149 million all funds, about 40 million SGF at that highest level. Now, of course, I don't have this on the slide, but obviously there would have to be a rollout of a waiver. I mean, and there's several pieces to this. Should the state move forward with a waiver, there's about a couple-year process to write, develop, go through all of the CMS pieces that this committee talks about all the time. To even get a waiver approved. And then obviously, as we look around at other states, I think there has to be kind of a reasonable rollout in terms of the network capacity. So, for example, if if the state moved forward and a waiver was approved and it was beginning, it might be reasonable, for example, to add 500 participants in the first year at a cost of about 4 million SGF, maybe 1,000 additional participants the second year. So again, I just wanted to share just briefly, we've done a little bit more detailed analysis, and on page 5, you can see the costs for each of the services that the interim committee recommended. But I know this committee's talked about this issue a lot, and I wanted to give you just an update on that request that the interim committee had made to us. The last thing I would just mention, and I'm not going to go through these, but on page 6 and 7, we just showed some of the enhancements the governor has recommended in the budget. And I only put those in here because there's a few that I think you heard even this morning from some of our stakeholders that relate to issues we've talked about here. I would just point out a couple that the budget committees will get to dive into on page 6. Towards the bottom of that page, automation of the care pass-our process. As you know, and you'll hear more about it from Deputy Commissioner Atkins this afternoon as it relates to care pass-our and our work to eliminate the backlog. But we appreciate the funding to pursue an automated system, and have already begun that work with KDHE, and I think Drew has additional updates on that. And then on page 7, maybe just the first 3 items, just some of those additional challenges on the rate side. I think you heard this morning about targeted case management. There are recommended increases in the governor's budget to the TCM rate, as well as to the rates for brain injury facilities, and to standardize HCBS rates as well in a number of categories. So again, I won't go into those in detail. I know the budget committees will have ample time to dive into that, but I just wanted to give those maybe recent updates to some things that had really occurred since kind of maybe the last Bethel and maybe since some of the last interim committees. I'm happy to stand for any questions now or at the close of the KDADS presentation.
We will take those questions now. Committee, any questions for Secretary Howard? Representative Ballard? I'm sorry. If we're going to do that, why don't we wait till after the rest of the testimonies for your question? That'd be all right. We could ask Secretary Howard to come back up. Yes, Representative Carpenter.
Thank you, Madam Chair. Thank you, Secretary, for being here. Many of you might know this is a little bit of a labor of love for me, and I appreciate everybody's hard work. I tell you, we had the most incredible interim committee, 36 tons of roundtables, just input like you can't believe. And staff, Orida, they were short-staffed, and they pulled people out. I have no idea. We had 7 states testify, but it's a great job, and I've had this ran by me here just the other day. We met, and I'm so happy with it. And the other thing that I say, the 500 people a year is really realistic when we talk about the workforce challenges that we still have in the ID and the DD community. So it's going to have to, we couldn't roll out the whole thing at one time if we wanted to, but I'm just glad to see that it comes in at a deal. But anyway, that's all I'll say about that. One other question very quickly. So the $15 million for the state hospital, when will they get that money? I met with the county commissioners the other day, and I saw now that it was approved by the State Finance Council on the 21st. And so they're waiting on this $15 million for them to move forward for architect's fees and site location and all that kind of stuff. So I said, you haven't got that money yet? No.
I don't have a specific date, Representative, but we're having conversations with them and working on that contractual agreement with them. So I can get back with you on an estimated date, or Deputy Secretary Bruner might have one when he testifies a little bit later.
Okay, thank you. Thank you, Madam Chair. Sorry for.
No, fine. Senator Fagg.
Thank you, Madam Chair, and thank you, Director, for your presentation. Has there been any conversation about like rural hospitals and telehealth? I was in one that had a whole wing of empty beds, and they would take a mental health patient into a room, telehealth, I think, with the doctor, and had a nurse there. And I thought, that's kind of an innovative way to handle that. That might help. And I just wonder if there's been any conversation in that area that might relieve some issues that way with mix-around. So you might comment on that.
Yeah, thank you for the question, Senator. I think that's a really valuable question, both in terms of workforce and in terms of just rural issues. You know, there is a lot of telehealth collaboration that goes on right now within the behavioral health world through our community mental health center networks, through KU, that allows some of the sorts of things you're talking about to happen at rural hospitals across the state. We have had some conversations at different points in time. For example, when we rolled out the state institutional alternative beds a couple years ago, I mean, looking at where we may be able to access psychiatric beds at regional at private hospitals across the state. We did have some conversations then. I mean, I think that the challenge for some of the rural hospitals that didn't actually have, you know, actual psychiatric beds was that they needed to do more things than just what the telehealth option would provide. And so we've had some good conversations with some of those hospitals. We still have some continued dialogue, but the ability, yes, to use telehealth around access to psychiatrists and things is also something that's really valuable to us. You know, for example, at Larned State Hospital, where we're able to do some things through telehealth that we weren't able to do before. I think it's critical to keep pursuing as we look at those workforce challenges.
Thank you.
Representative Landwehr.
So Secretary Howard, how does this work if the decision, because there was discussion on the whole mental health bed process of, you know, possible privatization of running it. What if there's an entity out there that wants to be the entity to run that and they're already finding sites? Do we know, are they working in conjunction with the county, or how's that going to work so that we don't have one entity goes out and finds a location and maybe that's not the best one when the other one found one that was more superior to that?
You know, what I anticipate, thank you for the question, Representative Landwehr, Madam Chair. What I anticipate one of the early steps that will take place from the county will be some type of an open process that has to do with, you know, kind of site selection that may include something related to kind of operator selection. One of the things the committee asked us to do in conjunction with the county is to make decisions about whether or not this would be directly operated by the state or through a private provider. You know, part of getting the information to do that, I think, is by getting some proposals in about what's out there. So I anticipate, Representative, that kind of one of those early processes would be designed to identify what some of those options are. And that's part of what we'll be talking with the county about is how they intend to kind of manage that process. But even in our earlier conversations, that's certainly what they intended to do. And it fits very well, I think, with previous processes they've used around some capital projects.
I just don't want us stepping on each other's toes and then ending up with something that's partially there, because I think there was a strong feeling from the committee members that, yeah, it might be 50 beds, but that expansion beyond 50 beds, I think, has got to just be a huge, huge piece that's laid out in there, because I'm not even sure, Madam Secretary, if 100 is enough. Can we staff that? Not right now, but that's where we have to be.
Yeah, definitely, Madam Chair. And that's why we mentioned on that slide that, I mean, that was a clear direction from the committee that there be the opportunity for expansion at whatever location, site, facility is identified or built. So thank you.
And our final question, Senator Baumgartner.
Thank you, Madam Chair, and thank you, Secretary. In your presentation, one of the things that you spoke to in the governor's budget is the funding of 2 FTE positions to support problem gambling prevention efforts because of the sports betting. Is that accurate? The price tag for that is $1.1 million for the fiscal year?
Thank you for the question, Senator. The description on the slide probably needs to be expanded. What the governor's budget did was expand the availability of funding overall for KDADS to spend towards problem gambling. And that also included funding for 2 FTE positions. So clearly the 1.1 million is not just for the 2 FTE positions, but additional funding around the kind of outreach we would do, additional treatment and things like that. There was some recommendations that this legislature made about a year ago in terms of prioritizing resources towards problem gambling from the problem gambling fund. And this in many ways kind of fulfills those directives from the legislature, Senator. But again,
Okay,
no,
and
at 2 positions, not 1.1 million for 2 FTEs.
Okay, and I assume you'll give us updates on how large the problem is of problem gambling with the sports betting. My other question has to do, I don't see anywhere where there's funding that would go from your agency to local communities that are paying for individuals to be in our jails, our county jails, because of the delays that are exceeding a year for them, the individuals to get into Larned for evaluation. Where is that going to show up, and how are these local communities going to be assisted with that?
Yeah, thank you for the question, Senator. You know, that was a recommendation that came out of the interim committee on mental health beds. The timing of that recommendation was subsequent to the time that we as an agency submitted a budget and budget appeals related to a governor's budget. So that's what I was alluding to earlier, Senator, that I imagine that there will be further conversation about that during the appropriations process during the session.
Okay, thank you. For our more rural communities, I mean, there is not that budget to be to cover those costs. Thank you, Madam Chair.
Thank you, and thank you, Secretary.
Thank you.
I'm going to go in the order that it's on the slide. So let's
Perfect.
go next with Mandy Flower, Interim Commissioner of Long-Term Care Services and Supports. Mandy, welcome to committee.
Thank you, Madam Chair. Good afternoon, committee. I am Mandy Flower. I am the Interim Commissioner of Long-Term Services and Supports here at KDADS. I would like to turn your attention to slide 10. We will begin talking about aging as well as the PEAK program. With our PEAK program, KDADS and the K-State PEAK team are going to start on-site visits again in February and run through March. We are looking and working with our rate-setting contractors. We've been asked, and we met with several states across the country to provide guidance and answer questions about the Kansas PEAK program. And the goals for the PEAK advisory group that they're getting ready to start working on are to increase input from residents and workforce, and how we can improve PEAK and improve these systems and services to improve person-centered programming in our nursing facilities. In January and February of March 22, KSU PEAK conducted Zoom survey interviews with direct caregivers in PEAK participating nursing facilities to learn more about their experience of working during COVID, what kept them there during COVID as we've seen the DSW workforce crisis. The purpose of that was to see if folks were staying in their jobs, considering leaving, and what was really driving that. And KSU PEAK discussed these situations with nursing, staff, social workers, housekeeping, dietary, everyone in the nursing facilities. The themes of that data have been highlighted, and they're going to begin compiling that into a report in spring after the 2023 on-site visits. And we're looking forward to getting that information as we continue to find what's going on as much as we can with our direct support workforce and the crisis and challenges that our stakeholders are facing. We also have some direct staffing exploratory items going on to see what's going on with that DSW crisis on the HCBS side as well. So we look forward to having that information and being able to compile that so we can see if we can find any trends that are getting people out of this, as well as trends as to who becomes a direct care workforce member. And we will continue working on that, and we will provide you updates with what we find out. For fiscal year 23, there's been an increase of 36 nursing facilities in the PEAK program. And as you can see, during COVID and the year after, our nursing facilities participating in PEAK went down a little bit, but as you can see, the trend is starting to go back up. Our nursing facility program updates for Q3. At this time, there's one facility in Topeka in receivership, which remains unresolved and for sale. 4 facilities closed in November and December of 2022. These facilities were located in Cloud, Montgomery, Sedgwick, and Stafford counties. These 4 facilities had a total of 146 licensed beds. No facilities were open during this reporting period. We also are still working on with the Recovery Office on the $15 million ARPA funds allocated by the Kansas Legislature for our nursing facilities. There are 278 facilities included in these rounds for a total of a little over $13 million that's gone out to our nursing facilities. 37 facilities are still working to receive their UEI with ks.gov for eligibility, and our nursing facility team is working with those facilities to get that accomplished. Disbursements are due to close at the beginning of March, and exit surveys for this funding will also have questions regarding benefit of disbursement to agencies. So we'll get some more feedback as to if this helped with retention and recruitment in our nursing facilities as well, so we can provide updates on that information as we get that. We are beginning our new nursing facility rate setting contract. The prior rate setting request for proposal was updated to make updates and revisions, and the request for proposals was posted on the 19th of December, and our RFP was submitted and answered when we had the questions in January of 2023, and the closing date of the RFP is February 3rd. We've also, for our nursing facilities and NFMHs, we had a rate increase for the VIN program that we're working on. It is effective 1/1/23, where it was posted for public and tribal notice on December 15th, and we're waiting informal questions from CMS. So we're working on that rate increase for our VIN program as well. I will now move over to a home and community-based services. Our waiver enrollment as of January 17th, we have a chart here. As you can see, our waiting list for the intellectual and developmental disability waiver is around 4,800, and our waiting list for our physical disability waiver is a little over 2,500. In January, our IDD waiting list, we have done an offer round for 60 people, and that offer round is for people who went on the waiting list 10/15/12 to January 8th of 2013. PD is also doing an offer round this week for 300 people, and the average time on the physical disability waiting list is approximately 2 years. Next slide, please. In addition to the day-to-day management of the waivers, we're continuing to work on the following initiatives: the FMAP enhancement projects, final settings rule compliance, and waiver amendments for telehealth virtual delivery of services, paid family caregivers, and our autism and SED renewals that are set to renew here in 2023. With our enhancement projects, we still are working on these, and our project focus is on workforce, employment, and access to care. We have completed the sequential intercept model, which Deputy Secretary Bruner was discussing earlier. More late-breaking news, we have gotten the initial rough draft of the report from that conference from our consulting agency. We have not had a chance to look at that yet. We got it early this morning. So we will be providing you information from that report as well. And while we've completed the SIM, we have developed several stakeholder groups that we're working with to really identify ways that we can start getting all of the systems to work together. So when a person has an issue with courts or gets arrested, we can determine what services, what can we do, and coordinate with agencies such as DCF, the police, sheriff, courts, so we can help this person get the services they need before they end up needing to be institutionalized or put in jail. We also have been doing a lot of work on the Employment First initiative. Our Employment First stakeholders have been a great assistance to us in the development of the RFP for Employment First. The state of Kansas applied for the NEON Award through the Office of Disability Employment Policy. 10 states were awarded that technical assistance, and we were one of them. We're going to use this technical assistance to enhance the work that we're doing with Employment First. We are going to be using this to, I think there was a question earlier about rate settings for supported employment. We're going to be using this technical assistance to look at some creative ways to do rate setting for supported employment. The technical assistance is also going to help us build the foundation and the supports we need on how we can let employers know the benefits of hiring folks with a disability. We will be receiving 100 hours of technical assistance for that employment technical assistance program, and it's based on the goals and needs of our state. And so we're going to be working closely with these stakeholders that helped us with Employment First so we can really find out what's going to help Kansas get supported employment, get Employment First really going. We're very excited about that because we feel that everybody who wants to work should have that opportunity, and it's of great benefit to Kansas as a whole. We're also working with stakeholders to develop a technology RFP. I think there was discussion earlier about how technology can help folks be independent. Our stakeholder group is talking about things such as smart homes. They're talking about devices that will have an automatic timer to remind you to take your meds, a whole bunch of different wonderful ideas that will help increase the independence of the people we serve. While we're still working with stakeholders, we are anticipating probably developing that RFP in the next month so we can get that out. Also wanted to give an update on our KDADS waiver amendments. We have currently in process our telehealth virtual delivery of services waiver amendment and paid family caregivers. Director Fertig talked a little bit earlier about public health emergency and Appendix K. I think out of these amendments, the one that is probably most prominent on folks' minds, Kansans' mind, is paid family caregivers. We are going to work on that amendment. It's currently allowed during the public health emergency where a parent can get paid to support their child. This has been really beneficial, especially with the direct service worker crisis. So we are working on that amendment to get that to be a service that's allowable after the public health emergency is over. And we're working closely with CMS on that, and they have assured us that we should have completion of that before the public health emergency expires. So parents who are working with their family member, we will not see a lapse in that where we'll have folks that need to find a caregiver. And I just wanted to give a brief update on the status of each waiver renewal. We have something going on with just about every waiver right now. Our SED, like I said, our serious emotional disturbance, or SED waiver, renews in 2023, as well as our autism waiver. Our TA waiver renews in '23 as well, and we begin meeting with stakeholders with the help of Wichita State to find out what they feel we should be adding into that waiver, services that are needed, and how we can modify the waiver to better help families. And as you can see, we have several in 2024 and several in 2025. So we're staying busy with our waivers, and we're also waiting upon direction on the community support waiver to see what we need to do with that as well. Final settings rule. I know that Commissioner Penrod talked about this often. The deadline for compliance is March 17th of this year. We are working closely with providers to ensure that we're going to meet that deadline. We've also submitted a corrective action plan. We have CMS coming out to do a site visit for final rule right in the middle of March, around March 13th, and they're going to be visiting providers throughout the state to see how implementation of final rule is going, as well as how the state assess settings to be final rule compliant. They will be here for about 3 days. They're going to go around the state. So we've applied for this cap so we can have time. If they find things that we need to fix, we can have some time to fix those with our providers. We also have taken our compliance portal that used to be ran by Wichita State. We have taken that into KDADS. We're developing that, and we're still working on the cleanup with that. So all tasks are in-house now, and provider data is being currently migrated to Community Connections database. So from the Community Connections database, to the HCPS compliance portal. And we continue to work on that as well. And I should have had this in the aging section, so I apologize. Just a quick PACE update. PACE program is innovative model of care that integrates and coordinates care across all settings. Since 2022, KDADS has been collaborating with Midland PACE program to work on expanding their services to Johnson, Miami, and Franklin counties. And KDADS is still in the process of finalizing that expansion with Midland as well as with CMS. Blue Stem also opened an alternative care setting in Hutchinson in the later part of 2021. And that is the end of my presentation, and I will stand for questions.
Thank you very much. Committee, do we have questions for Ms. Flower? I have one. If we turn to 11, slide 11, looks as though 2022 and 2023, that the survey or participation rates by year was 132. And do I understand that correctly? Out of 278 nursing homes, that it included 132 visits?
I'm sorry, what slide did you say?
I'm on number 11.
Okay. With the peak participation, we saw it go down during COVID, and we also are starting to see an increase. And I believe one of the additional questions that we were asked from last committee was asking nursing facilities, why are you doing the peak program? And the facility said the reimbursement rate, when there's several tiers, so they get a little more money that helped them through COVID, and also it's the right thing to do. Our PEAK program is looking at how we can make person-centered practices a reality in all nursing facilities in conjunction with working with K-State. So as we see that increase, we're very hopeful and excited that we can continue to make person-centered practices a reality throughout the state.
Do we have other questions? Oh, yes, Representative Carpenter.
Couple of things. So on that, applying
Whatever the direction legislature tells us to do, we will do it. We are already starting work on that. We've been talking to stakeholders and also having internal discussions about community support waiver. So we're getting those initial steps completed so we can be moving forward on that. For the FMAP projects, right now we're working with stakeholders to really find how we can utilize these funds to really meet their needs, because they have very unique challenges right now after COVID and now that we're going into the endemic. So we're working with stakeholders to try and develop some new initiatives, and we're really going on based of what they need, what they're telling us that our communities need.
The only reason I ask that is because we're going into the budget process right now, and it'd be nice to know what you were planning on spending that money on.
Okay.
And so I've been working on this for a number of months here, and, oh, sorry. Thank you for that. I've been harping on this for a number of months, but going into the budget process, it'd be nice to know what you plan on spending that money on.
Okay.
All right. Thank you, Madam Chair.
Senator Fagg.
Thank you, Madam Chair. Thank you for your presentation. On page 17, you talk about projects in procurement, and you list like 4 or 5 of them there. When you set those up, do you have measurable goals that you set to that? And then do you go in and review performance on them? And then do you report back? It'd be interesting exactly what your goal was, what you actually did, so that we can talk about cost effectiveness and service efficiency for the people of Kansas.
Absolutely. For example, we're working on the waiting list study right now. Our FMAP team is meeting with University of Kansas monthly to talk about the study and what the current status is, and we can update you as we go along with that. For the projects in procurement, same thing. The RFP has very specific goals on what we want to achieve, and we will be reporting on that as well.
Committee, I have one quick question, because I knew we need to move along. Could you be able to tell us exactly how you're planning to expand PACE in Johnson County? I understand they were seeking some Spark money, and now there's a possibility of some FMAP money.
Yes, as Secretary Howard says, I might have to phone a friend and see if the secretary can help me with that.
Thank you, Madam Chair. I mean, Midland Care has been working actively within their own organization around resources related to expansion, and has been talking within Johnson County about possible locations and things like that. They did make a request for $2.5 million through the Spark process. And within the Spark process, we at KDADS have been awarded a tranche of funding from the health and education bucket that we then need to that we then need to put out in another open process. That's kind of the direction coming out of the Spark for all of that funding. So we'll be doing that. We've continued to talk with Sean Sullivan, the director at Midland, about the possibilities. I mean, we're in support of the additional resource for him and through one of these buckets. So, I mean, I think that's probably the easiest thing to say today, Senator. We've been in close contact with him.
Thank you, Secretary.
Madam-
Real quick.
Madam Chair, Madam Secretary, just how much was that bucket?
So the health part of the health and education bucket that KDADS through the Spark process has been asked to manage is $66 million. There's a lot of projects connected to that, including the Spark portion of the regional hospital beds. So again, a number of potential projects there. We are in the process right now of finalizing the agreement with the recovery office, after which we would then need to put out kind of an open application process for entities to make application. Kind of the way the Spark process landed. I mean, even though folks had applied through that process, we kind of need to go through that additional open, transparent step. That was the recommendation for all of the Spark funds that came through the process. So again, but we'll be managing kind of that health tranche of $66 million.
Madam Secretary, we have one more question for you from Representative Landwehr.
Can we get a list of the items that are sitting in that bucket? Because I heard the other day that there's a portion of that money out there that may be there for the DO school in Wichita, and I'm trying to understand, okay, that school's up and running, so what are we trying to give them? What are they looking for from us?
Representative, we're happy to talk to the recovery office about that and about, there were some priorities that came out of the Spark subcommittees and the advisory committees as we would then open up the process for people to apply. But happy to respond back to you in the committee on that issue more definitively.
Well, and just so you know, from appropriations perspective, we've had difficulty getting responses back from the Office of Recovery on what's going on that. And we found out that there was a pot of money that was parked over with KDADS, and we don't know the details on it, and we're concerned that maybe other agencies are in the same boat. I'm not expecting you to respond on that. That's just a comment, Madam Secretary.
Yeah, all I would say, Representative Landwehr, is that when the Spark process completed and all of the legislative approvals happened late in the calendar year, different portions of funding were identified to be managed by different entities. And the Recovery Office is going through formal agreements, went through formal agreements to transfer those blocks of funds to those agencies, and we would then go through kind of those formal processes to seek proposals.
The problem that we're having is that we've been left in the dark because it was our understanding, and I think Representative Ballard was on that committee, or is on that committee, is that there was about 800 requests made by all the subcommittees that went all back to the executive committee, and then the 800 were just ignored. But now we're finding that, well, some of the 800 were paid attention to, some of the 800 were not, some people haven't been notified, so we're just real concerned on what's happening with that Spark money right now. So, I mean, that's not on your back, but the more detail we can get on what that pot of $66 million is would be helpful to approach.
Thank you.
Thank you, Madam Secretary. We have 3 more presenters with the Kansas Department of Aging and Disability Services. And in the sake of time, if you could please keep your presentation close to 5 minutes and give us time to ask questions at the end. And we are announcing Drew Adkins. Is that correct? Great.
That's correct, Madam
Thank you,
Chair.
Drew.
And certainly feel free, Madam Chair, members of the committee, to buzz me if I drone on too long, certainly. I'm going to start, apologies, Drew Adkins, Behavioral Health Services Assistant Commissioner. I'm going to start today talking about psychiatric residential treatment facilities. I won't go too in-depth with this. I'll read off some of the data we have here, and you have that in front of you. The current MCO wait list as of January 26 of this year was 76. Of those 76 individuals, 36 were in foster care, which is up 11 from our previous report. The number of licensed PRTF beds is 424. 162 of those beds are not being used. Our current census total is 262, and of which are 85 are foster care youth. I'll pause to see if there are any questions before.
Would you mind going ahead and continuing, and then
Yes,
we'll ask
absolutely,
questions at the end? Thank you.
absolutely. Just wanted to provide a quick update on the Camber-Hayes children's psychiatric beds. KDADS contracted with Camber Children's Mental Health to open and maintain operation of a new facility through June 30 of 2027. The new facility will be in Hayes. It will have 14 beds for children's psychiatric inpatient hospital treatment, and the facility will participate in the state institution alternative program. And late-breaking news, Camber-Hayes has been cleared to start accepting admissions on Monday, this upcoming Monday. Moving on to our Certified Community Behavioral Health Clinic implementation and some updates there. Our CCBHC program staff within KDADS started baseline reviews with the first 9 CCBHCs in October of 2022. And we are actually wrapping up next week with their last review of the 9 original centers. We continue to monitor any barriers or issues that are mentioned about service delivery with the implementation of the model. We do have teams that are going out and doing site visits and baseline reviews to try and to help and provide assistance there. KDADS continues towards onboarding for the next schedule of CMHCs to become CCBHCs by July 1 of 2023, and that number will be 9. And I'll move on to CARE, our client assessment, referral, and evaluation program for pre-admission screen and resident review, PASSAR. Our 2022 CARE annual report is out, and it's on the KDADS website. KDADS continues to, and I know that Deputy Secretary Bruner spoke to this earlier, we continue to recruit temporary workers and assistants from internal BHS and KDADS staff resources to work on the Medicaid assessments and evaluations that are pending data entry. We have also actually been able to contract with one AAA to help us out with that, working on trying to get some additional resources from the area agencies on aging to help us with both the special admissions and level 1 assessments. We continue to work with all of the nursing facility associations, both the trade and professional, to keep them privy to what is going on, and also continue to provide communication to individual facilities as we have contact information for. We have also set up a monthly CARE office hours for anyone to join, facilities, staff, stakeholders to join and talk about any issues or barriers with the CARE process and provide feedback to KDADS and KDHE staff for that. And on the last slide, again, Deputy Secretary mentioned these. I'll go back over them. This is in response to some follow-up questions that we had at the November, I believe it was 2nd meeting. Our CARE backlog does consist of both the level 1 and level 2 assessments and evaluations. And we do believe that June 30 is a reasonable expectation of a timeline, if not earlier, to get those assessments and evaluations to be at a manageable level. Just some quick data points. Since our last meeting in November, the CARE team has been able to work through over 1,500 inquiries, that being applications requesting a level of CARE score response from our team. We have also been able to keep nearly roughly 300 responses to make sure that those applications that were nearing the 45-day mark away from that and keep that number down. And KDADS and BHS is extremely excited about the governor's budget recommendations to support a fully electronic CARE PASSAR system. This will revolutionize and streamline the efficiency of the program. And we did actually hear back from CMS this week. I believe it was Wednesday afternoon that we have gotten approval to start the preliminary process, which is initial funding from CMS, a Medicaid match for us to hire some additional resources, contract resources, and start work on crafting an RFP to provide an IT solution. Madam Chair, members of the committee, I think that's all I have, but I'll stand for questions.
Committee, we have a couple of minutes for questions. Representative Ballard.
Thank you, Madam Chair. When you talk about Canberra opening on the 27th, one of our colleagues on social services attended that, and he brought back some brochures and all, and he was very impressed with the facility.
Okay.
My question to you is, what is the age limit when you say it's children?
I could guess, but I actually might use that phone a friend option and see if Commissioner Brown is in the audience and would like to help me out with that. Or, I'm sorry, Commissioner Lacey Hunter.
Good afternoon, committee. I'm Commissioner Hunter with Survey and Certification and Credentialing. In particular, at Camber Hayes, there's two sides to it. So the private psychiatric hospital side does not necessarily have age limits on it other than the minimum of 6 years. And then on the PRTF side, those age limits are outlined by federal law from 6 to 21 years of age for their residents, sorry.
And that's 21 is considered children?
There is what's called the psych under 21 exclusion, and that is how a PRTF operates, is under those parameters.
All right, thank you. Thank you, Madam Chair.
Seeing no more questions. Oh, wait, one more. Representative Ruiz, sorry.
Thank you, Madam Chair. My questions are regarding the PASSAR screens on page 27.
Yes.
So there was a backlog on both level 1 and 2. And who completes the level 2 screens? Are those contracted out?
Yes, they are. We have a contracted vendor that completes those.
And what's the expectation of their turnaround?
I don't have those specifics, Representative, but I'm happy to get those for you. There are guidelines for that.
Okay. And okay, and then crafting on the RFP for a potential vendor, and that's going to be for the online. Is the level 2 also going to be online, or
Yes.
just the level 1?
Absolutely, Representative. Madam Chair, this will be the full system.
And so for the folks, sorry, last one. So for the folks that are waiting on those level 1s and or 2s, where are they, or what are they doing, waiting for the completions?
So, Representative, Madam Chair, we do have a process that allows for individuals, especially individuals that may be in a hospital, to come in through a special admission process. And so they're not necessarily in I would say, a purgatory. They're able to go into the facility. We work with the facility then to get a response back so that they can know and determine if they're able to, or what coverage they're able to get.
Okay, all right. Thank you, Madam Chair.
Thank you. Committee, let's welcome Lacey Hunter. She's the Commissioner for Survey, Certification, and Credentialing.
Good afternoon, committee. As she said, I'm Lacey Hunter with Survey Certification and Credentialing. I will go over some information that I typically go over for this group today. I don't have too many slides, so I will try and keep mine short. But if we can go ahead and move to the next slide, I can get started. In this first slide, we are giving you a little bit of an update on Senate Bill 453 that was passed this last legislative session. Through that bill, it expanded the people who can be a course sponsor for what's called the Nurse Aid Training and Competency Evaluation Program. That is what a CNA is. You must take that training course to become a certified nurse aide. So since that bill has passed, we have expanded the ability to have hospitals, hospice, and PACE as course sponsors. Of those additions, we have had a hospital here in Topeka, actually, we've been working with. They're now on their second pilot course as a course sponsor for the CNA training program. At this time, we have not had any PACE or hospice providers reach out for applications. We did have 2 other hospitals who had initially requested information on becoming a course sponsor, but rescinded their request once they saw the curriculum for the course. We do continue to work with stakeholders and continue to have regular meetings to find ways to ensure that we are opening the direct care workforce door as broadly as we possibly can. Next slide, please. This next slide goes over a little bit of the COVID-19 waiver allowances that the federal government had, as well as here in Kansas. One of the big ones was the ability to use a certified nurse aide who had had less than the required hours of training. That was allowed through October 6th, I believe is the date. 2022 would be the date that they would have had to been trained by, unless as a nursing facility, they applied for a waiver that you can read about here on this screen. The waivers then allowed for those nursing facilities, and then our House bill that was passed last session, House Bill 2477 in conjunction, allowed for those nurse aides to work with the less than required hours of training for the nurse aide training and competency evaluation program. The provisions of House Bill 2477 expired on January 20th of 2023. So the waiver capabilities that are outlined in the federal level, as well as the capabilities within that House bill, have since then expired. At the date of expiration, we do not have a count on how many assisted living or state license only homes were utilizing the temporary nurse aide program. However, we do know that there were a total of 9 nursing facilities that were using the program up into that date. And then the last piece there, it is a little bit different. I'd put in there that the public health emergency had been extended for another 90 days, and that has since changed. That would put it out of April 11th, and the Biden administration has since then said that it will expire on May 11th. The next couple of slides are ones that I have been giving regularly, and they're just updates to some graphs. This first one here is our direct care workforce and the number of courses. So this is the number of courses we as an agency approved throughout the past couple of years. As you can see, we're getting back up to levels that we were at pre-COVID, not necessarily, but 2020 was probably the worst year since so many things were shut down. We're not quite to where we were in 2021 for 2022, but hopefully in 2023 we can kind of continue to see that go back up towards those levels there. The next slide talks about the actual number of individuals who took the courses on the first slide, but then after they completed the course, they took their training and actually came and got certified or registered their certification with my office. So they physically took that certification and went and got it. And the numbers and differences that you sometimes see there, especially when you're looking at the CNA one, is that sometimes once a individual receives their CNA training, they don't actually go get certified as a CNA. They step right into the CMA training and continue on up the healthcare portal field for their job lineage. The next slide, I'm going to switch a little bit. The next slide is not nearly as great as Ms. Mowbray's maps for this morning, but this covers the number of adult care home beds that have closed over the past 5 years. So much of the information given this morning was based on a facility count. The difference in my information is not necessarily, it does encompass all of those facilities that they discussed closed, but it discusses them in a representation of how many beds they had when they closed. This also then represents the number of beds if there has been a reduction in the beds. As you can kind of see, we do have some trends, especially with the nursing facility beds, that have had some very large increases over the past couple of months and over the past year or two. The next slide is my last slide, I believe, but it kind of does the reverse, and it goes over the number of adult care home beds that have been opened in the past 5 years. I believe that's all I have. Are there any questions?
Committee, do we have any questions? Seeing none, thank you so much. And our final presenter is Scott Bruner, Deputy Secretary of Hospitals and Facilities.
Good afternoon, committee. I just am going to make a couple of comments about state hospitals. One of the items we provide an update on is recruitment and retention of employees. We've shown you this graph over the last couple of months, trying to show the number of vacancies by number of positions vacant in our mental health disability techs, or our frontline direct care workers, our nursing staff, and our safety and security officers, kind of the three categories of staff that have the most daily interaction with patients and people that we serve. This shows for all four of the state hospitals the number of vacancies in those categories, and there's a line around the 1st of January that indicates when the first pay period that the 24/7 pay plan differentials took effect on people's paychecks. And you can see that for the for KNI and Parsons and Osawatomie State Hospital, that had a pretty good effect on flattening out the trend of more vacant positions, or of more positions being vacant. Didn't have quite the same impact at Larned, although we've seen in the last few pay periods some change there. The next slide does that as a percentage of the total positions that are available, which kind of gets a little further from the actual position count. Larned is still at the top of the chart with 58% of the positions vacant. And again, that has kind of leveled off. We've seen a little uptick at Osawatomie in terms of the percentage, but that the holiday season was tough, in particular at Osawatomie, of keeping some of the units fully staffed and not as much turnover. On the next slide, just a couple of the initiatives that we're trying to move those numbers in the more positive direction. We do have a KDADS position that we filled to work with the hospitals on recruiting and retaining. The human resources teams at each hospital do a lot of work out in communities, at job fairs and schools and places where people are looking for employment, and we can be there as well. That is limited kind of to the communities where our hospitals are, so that our KDADS person can spread that around the state, and maybe reach a little bit further into Salina for people that might want to work at Larned, for example, or other campuses. And then the other item, we did make a request. There was a pool of Spark money that was available to state agencies to apply for efficiency and effectiveness grants, I think was the category. We put in an application to fund purchasing 2 live scan fingerprint machines that we could deploy at Larned and Parsons State Hospital, so that when somebody's applying for a job, we do require everybody to have a criminal background check. Our process now is to do a paper fingerprint. They either have to go to a sheriff's office or some other place where they can get their fingerprints taken. We have to get the card, send it to the KBI, wait for it to process and come back. With live scan machines that are in place at several DCF offices and other places, we can just capture that electronically. It goes, I don't know, automatically, but pretty automatically to the KBI, and we get a response much faster. And those few days of transmission time can make a big difference when somebody's looking for a job, wants to start right away so they can get paid. We can hopefully, once we get those machines purchased, we can shorten that time frame by a couple of days. On the next slide, we also provide updates on state institutional alternatives. These are private hospitals that we contract with to provide a state hospital level of care. The list is largely the same that you've seen, although we have added one hospital, Hutchinson Regional Hospital, that's in the process of onboarding as an SIA. They haven't started receiving any patients yet. They're still in the accreditation process, but they are moving along. And since we started this program in August of 2021, we've served 754 adults and 906 children through those SIA alternative locations. The map on the next page shows you where those places are. But I won't tell you how a map works. That's what's depicted there. And we also provide updates on lifting the moratorium at Osawatomie. That's been lifted since last January, so we're a little over a year. And that does allow us to admit voluntary patients to Osawatomie State Hospital. We did that under the context of having a census management cap. So we look at our total capacity, and as long as we have available space over 85% of our bed capacity, we can take voluntary patients. In that year, we've admitted 20 patients on a voluntary basis. to our Adair acute unit, and we haven't admitted anyone voluntarily to the osaotomy side. We also started, as part of the moratorium process, providing some social detox services as well in the Adair unit, and we've had 4 individuals admitted through that part of the program. We did want to add a little bit of information about the waiting list and waiting time for osaotomy. Even though we're admitting voluntary patients, there is still more demand than we have available beds. And so the chart here has a lot of peaks and valleys in it, but it shows the daily waiting list that we keep track of at Osawatomie State Hospital. It includes anybody who's waiting for an admission to osaotomy, so that includes patients who have an involuntary commitment order from a court. It could mean somebody who is on a competency evaluation referral from a district court as well. And it does include folks who may not have met all the criteria for admission. So they may still have a medical issue that we need to clarify, or their legal status is pending. This is just somebody who is on our list to track that may be a patient at Osawatomie State Hospital. And you can see it's varied a little bit over time, but it hovers between 15 and 30 patients on any given day. And it does that list does turn fairly quickly, and you can see that on the next slide. Where we take the amount of time people wait. This is the average length of time people are waiting by month. If we exclude those folks waiting for competency evaluation or restoration, so these are folks just waiting for an admission under a care and treatment case. So in October and November, our staffing was a little tighter, so the waits were a little bit longer, but they hover between 30 and 50 hours that somebody's waiting. And again, those could be waiting on medical clearance or some other legal process, and just waiting to be admitted where there's an available bed as well. And then the last update is on our, also in the spirit of lifting the moratorium, the legislature funded our remodel of the Bethell building to add 14 beds, or 12 beds total on the campus. Once we get that completed, we did award the RFP to a local for Osawatomie construction company. We've moved patients around, so the building is available for us to start the renovation. They are projected to start doing some of the demolition, or doing the demolition work this month. And when that all gets done on the campus, we'll have a total of 102 certified beds for adult inpatient treatment. And the timeline to get that construction done is about 12 months once they get started. And Madam Chair, members of the committee, that's my state hospital report. I'm happy to stand for questions.
Thank you. Do we have questions? Representative KanCare.
Thank you, Madam Chair. Hey, Scott, I was talking to some hospital folks from my district, and they said that that they've started, instead of paying the outrageous amounts charged by the temporary staffing agencies, instead of doing that, they're starting to just close beds, and they only have space for what they have the workforce for, which is kind of creating a pipeline of, it's an access to care issue. Sure. Are we doing that at the state hospitals? Are we closing any beds?
Not because of staffing. And we're at Larned in particular, we're to keep our capacity where it is, both on the psychiatric services side and state security program side. We're heavily dependent on agency nurses and CNAs in some cases, and some direct care workers that we hire through contractors to fill some of those MHDD roles. But at this point, we haven't, because that would be the impact. If we reduced or significantly dropped the number of contract staff, we wouldn't have enough to keep the beds open that we have.
And it would start backing up the ERs again.
Yes.
Okay, Madam Chair.
More than it are. I mean, that happens today.
Yes,
so
I know.
It would be, yeah. So
Boy,
it would be
I
a more severe case.
Yeah. So, oh gosh darn! Now I forgot my other question.
Oh, I'm sorry.
That's all right.
Representative Carpenter.
Representative Kincannon, maybe you'll remember this after Scott, what question am I going to ask?
It's usually one of two.
I'm going to ask how much money we spent at Larned State Hospital on contract labor.
Through the end of December, it was right around $24.2 million, something in that order. Since, if you add January, it was a little bit off that, but it was about $4 million in January. So it's about $1 million a week.
Thank you for that.
And Representative Concanon just said, that was my question. So we're all good there. I'm not sure if this is for you or for Secretary Howard, but you had mentioned the Spark funds as well. Do we have any idea on the timeliness of when those RFPs will be going out for these funds?
For the,
Any of the Spark?
any, of the- so of the
Dollars.
$66 million that's been distributed to KDADS, our deadline to get the project descriptions, that's the what's going to describe the funding, the projects that you can fund through that funding. Our deadline for that, or the final date to get those to the recovery office, is the end of February, the 23rd of February, I believe. We're going to be ahead of that. So my goal is to have our request for proposals, or whatever the RFP process is, done by that same kind of deadline. So we'll get it to the recovery office before that, so we can release it before the end of the month.
Thank you, and thank you to the KDADS department for the presentations today.
You're welcome.
Oh, I'm sorry. Yes. Representative Ballard, that's right. I promised her that she could ask a question of the secretary at the end of the presentations. Thank you for reminding me, Representative Ballard.
Thank you, Madam Chair. Thank you very much. I don't know if it's a question you may ask, but it's one that's been posed to me, and I'm posing to you. It has everything to do with not a decision you made, but that a judge made in relation to the 3-year-old child and foster care. And the judge ruled that the 3-year-old was to go to the family that had 3 other siblings. In the article, it was mentioned that you had recommended that the child stay with the parents that have had her since she was 3 days old. I had 3 requests yesterday alone, and I said, well, I'm meeting tomorrow, and I know the secretary will be there. So my question is, do we have guideline rules in terms of how long someone can be with a family? Or do they get first dibs on adoption if they've had them for so long? Or what's the next step if people are really upset about it? Because these 3 people were really upset, and I caught it as if I had made the decision.
So, Representative Ballard, thank you for the question. The first thing I have to say you won't like, because I can't speak to the specifics of this circumstance due to the confidentiality requirements around child welfare. As Representative Concanon knows, in her role, there was a lot of dialogue related to this in an executive session of the Child Welfare Oversight Committee. I can respond in a more general way to your last question. When youth are in the custody of DCF and the case plan goal is not reintegration, but it's adoption, there are provisions under federal law and state policy that put some priority on adoption with relatives. That's not a be-all and the end-all. And those policies also take into account who the child may view as a relative or as a sibling, those sorts of things. So there's process that takes place in child welfare in terms of how the recommendations that are made for the adoptive placement. That occurs through our case management providers. In those circumstances, which are pretty small, where there's really more than one identified resource, is what's called a best interest staffing. I would tell you that just in terms of data overall in our system for youth who are adopted and don't return home, About 48% of those are adopted by their foster parents. About 48% of those are adopted by relatives, and there's 2 to 3% that kind of fall into that other category. So again, most of those are adopted in some fashion with, as I said, it's split about half and half, but I don't have the ability legally to comment on the specific case that you're referring to.
And that is why I said it's probably not a question that you can answer, but one that I did say I would ask today, and I did. I guess I would say I thank you very much for your recommendation in terms of the family who had this particular child. I do not know these people for 3 days, but I know there's a lot of people really upset about, and I guess because of my own career as a psychologist, I look at that in terms of 3 years old. I think you can make changes in terms of months, but when you get to be 3, they're very cognitive of what's going on and where they have lived and what they have done. And I look at our mission in terms of to protect children, to put them in the best situation, to basically take care of them. And I think I'm about as upset as the 3 people that let me know they were upset. But I appreciate your answer very much. And thank you, Madam Chair, for giving me that opportunity to talk about this, because I think it's a very, I'll just say, unusual situation. And if I had to put myself in the place of raising someone, finish.
May I? And Representative Ballard, you and I have dealt with this issue for a lot of years, and as much as we'd like to think that this is unusual, it's not. This one here got publicity. There's been several cases in the last 2 or 3 years that it's similar. Now, hopefully, the definition of attachment that's being worked on gets resolved, and that helps this. Because as was discussed with other judges that I worked with, was we bring a baby into the system, they don't know trauma because they're too little to know they've been removed from their home. But at 2 and 3 years of age, we put the trauma on them because we take them from the only family that they've known, and that's their foster care parents. So it's not as rare as we think.
Since I have my composure, I would say thank you very much. I think that's what KanCare deals with and what we deal with in social services. And I'm sure last night was a very difficult night for probably both sets of parents, because the one where the child went and the parents had raised them. So thank you for allowing me this time.
And I would say, Representative Ballard, I have shared your tears over this, having served on that committee, having gotten to know those families. Very, very difficult situation. My question to the Secretary regarding this on a general level, is there ever any appeal once a judge makes this decision?
Generally, in this circumstance, there isn't the ability for an appeal. I think we have indicated publicly that that as an agency, we did make an appeal that is pending in a higher court right now.
Thank you very much. Representative
Madam
Carpenter?
Chair?
Yes, Senator Baumgartner.
Just after Representative Carpenter, I'll wait.
He has a different topic, Senator Baumgartner, so please continue.
Thank you, Madam Chair. And there are several of us that have, we have an overlap of committees and are familiar. What isn't clear is how do we, and this is a question for the Secretary, how do we make certain that the information that is given to the courts is accurate and the information that is published in soliciting adoptive families is accurate, because we know that with, as Representative Ballard has spoken to, I know Representative Concanon and Representative Landwehr are aware of this as well. Oftentimes, the individuals speaking in a courtroom have never met the child. We have guardian ad litems that have never visited in the foster home, and yet assessments and recommendations are made that is just not accurate to the situation of the child or the experiences that are going on.
Thank you, Senator, for that question. I mean, as you indicated, there's a lot of parties that participate in the court. I can take responsibility for the information that's conveyed by DCF staff or by our case management providers, those contractors in those courts. I don't have any connection or oversight as it relates to the guardian ad litems, as you all discussed kind of during the interim in terms of the role of guardian ad litems. So I don't necessarily have anything to say with that side of it, but certainly from the DCF side, it's incumbent upon us to be reviewing closely anything provided through our case management providers or that we provide directly to that court.
Thank you, Madam Secretary. Representative Carpenter.
Thank you, Madam Chair. My question is not for you, it's for KDHE. And so I have this slide here that Healthy Blue Kansas is advertising on the television and all that. Healthy Blue is ready to be the Blue Cross Blue Shield Medicaid plan for Kansas. So as we go out for this RFP, are we going to have everybody that's going to apply for that RFP advertising that and causing confusion in our Medicaid, with our Medicaid folks?
So, Madam Chair, and thank you for the question, Representative Carpenter. We're aware that there are a number of companies that are not currently KanCare managed care companies who are doing awareness campaigns, reaching out to providers, asking them to contract with them in anticipation of their bid for the KanCare RFP. I'm told by my staff who have been through this process before that that's pretty common to do some type of awareness campaign and outreach to providers and that type of thing. Typically, the state would not get involved in that. We don't have a contractual relationship with them. We have no authority to regulate them in that fashion. But, if it started creating problems or confusion with providers or with members, we would ask them to kind of dial that back. I'm aware of that advertisement. We have not received any complaints from providers or members expressing any confusion in that regard.
Very good. Thank you for that.
Representative Landwehr.
You and I spoke on this issue the other day, and as I went back and I started investigating what went on back then, that yes, there was advanced work done on providers. That's normal. Mm-hmm. And I've looked at other states as well. There wasn't public advertising to be the next Medicaid service provider done in advance. And I think that there's a lot of concern, there's a lot of politics that may be playing right now that's out of your bailiwick. I get that. But I think if I was this provider, I would cease and desist this right now. If they want to go out and talk to the provider networks and start building that, that's on them, and that's fine, but not advertising to the general public.
Thank you very much.
Thank you.
Committee, we're with our last group. We have our 30 minutes here, and I think we should do just fine with that. If each of you would mind going 5 to 7 minutes to give us time to ask questions, we would really appreciate it. And we're going to begin with Chris, is it Bierman? Perfect. Director of Community Development for Aetna and Better Health of Kansas.
Good afternoon, committee, and good afternoon, Madam Chair, and thank you so much for getting my name right. I that's probably one of the first times that that has ever happened to me in my life. So I'm very excited by that. And I dropped my notes here very quickly. So thank you again very much, committee, for allowing me to speak today about not only our value-added benefits, but also our language line services. And thank you for the questions that have led up to the presentation today. So the first thing that I've got to address for you on the next slide, thank you, is a story about a family that is made up of a mother and two children that are Ukrainian refugees. The father is still in Ukraine fighting, but we were able to get them involved with our language line services, helping them to get established as our members, and started talking with them about one of our value-added benefits that we call the No Place Like Home grant, which provides assistance by working with local community-based organizations, helping an individual with housing insecurity. And so our housing administrator referred to a service coordinator who then helped this family to navigate the healthcare system, were provided with up to $5,000 that we offer to allow them to identify and help out with preventing the family from being evicted and allowing the mother the chance to take classes to improve her English skills so that she can get a job and to solidify the family's income. So just a little example there of the combination of the topics that I'll be addressing today. The next slide shows our 2022 value-added benefits that I've covered before, so just to make sure that you have those. But if we can go to the next slide, this is the utilization that we've had on each one of our value-added benefits. Basically, the total number of units, if you will, for the value-added benefit, or how many times that it was utilized by members. And then the next column talks about the unique members that participated in the value-added benefit. And all total, the spend was at about $2.4 million in 2022 on our value-added benefit program. I can stop and take questions about any one of the specific value-added benefits if you'd like, or can go on to talk about language line. Okay. So the next slide talks about our language line services, and then specifically, this is just some examples of what we provide in our member handbook for our members. On page 2, it talks about the interpreter service and how we are able to utilize interpreter service in that way for our members. Page 3 of the member handbook talks about the different aids and services for folks with disabilities who need assistance as far as communication. And then page 5, which is located on the right-hand side, is the table that we provide in each one of our brochures that talks about how that members can access services and language services in their language. So examples there. The next slide talks about our website, which is completely 508 compliant. A member can access the website, and at the very top of the website, be able to switch the entire website from English to Spanish. And then we can also work with them, and there's, in the slide, there is a link to resources that members can go to learn about how to access information in other languages. So again, we work to do everything that we can to provide the needed services for our members. The next slide talks about how we utilize member communications. As far as written communications, all written communication as that goes by the KanCare regulations are provided in both English and Spanish, but we also can provide additional materials to members when they ask. So I checked with making sure that I was clear on the timelines. For any other languages other than Spanish, it takes us about 18 to 20 days to get the member handbook translated and sent out to a member in a language that they need. Brochures takes about 4 to 5 days. For Braille, it takes about 7 to 10 days for the member handbook to be put into Braille, and for any other information, about 3 to 5 days. Now, we do offer CD-ROM. We've not been asked about that yet, but I did find out that we anticipate that it's about the same timeline as far as providing services in CD-ROM. At the bottom of this slide, we talk about our language services utilization, and we supported over 4,000 interpreted calls and provided services to over 4,000 in 2022 across 43 different languages. And when we surveyed those individuals, 96% of them rated us a 4 or a 5, which we feel is very good for the service. And actually the top, if you would expect, the top language was Spanish at about 83% of those calls. Burmese was 2.18%, number 2. Pashto at 2.01%, and Arabic at 1.8%. Okay, the next slide talks about how we provide language services at member care visits. And one of the things that the slide goes into that I wanted to emphasize is that we can provide interpretation services by phone 24/7, 24 hours a day, 7 days a week with no advance notice. We can get a language line interpreter on with that individual there in the hospital or in the doctor's office. Now, we do need advance notice to be in person with the member in that situation. The emergency room translation can happen by phone. For sign language services, we do ask for advance notice, obviously to be in person for that, but we can provide immediate help for those folks that need sign language by utilizing the TTY line. The last two slides, just something that we were very excited to participate in with the Ronald McDonald House in Kansas City, which sees a lot of KanCare members that if they have a kiddo that's in the hospital at Children's Mercy, they go in to get services from. We provided them with a $25,000 gift to help them with renovations for the family rooms at the Ronald McDonald House, and we cooked 100 breakfast burritos. And thankfully, I wasn't the one cooking, I was wrapping. And I think everybody appreciated that, especially if you've ever had my cooking, which is not very good. Final slide talks about some of the community events that we've got coming up here in the state. We're going to be in Great Bend tomorrow with a walk. Hopefully the weather will be decent enough. We also have a couple of value-added benefit presentations that we've got coming up with different folks. We've got some families seeking early childhood education events coming up, as well as a community awareness event in Wichita at the Lord's Diner. We sit there at a table and see sometimes 200 to 300 folks come up and ask us questions about not only Aetna Better Health of Kansas benefits, but also KanCare benefits also. So that is my presentation today. I'd be happy to take any questions or wait for the other two MCOs to present and can take questions after that.
We'll take them one at a time. Committee, do you have any questions? Yes, Representative Reese.
Thank you so much for all of the language services. I know I've been asking a lot about this.
Sure.
Can you tell me again about the access to interpreters, emergency rooms?
Sure.
At night, 2 in the morning?
Yes, yes. So more than likely, that's going to be by phone because we do have our member services staff that is available 24 hours a day, 7 days a week. We always have a live person to be able to answer the phone, so we can get them set up with language line services right away as soon as needed. So we can provide that.
Ask another question. And what experience have you had with people who are experiencing psychiatric crisis and they're speaking a different language and using the virtual, sometimes, being able to use an iPad, which is great.
Sure.
But it scares people who are pretty psychotic.
I apologize, Representative. I don't know that I know of any examples of that, and I think I'd be talking out of turn if I tried to make anything up, but it's something I can look into and get back with you. I appreciate the question, though.
Yeah, because the stories that I'm hearing, the really horrific stories are those that are at night or, early in the morning, and there's trauma that is happening, and there are children interpreting for their parents.
Let me get back to you on that. I really appreciate the question.
Thank you.
Thank you.
Thank you, Madam Chair.
Seeing no other questions, thank you so much.
Thank you.
Committee next will welcome Michael Stevens, President and CEO of Sunflower Health Plan.
Good afternoon. Thank you, Madam Chair and members of the committee. I have slides available for you as well. We've tried to give you a combination of some data so that you'll actually be able to see the frequency and the cost of some of these, along with some of the individual member stories. And as I listen to the nature of your questions today, I know that that's what motivates you to serve. And so at least as one of your contractors, we can share with you the positive difference that your work makes in the lives of those that are served by KanCare. I wanted to start with a quick member mission moment, and this is one that I would share for you that I wanted to include in particular to address the issue that we talked about at our last meeting about health equity differences in infant mortality and challenges with our members of color not being able to or not following up with prenatal care and postpartum services. It's a program that we have that is called Start Smart for Your Baby that includes really personalized care management, texting, calling, personal visits focused on helping that member to engage with prenatal care because we know that that will have a significant impact on low birth weight, along with reducing NICU infant days in the NICU in the hospital. And so we've seen great success with this, and it's something that we have put in place as a strategy for health equity. Next, I'd like to share a little bit with you about some of our value-added benefits. And on the second slide there is a graph that really shows how the money is being spent. The large red slice around there is our value-added benefit that is My Health Pays. This is a vehicle by which we load money on a prepaid debit card for members in recognition of engagement in healthy activities. So if they get a screening, if they take a child to a well child visit, if they are consistent in their diabetic monitoring, we reward them, and the money can be used for a number of things, including utilities or rent or daily expenses. By far, the biggest expense choice is the ability to spend it at Walmart for all kinds of daily needs. And so that has been, we think, a significant strategy to begin to bend the curve on high-risk behaviors and helping encourage people to take responsibility for their own health. You can see a number of others that we have, including the Start Smart for Your Baby. Moving on, Start Smart for Your Baby is a multidisciplinary, multi-contact way. We know that just passively mailing information, sending information is not going to help with changing behavior or education. And so we try to interact as often as we can from as many different directions to help make sure that we're doing everything we can for healthy babies. Next, we saw through the pandemic that one of the key strategies towards serving members is the engagement of family, friends, and other natural supports. But through the pandemic, we saw increasing burnout, not just of paid healthcare staff members, but of those family members that were caring for our members. And so we've created a value-added benefit focused specifically on helping those caregivers, whether it's a family or friend or others, to be able to pay attention to their own health and well-being so that they can put their attention to caring for the member. And so we've put together a series of services through value-added benefits to help support the caregiver so that they don't burn out. We heard from one of the earlier conferees this morning about the challenges of retaining his own caregivers because of that kind of burnout. We see that as a very real challenge and want to do our part to help support those caregivers as well. My Health Pays is the next one. I've talked about that a little bit. In the interest of time, I'll skip over that. The next page shows some of the behaviors through which a member can earn dollars on the My Health Pays card. Another mission moment for you on the next slide. Again, in the interest of time, I'll pass over that. And then we included some more information similar to our friends at Aetna about accessing interpreter services. Again, for us, these are available 24 hours a day. They're available both directly to the member as well as to any of our providers, including having a three-way call if that's necessary, because as Representative Ruiz pointed out, we don't want to be in a position where we're relying on family members, children, or friends to be the interpreter. And so we provide 24/7 access to those interpretive services as well. And I will pause there, given the shortness of time, and be happy to answer any questions.
If you don't mind finishing your presentation, or are you just going to let us look at the rest of the
I'm just
of the
going
40
to
pages?
stop there. I've hit the highlights. Thank you.
All right, excellent. Any questions then for Representative from Sunflower, Michael Stevens? Representative Ruiz.
Just want, again, thank you for the information regarding the interpreter services, and you've already heard what
Yes.
happens in the ER. Yeah, that continues to be an issue, but thank you so much.
Thank you.
Senator Fagg.
Thank you, Madam Chair, and thank you for your presentation. Could you talk a minute on farmers market?
Yes.
How that works? That kind of caught my eye.
We work with farmers markets all across the state to provide vouchers to our members that they can use to purchase healthy food at the farmers market. And so we will set up an informational table, our staff attends, and we hand out vouchers that our members can use to purchase food.
Committee, other questions? Representative Ballard.
I'll just have a comment about that. From so many of them, they don't have free vegetables. I mean, they don't have the access to that. And there was a time where we weren't able, it wasn't eligible for that to happen for them. And so at least I remember when it was introduced, it was very helpful because they could only, they pick and choose what may happen if they went to Dillon's or, AV or whoever was available. So it gave a good, an option for them. And for that, I think it's really good. So thank you.
Thank you.
Thank you
All
very
right,
much.
thank you very much.
And committee, our final presenter, sorry about that, Celia. Celia Ruiz, I'm sure she's not a sister of our representative.
I don't think so, not that I'm aware of.
All right.
I have some missing links, so you never know.
Okay, well, for Social Determinants of Health Project Coordinator and Bilingual Mental Health First Aid Instructor, UHC. Thank you.
Yes. Madam Chair and committee, thank you very much for your patience. I'm the last one today, so thank you. Yes, my name is Celia, and if you can say Celia Ruiz. I am the Bilingual Mental Health First Aid Instructor here at United Healthcare. And so then I want to talk to you today about mental health first aid. But before talking about mental health first aid, I want to put this in perspective. So when we think of medical first aid, and I will share with you the exact example I share with folks in community. If I were to have a paper cut, as I sit here and I shuffle through these, would you notice it as I kind of look awkward in my face? Or maybe I'm trying to press down on my finger, try not to be nervous? If you were to notice that, how would you respond? Would anyone that most here are all strangers to me, would they offer me a Band-Aid? Would they walk over to me? Would they say a paper towel, etc.? When we're speaking of our medical first aid, we have at least 4 or 5 options we can refer to. But when we're speaking of our mental health first aid, the equivalent, if I were sitting out in that hallway crying after this because I was so nervous, how would someone respond to me? Again, being amongst strangers. What I love, love, love about this course about mental health first aid is that it provides folks with a tangible toolbox of resources on how to respond to these mental health crisis, moments, challenge, illnesses. As you are aware, we are in a mental health crisis across the nation, and Kansas is no exception. In the 2023 report, The State of Mental Health in America, by Mental Health America, Kansas ranked as one of the top 3 states with higher prevalence of mental illness and lower rates of access to care. We can go to the next, yeah, I think we can stay on that slide there. But Mental Health First Aid is an evidence-based curriculum that teaches adults and teens how to identify and respond to mental health moments. This curriculum was developed by National Council for Well-Being, and I will add that we are not the owners of this course, and we are not the only instructors in the state. However, with this nationally recognized curriculum, we're able to share this 5-step action plan, and I'll share it with you all very quickly. I've been teaching since 2019, I know this. Algae, A, assess and approach. How are we assessing, how are we identifying, and how do we approach a person? L, listen non-judgmentally. And we practice what does it look like to listen and what does it look like to be non-judgmental. Give reassurance and information means don't give advice. But what is the hope? With facts that we can share with others. Encourage appropriate professional help is an opportunity for us to share with participants the range of professionals that folks can reach out to. And then it also introduces career exploration, which I think is pretty cool. And then E, encourage self-help strategies. And so then what are those strategies that are enjoyable and safe to that person until they're able to receive that professional help? You previously would have seen a photo, because I think we're kind of going through these photos here, but you previously would have seen a photo up on the screens or within your slides. It's actually slide 4. This is a class hosted by Revolución Educativa. It's an organization that supports parents and educators in the Kansas City area. I will say that most participants in mental health first aid courses are workplace professionals, many times because they are being paid to be there in the classroom for 8 hours. But we've had unique success in having parents, caregivers, and in my words, awesome everyday people in these classes. By providing this course in person, in community, in English and Spanish, and for the most part on weekends, we tailor the delivery of this course to the needs of the community. According to NAMI, the National Alliance on Mental Illness, more than half of Hispanic young adults ages 18 to 25 with serious mental illness may not receive treatment, and this inequality puts the community at higher risk for more severe and persistent forms of mental health conditions. As the only Spanish language mental health first aid instructor in Kansas, I have been privileged to hear firsthand not only the cultural, generational, linguistic, and systemic barriers within the Spanish-speaking community, but time after time, the response to this course has been, thank you, we've never had a class like this before, we need more. So our response to this ask was easy. We teach more classes. We've taught community health workers, statewide, parents, caregivers. We've partnered with FQHCs, school districts, associations across the state. And by equipping adults and teens, individuals are empowered to support each other with a greater awareness for mental health as well as resources to take action. To successfully hold these classes, multiple resources and strategies are brought together. From strong community and partner relationships to creative outreach, the purchasing of materials and meals during these 8-hour in-person presentations, all of those things need to come together. But then I must also add that I feel extremely privileged and honored that United Healthcare will let me spend my days and my weekends talking about mental health all day long in community, in English and in Spanish. But then also, as a member of our social determinants of health team, it's been so easy to integrate the health data, health outcomes that we see statewide into this mental health space in the front, right in front of the faces of our community. You'll see data on slide 7 that shows how many participants we've had. I think the number says 403 participants. Since January, I've already had a class. So over 430 participants, over 35 classes we've taught since 2019. And it's likely that we'll surpass last year's number. So I think we put 13 classes are scheduled up to this year, but within this past week, it's been like 15 or 16 that are scheduled. So those will continue to happen this year. On slide 8, you'll see some highlights. Again, me being the only Spanish language instructor, and I will say, we don't want it to be that way. Like, we encourage, and I'm actively recruiting folks to like be in this space as well. So that's one highlight. Last year, we were also able to co-sponsor the largest mental health first aid training in the state of Kansas in partnership with Association of Community Mental Health Centers of Kansas, Johnson County Mental Health Center, Blue Valley School District, purchasing materials for their coaches and mentors. The success of our Spanish language classes have also caught the eye of partners and organizations outside of the state. Chicago and Illinois, I've had conversations with them. That conversation's still pending. And it's technical assistance. Arkansas, Washington, are some of those that I can think of right now. But everything's listed there on your slides. And lastly, and I've run through all this pretty quickly because I really want you to focus on the most important voices. And so on the last two slides, on slide 9, I'd like for you to listen directly from one of our participants. And you see the native language Spanish being written first. But in that bold text, I will read to you what a Spanish-speaking mother in Kansas City, Kansas, wrote down in her post-survey. My daughter attempted suicide, and there was no one to help. I want to keep helping my daughter during her healing, and I want to help others. A Spanish-speaking business owner in Kansas City, Kansas, just a few weeks ago. I was in a class when I received that call that my partner died. I used the action steps in that very moment. On slide 10, there was a participant that sent an email to all of the classmates after the class, and they said, "I'm glad I woke up early on a Saturday for this. I felt like there was a room full of wonderful people and resources and material, along with each other. I'm sure you will all do great in the field and reach out if you need anything. I'm sure I will need someone to lean on once I hit a bump." And then lastly, a parent back in 2021. As a mother, this was helpful. I wish this course was around when I was little. So, that's
Muy
it.
bien, Celia.
Gracias. Thank you.
Committee, hay preguntas. Are there questions?
Yeah.
Representative Ruiz.
You know, I had to ask a question.
Please.
On slide 7, there are a lot of organizations that are listed. Are they helping to fund?
They bring
Because the classes are very expensive. I used to be an instructor.
Yeah,
They're very
bring the people.
expensive.
They bring the people. We provide the materials, we provide the meals, we provide the instructor time, classroom materials. They help promote and recruit folks into the class.
And are you a trainer too? Or?
So I'm not a trainer, but I'm an instructor and I recruit folks to come into this space.
Thank you very much. Thank you for your work.
Yeah, thank you.
Committee, other questions? Representative Ballard.
I would say thank you so much. I appreciate it a lot. You know, we talk about if we really want to help people, we have to be diverse. And we have to offer as many services as possible so that people can feel, you know, that there's someone listening to what I say, but give them that opportunity to do it. And when she says, I wish it was when I was younger, because there was a time, you know, when she was younger, it was not available. But I think in many ways, we look at different areas and we see now that there's all kinds of things that's really available to let people know that the legislature would like to find out what's going on and try to respond and make things available. And I think what you're doing is something unusual. And I can see why, you know, you need a little help to help you out a little bit, but you're doing a fine job. So thank you.
Thank you.
We would like to thank all of the presenters today, and committee, we are adjourned.